Hello, can you hear me?
check, 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 check.
So good morning, everybody. So welcome to South Neocon Non-Invasive Ventilation Workshop. So I think some delegates are still with the breakfast. I think as they join, we'll start off today's session without wasting much of time. I think this is the era of gentle ventilation, what we call. And people as postgraduates, when they were interns, they'll be thinking, I'll have to learn intubation. After intubation, they'll be wanting to learn how to manage with a ventilator. But fortunately, in the last decade, because of a lot of research from the Western countries as well as Indian countries, so we have been very comfortable with non-invasive ventilation. So I can quote figures for the last 3 years from our own hospital. So we ventilate at least 70% of our admissions. Ours is a predominant outbound unit. We get almost sick babies for respiratory distress. So 70% of babies will require ventilation when they come to the hospital. Of these 70%, 60%, I can say confidently that we are managing with non-invasive ventilation. So just 10% of our babies are requiring intubation. So if you learn NIV, I think you can manage. That means maximum number of babies comfortably. So for NIV, I think it's not a rocket science. So the physiology is quite simpler. The settings are quite simpler. It's just the monitoring and just the system what you develop in your own unit to manage NIV. So today we are going to learn about CPAP. We are going to learn about HFNC. We are going to learn about NIV and newer advances. Like we have already nasal HFO, which is coming up in a big way in some of the countries. And we are also going to learn about NAVA as well today. So we have theory sessions. So feel free to ask questions. At the end, we have the workstations. So where we'll demonstrate the equipments as well as the interfaces for you. So before we actually start the session, I would like Dr. Adar sir to introduce the delegates as well as the faculty. Thank you, sir.
Thanks, Abhishek. Good morning, all. So I'll talk very briefly and welcome all to the South Neocon conference. Actually, I want to ask a couple of people who are here. I know that some of them have joined online and some of them are offline here. What are their expectations before the conference, who they are and what they have come for? So by the end of the day, let us again see whether we have met their expectations and aspirations. Okay, sir.
Good morning, everyone. Myself, I'm Dr. Mahesh Patil. I have come from Jamkhandi. Basically, I do run my own hospital. We have a 8-bedded NICU, 8-bedded PICU, and general wards as well. But the thing is that we are not aware of this NIV, and we do intubate and do ventilation also. But since we come from a very small place where nursing care is not up to the mark as compared to the bigger hospitals, so this concept would really help for us as well as for the patients who come to our hospital. So we want to upgrade our NICU to this concept. So I have come with the main motto of learning this NIV. Thank you.
Thanks, Mahesh. So, I mean, all our post-graduation life, our main focus was to learn intubation. And now we are learning, we don't need intubation, or most of the times we can manage babies without intubating. What about you, sir?
I'm Dr. Vasant Mudigoda from Jamkhandi. I'm working in government setup. So our hospital is going to start a 100-bedded MCH hospital that is attached with the SNCU. what we call an NICU in outside. This is special newborn care unit. We call in government SNCU. So that SNCUs are what they in the guidelines they have what they have prescribed is that is without ventilation. SNCU without ventilator facility. So that means other non-invasive ventilation. So these things we should know. So that's why I want to learn this non-invasive ventilation facilities and what are the things. So I expect this from this session. Okay.
Thank you, sir. What about you, sir?
Myself, Dr. Hire Gowder. I am coming from Bijapur. Nearby Bijapur, one place is there, Sindagi, where I reside. I have my own hospital. We run 8-bedded NICU, 8-bedded PICU. Motto is to upgrade ourselves to the NIV concept and try to apply that on our patients so that they will be benefited.
Thank you, sir.
Hello, good morning. Myself, I'm Dr. Dakshayani, pediatrician from MCH Hospital, Chintamani. Ours is a 50-bedded MCH hospital. We don't have any NICU as of now. So I just thought I'll learn through this NIV, like CPAP and other things. Thank you.
Thank you. Yeah. Please have a word.
I'm Dr. Sahit, I'm an intern, and I just came to see how it works and then learn something at least before I graduate out. And
Thank you. Hope you will join pediatrics after this conference. Hope we will impress it upon you. So thank you all. Now I will leave the stage to the first speaker.
So once we have known your expectations, I think it's pretty much easier now. Like most of you are looking at NIV. So we'll also fine tune your CPAP skills as well. So today for the first talk, we have Dr. Binu Govind. So I think he's from Kerala. So Dr. Binu Govind, actually, he's currently the consultant at Lifeline Hospital, Adur. So he's a DM graduate from CMC Vellore in 2014. So he has 6 indexed publications. So his special interest is in parental nutrition. But if you see his CPAP slides for the day today, you will find he has special interest in NIV as well. So we'll start his talk for the day. So you can start his talk. I think he's joining us virtually. He sent us recorded video.
Good morning,
start with
everybody. This pandemic time, I'm sorry that I couldn't attend in person. So I thought I will send you this talk over web. I will be talking about science and physiology of CPAP or continuous positive airway pressure. Now, you know this, as you all know, the CPAP is the most common modality of care in NICU setups, for that matter, in any NICU. So the gadget with you, the gadget for the treatment in NICU for respiratory distress is CPAP. I'll be talking about the basics of CPAP in this session. And of course, you will have workshops and and evidence-based talks and all later on. Now, what is CPAP, or what do you mean by continuous positive airway pressure? Continuous positive airway pressure provides a constant programmed level of distending airway pressure throughout the entire respiratory cycle. Physiologically, it is the equivalent of positive and expiratory pressure. Now, what is this is that it provides a continuous or more programmed pressure throughout the respiratory cycle, so it prevents collapse of alveoli. Now, how does it prevent collapse of alveoli? We will come to it. Positive and expiratory pressure is the pressure in the alveoli above the atmospheric pressure at the end of expiration. Now, as you all know, if there is no pressure in the alveoli above the atmospheric pressure, it will collapse because the airway pressure, atmospheric pressure will be more than the alveolar pressure. Now, CPAP is a way of delivering the PEEP, but also maintains a set pressure throughout the respiratory cycle during both inspiration and expiration. So basically, it's a minimum guarantee. There is a minimum guarantee of flow of air, which will help to maintain the pressure and thus prevent the collapse of the alveoli. The application of CPAP maintains PEEP can decrease atelectasis, increase the surface area of the alveolar, improves ventilatory perfusion mismatch, and hence improves oxygenation. So basically, the continuous application of the pressure will keep the alveolar patent and increase the surface area so that there is well perfused mismatch. Happen either way. If there is poor ventilation, there will be then there will be desaturation because it will be like oxygenated blood. And the other way around, there will be a lot of ventilation if the alveoli is not collapsed, and if there is no blood flow, so there will be desaturation. So keeping the alveolar patent, it improves the vacuum mismatch and oxygenation. Now, during bubble CPAP, the expiratory limb of the CPAP circuit vents through an underwater state.
lesser. So CPAP thereby will actually obviate the need for surfactant as well in 50% cases. I think we'll see in the subsequent sessions for the day. So apart from this, CPAP actually reduces the work of breathing by dilating the airways. It reduces the resistance to airflow. So let's say if there is meconium aspiration, and if the meconium is sitting in the larger airway, there can be ball valve effect. That is, air can go in, cannot come out. So it causes emphysematous changes and air leak. CPAP actually causes dilatation of the airway and the meconium is dislodged. So apart from this, CPAP will also improve pulmonary vasculature, or pulmonary vascular resistance is reduced. We have seen in a collapsed airway, there is VQ mismatch. In a hyperinflated airway, so the vessels are compressed. So in optimally inflated alveoli, you have very good gas exchange. So your pulmonary vascular resistance is to the minimum. And apart from this, we have also seen J receptor stimulation. So by J receptor stimulation, it also helps in apnea as well. So overall, CPAP improves functional residual capacity, stimulates J receptors, reduces work of breathing, splints the airways, and even in meconium also, it helps us. So once we have understood the science and physiology, let's move on. So this theoretical knowledge, is it helping on ground or not? So to present this evidence, we have Dr. Srinivas Murthy. So he's in charge or HOD at JSS Medical College, Mysore. So can we have his slides? Yeah. So today he's going to speak about evidence of CPAP. So till now, what is the evidence in the Western literature or even in the Indian literature? Second slide, maybe. Second one.
Dr. Abhishek, can I share my screen or is it going to
You're from there. Allow sir to share the screen. I think Srinivas Murthy sir, you must be aware that he's the one who has a lot of innovations from Karnataka. He has at least 3 devices which he has applied. He has got patent, and other 2 devices he has applied as well. So actually he has done his fellowship from McMaster's University, Canada. He is the in charge or HOD at JSS Medical College, Mysore. So today he'll discuss about evidence of CPAP. Sir, you can share your screen, sir.
Okay.
We are able to see your screen, sir.
Okay, good morning, everyone. Can you hear me?
Yes, sir.
Okay, thank you so much. I'm extremely indebted for all the organizers for giving this opportunity, because this is one thing which always I like, because there will be a lot of discussions and learning from, it will be a two-way process in such encounters. So I'm very happy to be here with you. And don't worry about the title, they all mean the same. I think the one which is printed in the brochure is different, and one which is displayed on the menu is different, and what I am showing is different, but all of them mean the same. The whole idea of this presentation is to make sure that we discuss about why and when to start CPAP, and further to it there will be subsequent presentations about how and how to work with CPAP and how to monitor, etc. So the objective of this presentation is to understand why you should start CPAP and how to actually escalate or de-escalate the support that we are giving. So that being the objective, we need to understand that whenever a clinician embarks on putting the baby on CPAP for respiratory illness, I think the previous speaker told about the restrictive lung and the need for opening up the alveoli, otherwise it's going to be a mess for the baby and he's going to get exhausted. So our primary aim is to keep the alveoli partially open even during expiration, so that the work of breathing the baby is imparting for breathing will be efficiently used. So whenever we have these diseased babies like RDS, there are 2 things that we have to understand when we are putting on CPAP. One is, what is the severity of the disease? So we should be able to clinically or with the help of laboratory assess the severity of the disease. And the second part of it is, once we know the severity of the disease, we will be able to initiate an appropriate treatment, because we should not overtreat a lesser severe disease and we should not undertreat a more severe disease. I just wanted to pass here for a moment because earlier speakers and the coordinators were sort of very passionately telling about the non-invasive ventilation taking sort of, I would say, celebrity status in neonatal ventilation. I do agree with that. And I know that it is so important for us to prevent the lung injury by not intubating. But having said that, the skill of intubation is very important. So don't think that it is gone, it is still there. We need to learn the art of intubation and art of very gentle intubation as well, and ventilating the child even invasively when needed. Once when we are comfortable with that, then we can be very discriminate about not using it. That's where the non-invasive ventilation come into the fore. So let us move on to the next slide. So before that, we need to understand that we need to assess the severity of the disease, following which we should plan for the appropriate support that we have to offer. So for that, let us know how to assess the severity of the disease. We all know the babies come with respiratory distress, which is tachypnea, chest retraction, grunt, and use of accessory muscles, etc. Some of the books also mention, some of the clinicians also believe the babies can wheeze. Apart from that, there are many other things which should be classified or probably should be weighed equally as a respiratory distress. For example, irregular breathing. If the baby is exhausted, we may not actually see tachypnea, chest retraction. Probably it is more of irregular breathing, and if it is very severe, even the baby may stop breathing, which is apnea. So these are the things that we need to keep in mind, that the babies are having respiratory illness. Apart from that, increasing oxygen requirement or even cyanosis on examination, drop in saturation, etc., all should be considered as clinical features of respiratory illness, and which should be used for managing or sort of assessing the severity of the illness. So let us know what is tachypnea. Whenever the babies are breathing at a rate more than 60 per minute, then it is called as tachypnea. That is commonly seen in restrictive lung pathology, which means to say, let me be very simple. When we say restrictive pathology as a pathology term, in plain English, it is small, stiff, and sticky lungs. The lung tend to be very small. The alveoli tend to stick to each other, and it is so stiff that it is very difficult to open up, right? So that is how better you imagine a restrictive lung. Whenever that is there is a compensatory mechanism of increasing the breath rate so that the gas exchange will be reasonably maintained. Once the breath rate increases, the minute ventilation increases, which will help in removal of carbon dioxide. But the effectiveness of this tachypnea in improving the oxygenation is very marginal. So whenever there is tachypnea as a compensatory mechanism, we need to understand that carbon dioxide elimination can be more efficient when compared to improving the oxygenation. Here we need to understand there is another similar looking condition called as hyperapnea, where the amplitude is high, or there is deep breathing with very marginal increase in the rate. So these are generally seen in normal lungs whenever the breathing is affected by the metabolic derangements or CNS infections or bleeding, etc. So we need to tend to make the difference between tachypnea and hyperapnea. Tachypnea is low amplitude, high frequency breaths, whereas hyperapnea is generally high amplitude with very marginal increase in the breath rate. The next one is the chest retraction. We all know and we have seen how chest retraction looks like in the baby. It can be partial of, it can be only part of the chest or whole chest, upper part, lower part. It is very, very inconsistent. All that we need to know is whenever there is chest retraction, which means to say the effect of or the work of breathing is wasted. Whenever the baby tends to suck the gas into the lungs, instead of sucking the gas, it's sucking the chest wall inside because it is so soft and supple. So that means to say the work of breathing is terribly wasted when there is chest retraction. So I think the difference between upper chest, lower chest retraction probably fades because it is not very consistent. The grunt is one of the very useful, I would say, compensatory mechanism where the glottis tend to partially close at the end of expiration, so that it generates an internal peak, or the pressure at the end of expiration is still on the higher side, so that it will avoid collapse of the lungs. So exactly that's what we are trying to do with our CPAP. So there is an internal CPAP mechanism, which is the grunt. So if the baby is grunting, it is pretty much clear that we are dealing with a restrictive lung or a small stiff sticky lungs, which immediately says that we need to give some pressure to open up. I will tell you why it is important for us. Here again, there is a word of caution. You should not confuse this one with moaning. Babies, when they are miserable due to sepsis or pain or whatever, they tend to moan and they tend to make some sort of very, I would say, high-pitched, winning sort of noise. That is moaning. It should be completely. I think the clinician, should be able to make out the difference between moaning and grunting. Moaning indicates that baby is ill, whereas grunt indicates that baby has restrictive lung disease. So depending on this chest retraction and other clinical features, in 1956, these great clinicians developed a scoring system. This is called a Silverman-Anderson scoring, even it is used till date. Though it was based on their experience, I think that was so good that it has stood the stand of the time. So according to this scoring system, you can see in the slide, you can see on the picture as well, depending on where the chest retraction is there and how it is there, you can score. If this information is available everywhere, so I don't want to really elaborate on this. A score of 0 to 3 means there is no or mild respiratory distress. That's a good thing. If the score is between 4 to 6, it says that moderate respiratory illness is there. We need to act immediately. And if the score is more than 6, it says that it's impending failure. That means to say you are dealing with very, very sick child. So important thing that you need to notice here is it's all based on the clinician's observation. There is no other sort of laboratory thing or any other information sought in this Silverman scoring. I'll just place a few videos about how it will be helpful for us to know. You can see it is predominantly lower chest retraction here. You can also hear the grunting sound. Okay. This is a bit more severe. Even the middle part of the chest and lower part of the chest is quite sort of involved. Yeah. Yeah. You can see the retraction is predominantly on the lower part of the chest, and if it is severe, it can involve the whole chest. So when to act, if the Silverman scoring is more than 4, or if the baby is having irregular breathing, apnea, cyanosis, or if the saturation is less than 93% in the room air, that is the time to act. Please note these things. If the Silverman score is more than 4, if there is irregular breathing, if there is apnea, if there is cyanosis, if the saturation is less than 93 in room air, that is the time to act. How to act, we will discuss about it later. So what are the advantages of Silverman scoring? It is very easy because it is clinical assessment alone. We don't need any gadgets, and it has been pretty much well used for a few decades now, both in practice as well as research. The negative things about it is it relies only on the subjective assessment of an individual, which is not always consistent. Then came the down score, which sort of improvised on the Silverman score. They considered use of oxygenation as one of the indicator. So apart from the respiratory rate, they also included cyanosis, and they also included the auscultatory finding of air entry. Grunt was there, retraction was there. But if the cyanosis is present even after using oxygen, in the original down score it was 40%, but now in the modified one they have removed that 40%. If the baby needs oxygen, then you have to score it as 2. So this was a little bit of improvement because they tend to offer some treatment and see how it responds. So that was also included in the assessment of severity of the illness. Again, coming to the interpretation of the Downey score, if it is less than 4, we are happy. If it is between 4 to 6, similar to Silverman score, it says that there is clinical distress, we need to act. And here, if it is more than 7, it says that impending respiratory failure. Unlike in Silverman scoring, where it was more than 6. But obviously, it is a little bit more refined. So when to act here, if the down score is again more than 4, irregular breathing, gas, apnea, cyanosis, etc., we have to act. Very similar to Silverman scoring. So if the score is more than 4 or any other signs of respiratory distress which is not included in this, we have to act. So what are the advantages? Again, it is basically a clinical assessment, not needing much of gadgets. And is used extensively in practice and research. And also it takes into account the effect of treatment, because that is very important, because sometimes the disease can be mild with the minimal treatment, it can improve. And if you don't take that one into account, that might be a little bit of superfluous. So Down score did attempt to take the treatment effect as one of the assessment criteria. Again, the cons are very similar. Subjective is very subjective. And now we know all of us use pressures and not oxygen for treating the restrictive lung. So that is not taken into account in Down score. And they depend on cyanosis. But nowadays, I think the world has moved on. We are more reliant on SpO2 measurements. And air entry, obviously, it's very difficult to assess in newborn, particularly when they are in distress. These are the cons. Knowing that, you can still use it. So if you are confused, should I use Silverman score or Down score as soon as the patient arrives? Because to start on CPAP and use PEEP, it takes a while. So we need to assess the severity at admission. So which one is the better one? It is very difficult to say, but I think there was one of the very good study done from our St. John's Institute in Bangalore. It was a beautifully crafted study where they showed that Down score seemed to be better because there was a bit more of uniformity and ease of using it, both between interns and nurses who generally encounter these babies when compared to Silverman score. So for now, I think with this evidence, probably Down score is the one should choose to initially assess. I'm underlying this word initially. That is, when the patient comes to your hospital, then you have not started any treatment. You just give some oxygen and have put the saturation monitors on. Then it should be Down score that has to be used to assess the severity. So now let us understand why we need to use CPAP. I think the previous speaker did elaborate on this, and my job has become simple after that. He has told what is the physiology, how does CPAP works, and how does it make actually the baby better by reducing the work of breathing or making the work of breathing more efficient, right? So again, I want to impress at this point of time, whenever you are putting this baby on CPAP, it is the baby who is breathing. It is not the machine. So what we are trying to do here is use the baby's work of breathing and make it more efficient, and hence he will not get exhausted. So whatever the energy baby has is more efficiently used by using CPAP. Earlier, when I was also postgraduate, and probably in many places even now, we were sort of told to use oxygen, head box oxygen or nasal pharynx oxygen, etc. But that is not a great idea, because it is very clearly shown in the literature that giving oxygen is not going to help the baby very much when compared to CPAP. So if you can see the evidences that I have quoted, these are few, there are many of such kind. So even in TTN, which is a restrictive lung, CPAP reduced duration by nearly 1 day. And in RDS, why I'm telling this is because sometimes TTN just tend to improve by itself. And with CPAP, it tend to improve by 1 day, means within few hours. TTN generally resolves by 24 hours. So within few hours of CPAP, TTN actually resolved. So that is the importance of CPAP. If you use an RDS, you can even reduce the depth and need of mechanical ventilation in 36%. So that is a huge thing. And if you see the confidence interval, it's up to 50%. If you are reducing the risk of death, then I don't think that we should ask another question, should we use CPAP or not? We should use CPAP. And if you just consider mechanical ventilator alone, then it reduces by 28%, nearly 30%, or 1/3 of the children would have otherwise gone for mechanical ventilation, don't need mechanical ventilation if you start on CPAP. These are very few literature I have just quoted here. The reason is I didn't want to crowd the slide. Otherwise, there are ample evidence to say The CPAP is the way to treat a restrictive lung and not oxygen. Why not oxygen? Just see this study, which was, it is a review that was done in 1990, way long ago. And it has clearly shown in this review, they have shown all the studies done till date that it increases the incidence of BPD, necrotizing enterocolitis, ROP, and PDA. And in this, the authors actually claimed that we should use this term called as oxygen radical disease in neonatology for all these things. So that was the adverse effect or the unwanted effect of oxygen therapy. And has it changed now in last 30 years? No, it has been pretty much same. The oxygen does the same, cause the same problems even today. So whenever you see a neonatal unit where the neonatologists are really struggling to save small little tiny babies, they will be very, very fretful of oxygen. They will say, oh, turn off the FiO2, come down on the saturation to 94 or 90 or something like that. That is because now it is well recognized that oxygen, though it's a drug, when it is given even in the little higher dose, can cause more problems, and the therapeutic index for oxygen is not that high as we earlier thought. So that is why we should now, at the end of this talk, conclude that in any baby, newborn baby who is having restrictive lung disease, it is not the oxygen, it is the pressure which has to be the first line of treatment. Yes, of course, before you set up the CPAP and all those things, you have to offer some sort of support for a baby who is brought with retractions. So then you can use a little bit of oxygen before you actually start on treatment. But that is not the treatment that has to be continued. That's my sort of view. So now when it comes, we understood how to assess the severity of the illness when the babies just arrived, when the treatment was not given, or when the treatment was as minimal as giving prongs or head box oxygen. Now, when we have already assessed the severity of the disease and they put the baby on CPAP, we understood why we have to put the baby on CPAP. And once we have put the baby on CPAP, there are two things that will be happening. CPAP per se will make the disease better, or they make the breathing better. And also the pathology itself is changing, it is dynamic. Sometimes it improves, sometimes it worsens. So the interplay of these two has to be assessed. Till date, unfortunately, we did not have one good measure to assess the interplay of the treatment as well as the dynamicity of the disease. But now it has changed, which I'm going to discuss in future slides. So if the clinician just depend on the requirement of oxygen, that is not helpful, because it can increase the pressure, which can have a better effect on the disease outcome when compared to requirement of the oxygen alone. So FiO2 cannot be used as an assessment parameter after putting the baby on CPAP. If you want to take the pressure alone as the assessment parameter, that is also very difficult, because you cannot increase the pressure beyond certain limit, and people tend to use a lot of oxygen whenever there is desaturations. So unless we combine both of them individually, they are not good monitoring parameters. And what happens if you give either oxygen or pressure or combination of both? Then there will be change in SpO2, because both the parameters or both the treatment modalities that we have given will eventually reflect as SpO2, and hence we need to monitor the SpO2 as the outcome. So now we were doing blood gases for many babies, which we have to stop, because babies on CPAP doesn't need blood gas very often. It should be only reserved when the babies are becoming sick. So how do we know babies are becoming sick and when to embark on arterial blood gas? We will discuss. This is a small quiz for all the people who are involved. These are the shapes of the chest that I have drawn. Can you make out which one is the smallest and which one is the biggest? It is not possible, because unless the geometry is very defined and symmetrical, like circle or rectangle, where we can use formulas, such abnormal weird shaped chest, it is very, very difficult to make out which one is the biggest or smallest. Why are we talking about smallest or biggest? Because in the restrictive lung, the lung volume comes down. It will be low volume lungs. And if you use CPAP to inadvertently you can even overexpand the lungs and it can be detrimental as well. So it is very important for us to assess the volume of the lungs. So now let us think of this chest wall. These are the pictures of the chest wall you can see. And when we know that we cannot apply any geometry formulas to assess the volume, what we can do is we can fill this container with water and pour this water back to the measuring jar, and we can measure the volume of the water. That will give us the volume of the container. I think that is very straightforward. Whenever we have weird shapes, all that we need to do is pour some water into that container, get the water back onto the measuring jar and measure the volume of the water, and that is the volume of the weird shaped container. So we are using this principle for assessing the severity of the illness, or in other words, the volume of the lung after giving CPAP. So why did we need all these things? Because we know the variation of the practices in NICU. Some people tend to change pressures very often. Some people tend to change oxygen very often. Some people make an alternative changes. There are so many preferences the clinicians will have. So how can we make it as a uniform assessment? So that is the reason why we have come up with a new index called as saturation oxygen pressure index, or SOPI. I'm very happy to say that till recently, that is last couple of months ago, this was a proposal and proof of concept. Now it is validated and published in the literature so that everyone can use it with a lot of confidence. So how did we develop this one? This is the journey from conceptualization to validation. So this index is used for babies who are on CPAP. So as I told you earlier, once you put on CPAP, things change because of CPAP as well as because of the disease. Now we have to assess the volume of the lungs or the severity of the disease. So that we have to use all the things available to us. It is the saturation that we can monitor, the FiO2 which we are giving, and pressure we are offering. And just using these things, we can make a uniform assessment throughout. So what is this SOP index? SOP index is a very simple index where you multiply the PEEP given by FiO2 and divide it by SpO2. We generally use in decimals. So SOP index is in decimals and does not have a unit. So it's as simple as that, PEEP on the ventilator or CPAP if you are using bubble CPAP or something. So that has to be multiplied by the FiO2 and divided by SpO2. Now you can see here we have involved both the pressures, we have involved the oxygen that we are giving, as well as we are titrating it against, or we are comparing it against the outcome of this intervention, which is the SpO2, which we can easily monitor. So in the initial study, which I did way before in 2013, I believe, it was a proof of concept study. So what did I do? Because we could not do it on the babies on CPAP, I took the advantage of the unit that I was working, where they were working too much on pressures rather than FiO2. So I took the babies on ventilator and I removed the PIP part of it and just used the PEEP. So that gave me an idea that this can be used, because there was a good correlation between SOPI and the oxygenation index, which we would calculate at that time. It was 94%. So after publishing this, we were more convinced that we can do a clinical study, and this was a proper clinical study done using 57 neonates. What happened here, we used babies who were on CPAP, we calculated the SOPI for them, and we titrated against the arterial oxygen gradient, or AADO2. Why did we do that? Because AADO2 is the one which will give a clear idea of VQ mismatch, which is more comprehensive than oxygenation index in assessing the severity of the illness. So we use that more comprehensive, more complete sort of objective evidence of severity of the disease and compared our SOP index with that. And it was very heartening to know that the correlation was 84.7%, which is quite high. Then we completed our validation study. For that, we had to know how much AADO2 is bad. So we know we can calculate AiDO2, but how are we going to classify that this much AiDO2 means it's a very bad lung, and if below this is good one? And this was sort of decided by an expert opinion after going through the literature that was published from PGI Chandigarh. That was a very interesting study where they calculated the factors that might have influenced the babies who failed extubation. So they took the babies who failed extubation, and then they took the babies who were successful in extubating, and they compared various parameters. In that, they noted that the AiDO2 of babies who failed extubation was 55 plus or minus 17 was the standard deviation. And hence, we thought that a cutoff of 70, that is 55 plus 70, would indicate that the disease could be quite severe, because nearly 63% or 2/3 of them would fail extubation anyway if they are already intubated. So this was a sort of a common sense agreement which we made, and we showed in that study a SOP of 1.6 had a sensitivity of 80% and specificity of 90% in determining the AiDO2 of 70. So that was quite heartening for us to know. The correlation was 84%, and a SOP of 1.6, please note this number, SOP of 1.6 did have a very good sensitivity and specificity to identify AiDO2 of 70, which we thought represented severe disease. So I think that's the same slide here. Yeah. So in the validation study that we undertook just last year and we published few months ago, again we found that the correlation between SOP and AiDO2 was 82.7%, which was similar to the previous study. And in here, we thought that, look, in our setup, in our country, there are units which are working at a very posh level where people can afford a lot of money, whereas there are units which are working in a government setup and the resource can be very limited. So if we just give one setup, one cutoff, that might be a bit difficult for them to decide when to intubate. So we took the mean plus 1, 2, and 3 standard deviations as cutoffs. And we have given these numbers which correlated with that. And the people who want to be aggressive in intubating and ventilating can choose a number of 1.52 or 1.5. And people who are really stretched can use a SOP of 1.6. Here in this study, a SOP of 1.52 in the validation study had a good sensitivity and specificity for AiDO2 of 70. The sensitivity was 80% and specificity was 92%. And a SOP of 1.57 had a sensitivity of 81% and specificity of 90% for AiDO2 of 85, which is 2 standard deviations. And a SOP of 1.6 definitely told that the AiDO2 will be around 100 or more than that, which had a sensitivity of 83% and specificity of 90%. So with this evidence, we were very much convinced that we should say that SOP of 1.6 is the high thing that we can accept, and then we should start thinking of changing the gears if the SOP increases beyond 1.6. So this was just published a couple of months ago in European Journal of Pediatric Medicine, European Journal of Pediatrics. So now, after all these things, we have now sort of trying to find out how to go about a child who is brought to our hospital with respiratory distress. This is a flow chart that we have just developed in our hospital, which might be helpful for others as well. And this is not something which everybody has to follow. You can have a similar flow chart with different cutoffs if you need for your own unit. So how do we do that? If on arrival, if the down score is more than 4, then we are going to start on CPAP. So after starting on CPAP, we are going to monitor the babies for every 15 minutes. And that we monitor for next 1 hour. And depending on the change of SOP in that 1 hour, we may alter the CPAP parameters. If the FiO2 is an issue, we go up a little bit more on if the saturation is the issue, we go up on FiO2. If the retractions are more, we go up on the pressures. So that is up to the clinicians to decide what to do. And then at the end of 1 hour, we'll take a look at it. And if the SOP improves to less than 1.6, then we will change the monitoring frequency from 15 minutes to 30 minutes, and it should be done for next 4 hours. And if the SOP is either same or increasing beyond 1.6, then we will continue monitoring the babies every 15 minutes with SOP for next 1 more hour. And again, if the baby's SOP improves, then it will come to this limb, otherwise it will stay there. And within next 4 hours, if the SOP exceeds 1.6, then I don't think that we should wait any further, because delayed treatment can be dangerous as well. In our unit, we intubate and give surfactant and remove the tube. That is ensure approach. Or some units might just follow intubate, surfactant, continue intubation, and then extubate. Or some units go for MISA or LISA, that is less invasive surfactant. Some units might even choose to go for NIPPV. Currently, our trial is on. So if the SOP is beyond 1.6 or more than 1.6 after 5 hours, total of 5 hours or more than that, in this baby, that is the time to change the gears. What gear you have to change is up to your unit protocol. In our unit, we intubate and give surfactant. If the SOP has improved to less than 1.6, then we are comfortable telling that we will continue on CPAP alone, and we continue hourly SOP monitoring till the baby improves and we can take him off. This is a very, I would say, sketchy flow diagram for what to do with babies who come with respiratory distress with respect to CPAP treatment, augmentation, or changing the gears. But this can be sort of altered according to the unit protocol and practices. So that's about my talk. Any questions, I'm happy to take.
So thank you, Srinivas sir, for summarizing the assessment of respiratory distress initially. I think most of our participants would be happy to know that they can objectively score the respiratory severity by using Downey score or Silverman score or the new SOP index as well. And thank you, sir, for sharing the wonderful study. I congratulate your team for publishing the SOP study as well. It has shown a very good correlation with AADO2.
Yeah.
So the surfactant administration is more a subjective thing, like babies having more distress or the X-rays showing severe RDS. There are more subjective features into it. You brought an objective thing into that. I think we'll see many more studies with
Yes,
SOP
yes, yes.
in future.
I'm sure that it's going to improve once people start taking it up and do some more studies. Probably we might have better picture of this SOP about how to use it. But currently, this is what is our proposal.
So any participants has any question to ask, sir, on clinical monitoring or SOP index? So there are no questions, sir. Hope they have understood well.
Thank you so much.
Thank you. So we have the next speaker for the day. So Dr. Anil Kallesh. So Dr. Anil Kallesh is a consultant neonatologist at Sarji Hospital, Shumoga. So Dr. Anil Kallesh did his MBBS from Bangalore Medical College. He did his MD Pediatrics from PJMER, Chandigarh. So after that, he moved to New Delhi to do his DM neonatology. So he was a consultant assistant professor at Keli Medical College, Belgaum, for a couple of months. So he's currently working at Sarji Hospital at Shumoga. So Anil Kallesh will take us through CPAP delivery devices and interfaces. So over to you, Anil.
Am I audible, sir?
Anil, you're audible.
Okay. Good morning, everyone. Today I'll be dealing with mainly CPAP delivery devices and interfaces. And let's not waste much time and let's get into the topic. So objectives of my presentation is to enlighten about components of a CPAP device and types of CPAP delivery devices and the comparison of various CPAP delivery devices and different patient interfaces that are available in the market and the comparison of different CPAP patient interfaces and which one to use and how to choose a better CPAP patient interface. So any CPAP system to provide a positive pressure to a breathing baby, So we need three components. Firstly, there should be a gas source, which provides a continuous uninterrupted supply of warm, humidified, and a blended gas. So always try to use a blended gas, which is a blending of air and oxygen, and a pressure generator, which creates a positive pressure to the circuit, and a right patient interface and delivery system that connects the CPAP circuit to the patient's airway. So these three components are a must. So based on the type of pressure generators in the CPAP, we divide the CPAP devices into two types of devices. One type of devices provide continuous flow of air, and the other type of devices, they have a variable flow. So continuous flow devices, they give a desired CPAP pressure, and the pressure is usually generated by obstruction. There will be a continuous flow, and to this continuous flow, there will be a fixed obstruction. Either in a ventilator, it is provided by an expiratory valve, or in a bubble CPAP, there will be a water column wherein we dip a column of tube into the water column, and that water column provides the resistance, and the back pressure generated will provide the pressure into the CPAP circuit. And based on this, the continuous flow devices are either it can be an infant ventilator or a standalone CPAP machines. Here there will be an exhalation valve, and adjusting the valve exposure, that is the amount of valve opening or closing, it will adjust the amount of CPAP required. Whereas in bubble CPAP, as I already told, the pressure is generated by submerging the expiratory limb into the water chamber. And if you adjust the depth of the submerging column, the extent of level of CPAP can be adjusted. And the other type of devices, totally different type of devices, which are less commonly used, but they are very good and more effective, are variable flow devices. So here the desired CPAP level is generated by the varying amount of flow. So the common examples of variable flow CPAP devices are IFD, that is infant flow driver CPAP, or a Viasys CPAP device. Here, the CPAP pressure is generated at the proximal end of the patient nares, not at the machine or in the water column. The CPAP pressure is generated at the patient nares. So these are our conventional bubble CPAPs. This is the Fisher-Paykel bubble CPAP machine, wherein we can see the column which is dipped into the bubble, and on the right side we have a ventilator CPAP. So these are the variable flow CPAP devices which I was talking about. The left side is a Care Fusion infant flow driver CPAP, and here you can see the second diagram, where the CPAP pressure generator is at the infant nares, where there will be a flexible bellows which generate the positive pressure. Because of the flow, increased flow, the variable flow, the pressure is generated at the patient nares. This is another Viasys CPAP device. So coming to the principle how the CPAP device works, the bubble, here we see the bubble CPAP device. This is just a representative diagram. Here we have an oxygen and a flow meter, and the air coming through will have a heated humidifier, which will heat the gas to 37 degrees Celsius, which will be taken up by an inspiratory line, and the inspiratory line, there will be an expiratory limb which is also connected at the patient interface, and the expiratory limb is dipped into a water column. The bubbles in the water column and the depth of the inserted limb will provide the pressure generated, and the pressure generated is back transferred into the patient interface, and it will be transferred to the lung. So this is how a bubble CPAP works. So if we measure the pressure at any pharyngeal area, so if we keep averaging a pressure of around 6 in a CPAP, the bubble CPAP will oscillate around the 6 measured CPAP, and this is how a bubble CPAP pressure will be recorded by any manometer if it is measured near the pharyngeal area. And the same pressure may not be transferred to the down airways. There will be always a fall in pressure than what you set at the CPAP level. So here is another graph which shows the pressure set by using an Hudson prongs. We are delivering a CPAP using a Hudson prongs, and we have set a pressure of around 6. And whenever there is an open mouth, there will be leak of the pressure set, and there will be fall in the pressure. The pharyngeal pressure is always 1 to 2 centimeter lower in compared to the set pressure. And when the mouth is closed, the measured pressure will matches the set pressure. So coming to the variable flow CPAP devices, these are the 3 CPAP devices that are available in the market. One is infant flow driver system, another one is Arabella or Hamilton medical system, and Viasys CPAP system. There are other variable flow CPAP devices like Fabian Accutronic, which is also available in the market. So variable flow CPAP devices, how does the CPAP principle work? So it works on two principles. One is the Bernoulli's principle and the another one is the Coanda effect. The nose piece where at the patient interface is designed to allow the Coanda effect to take place. So what happens in the Coanda effect is there will be a fluidic flip of the gas system during exhalation. During inhalation, the gas enters into the patient's airway, and during exhalation, there will be fluidic flip, the flip of the gas away from the patient, and it enters the exhalation valve. So this is how an patient interface looks of an infant flow driver CPAP. So here will be the entrance of air and oxygen source, and this is connected to the outside atmosphere. The exhalation tube is not connected to any underwater column or anything. The exhalation tube is just left into the atmosphere, outside atmosphere. The exhalation tube is not connected to any column or not connected to any ventilator. This will be a just tube which is lying around. So the air source is channeled into the inlet, and during inspiration it is transferred into the nose. And during exhalation, because of the Coanda effect, there will be fluidic flip of the air column, and the excess air coming from the inspirator limb also will be channeled to the outside atmosphere. The patient will not be required to breathe against an inspiratory air column. So there will be maintenance of uniform CPAP pressure both in inspiration and expiration. Whereas in bubble CPAP, there will be fresh gas flow entering during inspiration and expiration, and the patient has to exhale against a newly fresh coming gas against a resistance of a fresh coming gas. So this is another effect, another diagram showing the Bernoulli's effect and the Coanda effect. During inhalation, there will be the air column will be entering into the nose, and during exhalation, the pressure generated from the patient will direct the fresh coming gas away from the inspiratory circuit, taking into the atmosphere. So the patient need not breathe against a resistance of freshly coming air. So a uniform CPAP pressure will be delivered. So this is one of the another age-old system which is type of variable flow CPAP. This is called D'Amica Benveniste valve. Here there will be a gas jet which is directed through a ring-like interface, and the gas from the jet is inspired, while the expiration, the gas goes into the surroundings. So there will be no separate expiratory limb provided in this. And we are providing the system through a Argyle prongs. You can see the Argyle prongs in this interface. And this is a Benveniste valve. So if we compare the different pressure generators, so main ventilator CPAP, the main disadvantage is the cost. You need to have a financial assistance of around 6 to 10 lakhs to maintain a ventilator CPAP. And along with it, there will be annual maintenance of the ventilator. And special advantages is whenever you are on an invasive ventilation, we can just shift to non-invasive ventilation like CPAP without going to another separate equipment. You can just convert the same equipment into a ventilator CPAP. So main disadvantages, it is usable only in big hospitals, and the ventilator only provides a set flow. If the set flow is insufficient, the patient may have to have increased work of breathing. You may not know whether the set flow is sufficient or not. And coming to another standalone devices, cost may not be as high as CPAP, but they can be good for smaller hospitals. Whereas the standalone CPAP, there may be improper blending and there may be improper flow generated in standalone CPAP machine. Whereas bubble CPAP machine, they are very good for a low cost or a resource limited settings, and the cost is intermediate between a ventilator CPAP and a standalone CPAP. And gas exchanges are better in bubble CPAPs, whereas the main disadvantages is very high leak can occur in them, and it is very difficult to detect the flow, and there is no any currently available market devices. They don't have any manometer to detect the pressure. We have to have an external manometer which has to be connected to bubble CPAP devices to measure this, whatever the pressure is set is delivered or not. Whereas a variable flow CPAP device cost is very high, whereas they have an advantages of decreased work of breathing, and it provides a uniform pressure. Whereas to use a variable flow CPAP device, more expertise is needed to learn how the variable flow CPAP device works. So coming to evidences, whether to use a variable flow CPAP device or a continuous flow CPAP device. So there are many evidences available. Based on RCT on 276 infants on less than 32 weeks, they compared infant flow driver CPAP versus a ventilator CPAP, not a bubble CPAP, and post-extubation and as primary treatment for RDS. Both were compared. And the outcome measure was treatment failure rates within 3 days. And the result was the treatment failure rates were similar with both variable flow CPAP devices and infant flow driver CPAP devices. And infant flow CPAP devices were associated with lower extubation failure rate in low failure rate in post-extubation group, but where there was higher incidence of pneumothorax. And the variable flow CPAP device was associated with lesser nasal injury. So if you consider variable flow CPAP device, whether it's superior to continuous flow, for post-extubation, there are other 2 trials to support this. And other 2 trials found there are lower extubation failure rates with infant flow drivers, but the other 2 trials did not show much differences between the infant flow driver CPAP or ventilator CPAP. There is only one Indian study which found rates were similar on successful extubation between the 2 devices. So there are no conclusive evidence to show that the variable flow CPAP device is better than continuous flow CPAP devices. So if we compare the continuous flow devices, among the continuous flow CPAP devices, there is bubble CPAP and ventilator CPAP. If we see that studies comparing bubble CPAP and the ventilator flow CPAP devices, there are 2 studies, which is one from KEM and other from AIMS. The KEM study compared 114 preterm neonates. They compared bubble CPAP versus ventilator CPAP, and the outcome measure was a failure of CPAP. And in this, the bubble CPAP had a higher success rate compared to a ventilator flow CPAP devices. And also in another study from AIMS, the bubble CPAP device is associated with 50% reduction in extubation failure rates. However, in this study, the difference between the bubble CPAP and the ventilator CPAP is still not statistically significant. And still there is a gray area whether to use a ventilator CPAP or a bubble CPAP in neonates. So coming to summary, the variable flow CPAP has a physiological advantage over bubble CPAP or a ventilator CPAP. However, the cost factor precludes its usage in resource limited setting. And still the clinical trials have not demonstrated superiority very consistently in all the trials. So still the variable CPAP device is not so much used in market and also in our hospitals. So bubble CPAP device is always, the pressure is dependent always on the flow, and possibly it delivers a slightly higher pressure than set pressure if the right interface is maintained. And this will account for improved efficacy compared to some of the studies showing ventilator CPAP, better results than ventilator CPAP, because it delivers a slightly higher pressure because of the right interface being used. So after the pressure generators, coming to patient interfaces. So there are so many patient interfaces which are available. We have nasal devices and other devices. So nasal devices are divided into nasal prongs, nasal masks, and nasopharyngeal devices. And nasal prongs may be single or a binasal prongs, and other one is nasal masks. So nasal masks available are Fisher-Peckel, Drager, and McQuett, whereas nasal prongs available are Argyll prongs, Hudson prongs, Drager, Fisher-Peckel, and McQuett. And nasopharyngeal, which is very outdated now, which is not currently used since last 8 to 10 years. And the other devices are like sealed masks, chambers or head boxes or ET tube. These are phased out from the market, and it is not advised to use these devices to provide CPAP to the patient. So these are the available interfaces. So this is a Hudson prong, and this is a short binasal Fisher-Peckel prongs. And we have is Argyll prongs, and these are age-old devices which can be used in resource-limited settings still, like ET tubes or binasal prongs. And other very frequently used devices are ramps cannula. These are the various prongs available sizes. Hudson prongs comes in 3 sizes: 0, 1, and 2. This is used based on the patient's nose size and also on the gestational age. Fisher-Paykel also comes in the variable sizes and also comes with a marker indicator where we can measure the size of patient nares and decide which masks to, which prongs to use. And this is the Argyle prongs. This is one of the representative diagram where we have shown the Hudson prongs being used to deliver CPAP, where we can see Hudson prongs is attached to the patient nares using a Velcro tape and a locally made fixation to the cap. The cap is provided, whereas the straps have to be made. The cap and the Hudson prongs comes together along with together in a pack, whereas the fixation has to be made locally using a pin or a tape or another adhesive can be used. So this is one of the diagrams showing how a locally used resources can be used to attach Argyle prongs. Using a socks, adult socks, some holes can be cut and can be used as a cap, and Argyle prongs can be used to deliver CPAP to the patient. So Argyle prongs can be connected easily to a Neopuff, Fisher-Paykel Neopuff device, and CPAP can be delivered during the transport or during labor room to the neonates when they have respiratory distress until they reach NICU. So this is a representative figure of a McQuet masks, and this is the right side is a McQuet prongs. So endotracheal tube, using endotracheal tube, we are used to give CPAP either a oro or a nasotracheal way. So it has a very high resistance and it is equivalent to breathing through a straw, and the patient has to exhale, inhale almost like a straw, and this increases the work of breathing. This causes atelectasis, and this has all disadvantages of intubation. Whatever invasive intubation we have, same disadvantages the patient has if we use endotracheal tube for providing CPAP. And latest Cochrane review also forbids the use of ET CPAP for extubation. After extubation or before extubation, giving a CPAP through AT tube is forbidden. So coming to comparison of CPAP interface devices, nasal prongs are very not cost effective. However, the advantages have low resistance and there are less blocks, less nasal blocks. However, disadvantage is very difficult for fixation and they are highly prone for trauma. And whereas nasopharyngeal, they are very low cost and they can be fixed easily to the nose. However, it can be given by ET tube, which is locally available. But as earlier I told, it carries its own disadvantages, same as intubation. And it is easily prone for more blocks and easily gets kinked, resulting in very poor delivery of CPAP. Nasal cannula are easily available and very cost effective, and the disadvantage is they don't deliver reliable pressures, and it requires very high flows to deliver the set pressure. Whereas nasal masks, that is Fisher-Paykel or the Drager or the McQuet masks, are intermittent in cost between the nasal prongs. However, they are very simple to use and they are less prone for trauma. And currently the data are still picking up for usage of nasal masks. However, the best interface according to my practice is use of Fisher-Paykel nasal masks. Sorry for the jumbled up slide. So if we compare the different studies, comparing the different interfaces, so in Cochrane, the initial studies also showed they compared short binasal prongs with the nasopharyngeal prongs for prevention of reintubation in preterm infants. There was the relative risk was 0.59. There was 41% reduction with by short binasal prongs in comparison to nasopharyngeal prongs. And there is also decreased oxygen requirement with use of short binasal prongs. If we compare masks with prongs, both are equally efficacy. However, the masks are safer. They are less effective, less prone for injury, and less nasal injury occurs with masks compared to, there were in one study from AIMS, there was almost 0% injury with use of nasal mask in comparison to 30% with use of short binasal prongs. So this is another study comparing the pressure which is delivered by different interfaces. They have compared inflant flow mask, Fisher-Paykel mask, and inflant flow prongs, Fisher-Paykel prongs, Ram's cannula, and Hudson prongs. they compared the resistance offered and the at different interfaces and different sizes of the same interfaces. 3 sizes of each interfaces was selected, and out of this, the rams cannula and the prongs, Fisher-Paykel prongs, they offer the highest resistance during the usage of CPAP, and rams cannula has persistently shown a higher pressure at expiratory circuit of more than 4.5 centimeter, and it is inconsistently delivers the set pressure to the CPAP. So the highest resistance is shown by prongs and the rams cannula, and so it is not advisable to use a device or an interface which provides highest resistance. The least resistance is shown by Fisher-Paykel mask and also the infant flow mask. The masks have the least resistance offering to the circuit and better delivery of the CPAP set pressure to the patient rather than the prongs. So the available devices which we have already discussed. The ventilator CPAP, it costs minimum, it costs around 5 to 10 lakhs, and the bubble CPAP machine, it costs around 1.6 to 2 lakhs, and the standalone CPAP machine, which are cheaper compared to other devices, but they are not very consistent in delivering the pressure and the flow. Whereas the variable flow CPAP device, they cost somewhere around 3 to 5 lakhs and is not easily affordable in resource limited settings. So this is a new innovation which is coming up, which is called SIAPAP, that is Seattle PAP, wherein the dipped column is bent at 135 degrees, and it provides a higher oscillation, higher frequency oscillation to the expiratory limb and better recruitment of lungs during the CPAP. And these are being used in resource limited countries like Africa as a pilot project by Bill and Melinda Gates Foundation. And these are yet to reach the market and in our country and other developing countries. So these are the crude CPAPs which we see in day-to-day life, which are non-blended and in very resource poor settings we can, which is being still followed. And however, this has very high risk of giving 100% FiO2, causing retinopathy of prematurity or BPD, and also unhumidified, unheated oxygen and air, which lead to hypothermia, and also poor humidification in the circuit will lead to nasal crusting and blockade, and sometimes even the bottles are also not available for providing CPAP. So this is one of the slides which shows if we don't have a blender in our setting, how can we give a blended air oxygen mixture? This is a ready-made table wherein we decide the flow of the air and oxygen, and we can calculate based on the flow rate the amount of FiO2 being delivered to the patient. Based on the saturation the patient is showing, we can always titrate the FiO2 based on the rate of air and oxygen flow rate. This is also a graph wherein we can titrate the FiO2 to the patient and also prevent the oxidative damage to the patient. So it is, if the blenders are not always available, there are also other sources to provide blended oxygen. So there are always ways to give blended oxygen and prevent the morbidities that occur in the premature neonates. So take-home message is almost 88% of neonates less than 32 weeks require CPAP. And both European consensus and American Academy of Pediatrics definitely recommend to use CPAP upfront, but they do not recommend any one type of CPAP delivery devices or an interfaces. And we have to decide on the factors in making decision, like the comfort of the device and the risk of nasal trauma by use of the device, and how effectiveness of the seal created using that interface and the device, and how is the positioning and also the potential for head molding occurring because of the caps and the circuits, and also the cost of the CPAP devices and the interface that are being available in the market. So these are the factors which play in making decision of right CPAP delivery devices and interfaces. I have not covered the nasal injury part because of the CPAP. I think it will be discussed in somewhere else. I'll be happy to take any questions, Abhishek sir.
Thank you, Anil, for summarizing the CPAP devices and interfaces. So I think in CPAP devices, we have learned that bubble CPAP, whatever evidence is showed, bubble CPAP is definitely superior to ventilator CPAP from most of the studies available till now. And apart from bubble CPAP, he also discussed about interfaces. He showed us that mask has the least resistance. But most of the nurses may find mask to get dislodged. It's very difficult to maintain mask. So nasal cannula, many people have moved towards using Ram's nasal cannula. Some are still using Hudson prongs. So Anil, can you summarize on the usage of nasal interface? What should be the take-home message for the people listening here? Can you unmute yourself?
So the right interface depends on the availability. According to the personal experiences, it is better to always go for nasal masks, and the right interface has to be trained to the nursing staff, and right protocol has to be devised for the unit. And any device is not fall short of injury. Even the nasal masks also prone for injury. If you use nasal prongs, there is more injury to the septum necrosis and septum damage can occur. Whereas the nasal masks are also prone for nasal bridge injury. So all devices are prone for their own advantages and disadvantages. So each device has to be unit specific. And if we train the unit specific nurses and choose the devices wisely and the interfaces wisely, we can give better results to the patient. And I advise to go for nasal masks rather than prongs, because it is easy to fix and easy to handle, and also less trauma compared to nasal prongs.
Yeah, thank you, Anil, for that. This one. So I would partially agree with Anil. So Anil mentioned that nasal interface primarily should be unit specific. So it should be like if you see mask versus Hudson prongs versus Ram's cannula. So the physiological experiments have shown that Ram's cannula, there is loss of pressure. So nasal masks are superior with physiological experiments. But if you see on ground clinical trials, so Ram's cannula, the CPAP delivered to the babies, the outcomes are almost similar. So what I would say is still we need more evidence. If you are comfortable with using mask, continue to use that. So there are many units who are still comfortable with Hudson prongs, but if you find nasal trauma is more, we'll have to rethink on your practices to think of using Ram's cannula or preferably nasal mask. So any questions to Anil at this moment? How many of
Dr. Anil,
CPAP?
it is Srinivas Murthy here.
Sir, you can.
Yeah, I think we should congratulate Anil for such a beautiful, wonderful, lucid and crisp presentation. I learned a lot, honestly. And because of his presentation, now I have a clarification, a doubt in my mind, which I would like Dr. Anil to clarify. It's not that I'm asking you a question, but I'm just trying to educate myself.
Sure.
When you said about the variable flow devices, and just educate me, how is the pressure regulated here at the end of expiration? Is there any idea about it? For example, if you want to give a CPAP pressure of 4 or 5 or 6, what determines that pressure? If the expiratory gas is let out to the atmosphere without any obstruction or without any challenge, then is it the flow which is going to decide the pressure? I just don't know about it. So please educate me.
The flow, the flow changes during the inspiration and expiration. It is never a constant flow in this type of CPAP. So if we have to set the pressure, suppose if we set the pressure at 6, the flow rate may vary between 6 liter per minute during inspiration and 8 liter per minute during the expiration. And the flow flips from one level to another level to deliver the constant CPAP that we have set. So the main difference is the flow rate, which adjusts according to the expiration and the inspiration, during expiration and the inspiration.
Yeah, that's important. That I just wanted to make sure that what I know is correct. Yes, it's the flow which varies. The thing is, I have one sort of doubt about why do we need to worry too much about the pressures during inspiration, because anyway it is the baby's effort which gets the gas into the lungs. So as long as the gas is present around, and even if it is at the atmospheric pressure, the inspiration shouldn't be a problem unless there is an obstruction to the upper airway. So I am of the opinion that well, I'm just challenging the superiority of whatever the claim superiority of air flow devices about having a constant pressure, because that is not a determinant of anything. The pressure at the patient and during inspiration is not a determinant of anything apart from our academic discussion. So it is the pressure at the expiration which is important, and I agree with you that it's more of a variable flow which sort of offer the resistance. So yeah, I just want to clarify myself, because the way you presented made me to think in a different way, and it was very, very nice. Thank you so much, sir.
Thank you, sir.
Thank you, Anil, for that clarification. Any other doubts? Anybody? How many of you are actually using CPAP or practicing CPAP? Few of you are already using CPAP. So, Anil, can you just help them with the delivery room CPAP, which device to use, or how do we make it possible while you are there? Because half of them actually, after this workshop, are planning to implement CPAP in their units. I would request you to just throw some light on delivery room CPAP.
So delivery room CPAP is a very effective measure. It prevents the alveolar collapse immediately after birth. And also there are different studies showing that there is decreased need of surfactant, decreased need of intubation, and very effective in preventing BPD also. So various devices can be used to provide delivery room CPAP, like Fisher-Paykel Neopuff, whatever we have TP's resuscitator can be effectively used to provide delivery room CPAP. And Fisher-Paykel CPAP can be attached to, as I told, either it can be attached to masks that are available, anatomical round masks to deliver pressure as given in NRP. Or if there is prolonged requirement of CPAP, which is difficult to hold the mask because of high leak, the Fisher-Paykel exactly fits into the argyle prongs. The argyle prongs can be made available in the delivery room, and the cap and the suitable thread can be used to fix the argyle prongs in the delivery room as we wait the NICU ventilators being set or the CPAP machines being set. Or even if the facility is available, even we can set up a Fisher-Paykel CPAP device can be made ready in the delivery room. And the same with same CPAP device, the baby may be transported to the NICU, and the same device can be continued to be used in the NICU stay also. These are the various ways of giving a delivery room CPAP.
Thank you, Anil, for that summary. I think hope most of you have understood. So we are not device specific, we are not company specific there. So just to emphasize again, there are various devices from Fisher and Paykel to Phenom to NICE, Neotech. Basic physiology there is we'll have to use a TP resuscitator. So the TP resuscitator can deliver PEEP. You can use that. Or if facility is available, definitely you can set up a standalone or a bubble CPAP direct delivery room, and you can transfer the same to your NICU. So any questions? So you had any questions or doubts? You wanted to speak something. Anil, there is a question for you.
Delivery room CPAP, sir. Actually, I wanted to know whether we have to monitor about specific about the PEEP as well as F5O2, or is it just a crude one where we get just a regular PEEP and F5O2? I wanted to know, and if so, which equipment or which company is the best among them?
That's a very good question, sir. Actually, ideal situation, you should have a blender, because NRP also advises to start resuscitation with room air to term neonates, and also for less than 32 weeks at 21 to 30% FiO2. So if it is best, it is available, we connect the blended air and oxygen to the CPAP delivery device, and then use the CPAP delivery device. That is the best scenario. If the resource is restricted, we can try using a directly 100% oxygen at least to give initial CPAP during resuscitation, and then transport the baby to NICU, where we can give blended oxygen and air as soon as possible. The devices, as already told, TP's resuscitators are available in the market. That is best available, where we can transport the TP's resuscitator, and also sterilization is also easy about the circuit, and they can be easily transported to any place where the resuscitation is happening in the different delivery rooms. If we attach the standalone CPAP, it is difficult to transport to another delivery room. So if for a OT or a labor room, we can easily transport the TP's resuscitator and take wherever we want. It can be taken along with the resuscitation kit. The TP's resuscitator must, I advise it should be a must for every resuscitation kit. And as I told, it can be attached to either a face mask, anatomical face mask, round or anatomical face mask to provide CPAP transiently during resuscitation, or for prolonged duration, you can definitely attach to argyle prongs. That is very easily attached and can be easily fixed and secured till the transport of the baby. Argyle prongs are easy to use to fix to TP's resuscitator. That is what I advise. And TP's resuscitator, there are various available in the market, and I don't think anything is superior or inferior. All TP's resuscitators can be used to deliver this CPAP, to delivery room CPAP.
So Mahesh, sir, I think that answers your question. So it's important, which is specific for that device. If you're using a standalone CPAP, the flow is set for that standalone CPAP. If you're using a TP's resuscitator, you would need 6 to 8 liters flow. You should be worrying about pressure. It has a dial TP resuscitator, which will show us the pressure delivered. And regarding FiO2, as Anil mentioned, using a blended oxygen, we can prevent ROP, especially for preterms. And we can start off with 30%, as Anil mentioned, for preterms. So that should answer your question. In workstation, we have a TP's resuscitator for display. So there, I think we can discuss.
The cost is around like 80,000 to 1 lakh for the TP's resuscitator. All the available market devices will cost between 80,000 to 1 lakh. So
most of them are flow operated, so it doesn't require electricity, most of them. That in the workstation, sir. Any other questions to Anil? Thank you, Anil, for the presentation. So the next talk is about CPAP case studies. So till now, we had sessions from our experts on science and physiology of CPAP. We have seen how to assess the distress. What is the evidence? We have seen Anil speaking extensively about CPAP devices. Now let's learn CPAP application through some of the case scenarios. So this will be more like an interactive session. So the questions will be directed to you directly. So there's nothing right or nothing wrong. So you can think, you can give out the answers, and we can see how the case moves on. So the next 30 minutes, we'll discuss about just 2 case scenarios. We're not going to discuss many cases. So practical case scenarios, that is CPAP in respiratory distress syndrome, CPAP in the situation of post-extubation. So as the case unfolds, we'll learn, again, we'll have to revise the evidence, what the previous speakers have told us. We'll go through this one by one. So the first case, our learning objectives will be antenatal counseling of a preterm delivery. How do you prepare delivery room for the delivery of a preterm? RDS in a newborn. How do we optimize CPAP? What are the steps of surfactant administration, or what all goes in our mind when we decide to give surfactant for a baby? So it's pretty much simpler. Most of you would be already practicing it. I'm just trying to fine tune your thoughts and skills here. So the first case, a 26-year-old gravida 2 with 1 abortion, 30 weeks of gestation with PIH in labor, PIH is pregnancy-induced hypertension, is planned for LSCS in view of fetal distress in the next 30 minutes. She has been given antenatal steroids at 28 weeks. Estimated fetal weight is around 1.1 kg. You have been asked to do antenatal counseling. What will be your concerns in this case? 30-weeker, 1.1 kg, mother having PIH, steroids given 2 weeks earlier. So what will be your concerns for the parents?
The first and foremost will be because already the mother has lost 1 child. This thing, we have to explain all the possible consequences. The second one, for the baby, we have to tell them that it may need, because we have given already steroid and all, and it is PIH mother. Usually their lungs are well matured than other babies. It may not need any extra assistance, but we have to be prepared for that, and its cost and all the consequences of that. I think that has to be counseled regarding the.
So anybody wants to add further for that? So apart from, yeah. Yes, please.
Since the mother is just 30 weeks, baby estimated fetal weight is 1.1 kg. This is through the scan. Once the baby is born, baby may be less than 1 kg. So it's a extremely low birth weight baby. So baby needs NICU care. Feeding support, suckling might have not developed sucking reflex, and also feeding has to be taken care of. And mother should be like, parents has to be counseled regarding IVH, low birth weight, taking care of the temperature and any PDA, NEC, all those things, it has to be explained to the parents, and like need for NICU care for the baby has to be told. Since the steroid is given just 2 weeks back, there is I think there is no need to repeat again. Thank you.
Yes, ma'am, you are right that we need to add up, apart from antenatal counseling of HMD, we need to add upon the need for NICU care, the feeding challenges in this case. So you wanted to add something, sir?
Just whenever we expect such a baby, we can actually do the counseling in 3 broad ways. One is mother perspective, baby perspective, and the financial perspective. Coming to the mother's perspective, since it's a preterm delivery, it is going to have some psychological effect for the mother also. Probably that should be taken care for the gynecologist, and we need to talk to the gynecologist also. And from the baby perspective, since it is a 28-week baby, the development of the baby with all the internal organs and their complications, whether it could be respiratory, cardiac, jaundice, renal related problems, and the percentage of how we can save the baby, all these things we have to discuss in detail with the parents. And third point is about the financial aspects. What types of treatment are involved in this baby, and what are the costs going to be incurred during this process, and how many days the treatment should take place. So in these broad lines, I think we need to do this in detail counseling, because it will take a long time, lot of expenses, psychological factors. Considering all these points, we have to talk to the parents.
Thank you, sir, for summarizing the complete thing. So apart from RDS, apart from delivery room management, we need to discuss about length of stay, financial aspects. So I put a slide for you from the latest report from the Indian National NICU Collaborative, where 20 NICUs contribute their data on prospective basis. So we have 2 hospitals from Karnataka as well who give their data here. You can see that for a 30-weeker, so you can see the CPAP requirement is close to 70%. The mechanical ventilation rate is roughly 35%, 1/3 of babies. So NIV rate is 14%. As centers will use NIV more, I think this will pop up more. You can see half of them are requiring parenteral nutrition. So central line need is also almost half for these babies. So that means these babies will be sick. They would need intervention, ventilation, as well as central line or surfactant. You can see the surfactant need is close to 52%. So despite steroids, half of them may still require surfactant. You can see half of them may still require 2 doses as well. So by day 10, they will attain full feeds. So you can see that roughly out of 700 babies, 50% are requiring surfactant. That too, another 25% are requiring 2 doses of surfactant. So I think you can give these figures based on your unit data, and these are rough national figures for you from the National Collaborative. So apart from antenatal counseling, I think we had a short concern about antenatal steroids. I think from the national guidelines, we are all well aware that dexamethasone is the steroid of choice, and dexamethasone generally is given only once in the national guidelines. But if some people are following ACOG or RCOG guidelines, they may consider repeating 1 more dose since the 14 days is elapsed. So there's nothing wrong in giving the second dose, but we are not recommending any multiple courses here. So steroids, I think most of us are aware that the most important effect is on survival. The survival is close to almost 22%. So this data is roughly from 10,000 odd mothers and 10,000 odd babies. If you see the RDS, there's decrease in RDS by almost 29%. So that 29%, rather than that, if I say number needed to treat with this steroids is 23. That is, if you give steroids for 23 mothers, one mother will definitely benefit from this intervention. So that is the effect of steroids. So apart from steroids, I think special preparation has to be there in the delivery room. So we all know that we need 2 people trained in NRP, especially one person who has to manage the airway. So remember, it's a 1 kg baby. Will have to have cling wrap, cap, especially if you have to prevent hypothermia. Keep your transport incubator ready. Let it be warm. And remember, in the delivery room, we need to prefer gentle ventilation. If you have to prevent BPD, we need to start gentle ventilation from delivery room itself. I think we need to prefer T-piece resuscitator versus a bag-in mask. We need to use blended oxygen if available. Prefer delivery room CPAP, that is start CPAP and the delivery room itself. Cautiously. So regarding delivery room CPAP, just to summarize, it's a busy slide. I'm not going to read every word of it. So remember that there are 3 major trials: COIN trial, support trial, and Von trial. All these trials compared starting delivery room CPAP versus the conventional approach. Conventional approach in these trials varied from mechanical ventilation to surfactant versus starting CPAP later, that is at the onset of distress. So they have found that summary of all these 3 is that if you start delivery room CPAP, you are going to reduce mechanical ventilation need by 50%. So if you start delivery room CPAP, you're going to obviate the need for surfactant in 50% cases. So if you start CPAP in the delivery room itself, you don't need to use surfactant and mechanical ventilation in half the cases. So if you're not using mechanical ventilation, that means you're reducing the risk of chronic lung disease in these babies. So that's a summary of delivery room CPAP. So coming back to the case now. So now the baby has been delivered. The baby cried at birth. Delayed cord clamping was done for 60 seconds. The Abgas were normal. There was no asphyxia. The baby has respiratory distress, and we have stabilized the baby on delivery room CPAP, and we have transferred the baby to NICU in the incubator. The admission temperature is appropriate. The baby started on bubble CPAP at 5 centimeter PEEP, 5 liter per minute flow, and FiO2 of 50%. So just basically, we are just following the rule of 5. You can see that it's 5 centimeter PEEP, 5 liter flow, 50% FiO2. So what are your concerns at this stage? Now the baby is in NICU on bubble CPAP with these settings. What are your concerns now in NICU? Who wants to attempt this? What are your concerns now in the NICU? Anybody wants to take up this, or should I call? You want to take up, sir? Yeah, that's great.
Whether these settings are sufficient to keep the baby in a stable condition or not. Second thing is whether do we need a surfactant. We have to always keep our finger crossed in this matter.
Rightly read the slide. Next slide. So the concerns at this stage for us will be surfactant administration. So how do we optimize this CPAP? And remember, we need to stabilize this baby within this golden hour to have maximal outcomes. So let's go one by one. So regarding surfactant administration. So whenever surfactant is being delivered to a preterm, the question that comes to anybody's mind is, should we give off surfactant or should we increase CPAP and then give surfactant? That is prophylactic versus rescue surfactant. If you look at era, just one decade back, just 10 years back, people actually used to take surfactant to the delivery rooms. So if babies were born preterm, they used to intubate, give surfactant, start the baby on CPAP, then shift to NICU. That was a practice I think most of us would remember. But over the last 10 years, the practice has changed. So people have moved away from prophylactic surfactant to rescue surfactant. If you look at the last Cochrane 2012, with routine application of CPAP in the delivery room with good antenatal steroid coverage, so you can actually get away from prophylactic surfactant. So it's better to wait, stabilize the baby on CPAP, and then consider surfactant. So because if you're giving rescue surfactant, there is less risk of mortality or even chronic lung disease with rescue surfactant. So the message here is optimize CPAP first, then decide about surfactant. Coming to the surfactant administration. So if you have decided to administer surfactant later, how later it should be, or how earlier we should give surfactant to maximize the outcomes. So this is a busy slide. I think this is a forest plot. If somebody could recognize it, this forest plot actually shows comparison between early CPAP versus late CPAP. Early CPAP meaning the first 2 hours versus beyond 2 hours. So if you look at the forest plot diamond, the diamond lies in early CPAP. I think the screen is not visible. So 0.83 is the RR. That is, there is 17% less risk of CLD or death if you prefer early surfactant. That is, if you're optimizing CPAP, optimize CPAP well within the first 2 hours and deliver the surfactant if necessary. So if you do that, you can maximize outcomes in terms of less CLD or death. So coming to the oxygen threshold, at what oxygen threshold we should be delivering surfactant. So there are various guidelines available. I think hope we soon get the clinical practice guidelines from NNF soon, but with the available evidence from the European guidelines, the reasonable threshold for surfactant administration is at a FiO2 of 30% and a PEEP of 6 centimeter. So at a PEEP of 6 centimeter, at an FiO2 of 30%, you can consider giving surfactant if the distress persists. If the FiO2 requirement is below this, I think probably you can continue with CPAP. That's the thing. So coming to the optimization of CPAP, so remember, we can optimize CPAP primarily by clinical monitoring. If you have retractions and grunt, increase the PEEP. Some units can go to PEEP as high as 8 centimeters. Some people stop at 6 to 7. It depends on your unit expertise. If you have expertise to manage air leaks, or if you're comfortable, you can go up to 7 to 8 centimeter. Otherwise, you can stop at 6, decide about surfactant. Regarding hyperinflation on an X-ray or clinical hyperinflation, you can decrease the PEEP. If saturation is high or low, that is a target of 91 to 95. If it is below or higher, you can titrate your FiO2 based on the settings. So this is how you titrate PEEP and FiO2. We'll discuss this further in the workstations. So coming back to the index child, what happened to this child? This child is currently 15 minutes of life. There is tachypnea, retractions. The SAS score, that is Silverman score, what Sir discussed, Srinivas sir discussed in the morning class, SAS score is still 3, SpO2 is 91%. So should we increase or decrease the settings? Should we increase FiO2 or is FiO2 fine? Our FiO2 target is 91 to, SpO2 target is 91 to 95. Here the SpO2 is 91%. So there's no need to titrate FiO2. What shall we do? There is retractions, there is tachypnea. We need to increase PEEP. So from 5 centimeter, we increase the PEEP to 6 centimeters. So at 30 minutes, the effect of this is the tachypnea has settled. There is mild intercostal retractions. SAS score is now 1 because of mild retractions. SpO2 is 98%. So what shall we do? Yeah, continue with the same PEEP because there is mild retractions, decrease the FiO2. You can decrease the FiO2 by 2 to 5% every 5 to 10 minutes. Next, at 45 minutes, now your RR is normal. SAS score is still 1 because of compliant chest wall. SpO2 is 98%. You're on a PEEP of 6, FiO2 of 35%. What should we do next? Yeah, reduce the FiO2 further, continue with same PEEP. So at 1 hour now, we are at RR of 54. SAS score is still 1, SpO2 is 96. We are at a PEEP of 6 centimeter, FiO2 is 25%. We could establish a central line by now, by the end of 1 hour. So our ABG virtually appears normal. So what should we do next? We need to taper PEEP and taper FiO2 as well. So always taper FiO2 first and last would be PEEP. There are no general guidelines. How do we decrease PEEP? So if there is clinical hyperinflation, we decrease the PEEP. Or if you have FiO2 pressure balance, generally they say, if you are delivering a PEEP of 5, your FiO2 should be 30%. If you are delivering a PEEP of 6, your FiO2 should be up to 40%. If you're delivering a PEEP of 7, it is 50%. And once you are on a PEEP of 8, you should have a FiO2 of 60. So once you are beyond 60% FiO2, it is better to consider NIV or intubation. So those are rough figures, what we can say, which are not evidence-based, but those are rough pressure and FiO2 balance. So how will we monitor this baby further? So what do we ask a nurse to monitor? So whenever a baby is on CPAP, the monitoring is different. So the monitoring is simpler. Remember that. So what I meant to say different is that we'll continue to do clinical monitoring, that is respiratory rate, retractions, SpO2, SAS score. It's better to train your nurses on SAS score compared to Downey score is what I feel, because Downey score has a component of air entry, which the nurses may find it difficult to manage. So better to have SAS score. So if you are trained in SOAPy index, I think that's a good one. What we learned in the morning, we can continue or try using SOAPy index as well. So apart from clinical monitoring, the extra monitoring will come in nasal orifice. We need to do nasal trauma assessment at least once in every shift to assess for nasal injuries. So I think we'll learn more in the next session. We need to monitor the machine as well. If you are using bubble CPAP or ventilator CPAP, check at the flow, check the pressure which has been set, check the humidifier temperature, look for any condensation in the circuit, look for bubbling or seal. Because if you miss this, baby may get higher pressures or lower pressures, depending upon the problems with the machine. So coming to the blood gas, there is no indication to do routine blood gas for a baby on CPAP. So if you're anticipating intubation, then probably you can consider blood gas, but I would say routine blood gases are not indicated for a baby who is stable on CPAP. So coming to the next, X-ray chest. Again, remember, X-ray, there's no routine indication to assess inflation or to decide on surfactant. X-ray you do only if you have a concern about diagnosis. So you're worried about diagnosis like aspiration versus pneumothorax or collapse, you do an X-ray. Otherwise, routine X-ray for a baby on CPAP is not necessary. Coming to the summary of this case, RDS is a common morbidity below 34 weeks. Delivery room CPAP reduces the need for mechanical ventilation or surfactant. CPAP initiation rule of 5, remember that 5 liter flow, 5 PEEP and 50% FiO2. Optimize CPAP based on retractions, grunt, SpO2. Only if needed, do X-ray or blood gas. Avoid prophylactic surfactant. Prefer early selective surfactant if you are needing PEEP of 6 centimeter and FiO2 beyond 30%. So these guidelines may change once we get the national guidelines soon. So we have come to the end of the first case. So let's move on to the next case. The second case, we are going to learn about CPAP failure. What is the post-extubation care of a preterm neonate? We'll also discuss about role of CPAP post-extubation. So this is more or less a similar case. It's baby K, 30 weeks, 1.1 kg, gravida 2 with 1 living issue, born by emergency LACS. I think even this mother has PIH. Here, mother has not received antenatal steroids. So the baby required positive pressure ventilation for 30 seconds. So the baby was started on CPAP, but the baby required almost PEEP of 7 centimeter, FiO2 of 60%. I think everybody would agree with me that this is a case where we need to give early selective surfactant. So surfactant was delivered by Insure. Post surfactant, baby continued to have distress with PEEP of 7 centimeter, FiO2 of 70%, SAS score of 4. So we have given surfactant, but still the distress is persisting. What are all the possibilities in your mind at this moment? So similar picture, no steroids, had asphyxia. You're given surfactant, but still the distress is persisting. What are your possibilities? Sir, please.
then we should go for intubation.
Sir feels we need to go to intubation as a management. I agree with you, sir, regarding management. So what has gone wrong here? Yeah, somebody said pneumothorax. Yeah, you're right. Pneumothorax is a possibility here. What else? Yeah, pulmonary hemorrhage post-surfactant is still a possibility. Yeah, you're right. What else? So yeah, that must be the cause for requirement of resuscitation at birth. But now the baby is having distress. I think most of you, you have picked up half of it. I think some of the possibilities what we need to consider, especially when baby is not responding despite the first dose, would be, is it severe HMD? So because you have not given steroids, required PPV as well, mostly this baby would require another dose of surfactant, who knows? So I think one of you rightly said there is a possibility of pneumothorax. One possibility could be your surfactant could have gone to the right lung preferentially if you have caused malposition of your ET tube while delivering surfactant. Fourth possibility could be PPHN as well. Preterms are also prone for pulmonary hypertension. So fifth possibility could be undiagnosed infection. So another sixth possibility, I think pulmonary hemorrhage is still a possibility. So the summary from here is that causes could be anything. So we need to rule out one by one. So in this case, I think somebody rightly mentioned that should we label as CPAP failure? So definitely this is a case of CPAP failure. So when do we label a child as CPAP failure? So if somebody is requiring FiO2 beyond 60%, if you do a blood gas, there is acidosis, that is pH below 7.2, or PSO2 beyond 65, or somebody having frequent apnea requiring PPV on CPAP, you call as CPAP failure. So before labeling CPAP failure, we need to ensure adequate pressure, seal, and FiO2. So look at machine factors before labeling a CPAP failure. If CPAP failure, consider NIMV or intubation. So for the index case, baby had severe respiratory distress. The baby needed invasive ventilation by SIMV mode. So we had to give one more surfactant after 12 hours. So on day 3, now the baby's distress is improving. The baby is on a setting of 14/5, 25/30 rates. So what are your concerns at this stage now? What are your concerns now? So we had severe RDS, we gave second dose of surfactant, there was CPAP failure because baby was early preterm, had asphyxia, there was no steroids, so there was CPAP failure. Yeah, you're right. You'll have to try extubating. When will you consider extubating a baby?
Baby is having a respiratory rate which is normal, that is 30 cycles per minute, and saturation it is maintained at 25% of oxygen, which is almost equivalent to room air oxygen, and PEEP is 5, which is normal minimum.
Yeah, you're right. Actually, so remember 30% is a magic number there. Whenever you need more than 30%, consider surfactant. Whenever on invasive ventilation, if somebody is requiring below 30%, extubate as early as possible to prevent VAP. So here the FiO2 is below 30%. The pressures are minimal. You can consider extubation. So how will we assess extubation readiness? Although there are several scoring or several tests available, the best marker would be FiO2 and the clinical condition. So what do we actually check prior to extubation? What are the factors we need to normalize or optimize before extubating? Yeah, you're right. The baby's breathing drive should be good. What else? The baby should be? Blood gas should be normal. Yeah, blood gas should be normal, which would indicate that the disease condition is improving. So second would be the disease condition should be normalizing or improving. What else? Actually, Cochrane actually has forbidden usage of ET-CPAP in newborns because the resistance is more. So ET-CPAP is only restricted primarily now for research studies. For clinical practice, I think in a newborns, ET-CPAP is not a good tool to assess extubation. So off inotropes, normal hemodynamic status, chest. So probably chest X-ray not showing any collapse or air leak. There's no need to do routine X-ray. Remember that if there was a collapse or if there was an air leak, that should have got corrected. So the primary things is the disease condition should have improved. The baby should be hemodynamically stable. Metabolic parameters should be normal. So the calcium, sugar should be fine. The baby should not have any hemodynamically significant PDA. So if there is a collapse on pneumothorax, that should have got corrected. You had something. Okay. So we assess that. So now for extubation, what is the best mode? Should we extubate this baby to CPAP or NIMV or HFNC? Because the speakers after me will be speaking on NIMV and HFNC. So Dr. Srinath feels HFNC is a better one. Let's look at the evidence. So this is a slide from Cochrane 2017, the evidence table, which actually compares CPAP versus NIMV. Just concentrate on these two rows. This is a respiratory failure in the first 72 hours. This is reintubation within first 1 week. So it is clear from this slide that the risk ratio NIPPV versus CPAP, NIPPV, there is 30% less risk of reintubation within 3 days. RR is 0.76, that is 24% less risk endotracheal reintubation during the first week. So NIPPV, it clearly shows from approximately 8 studies that so it prevents reintubation, especially within the first 1 week. So we have a moderate quality of evidence saying that NIPPV is better than CPAP to prevent extubation failures. So somebody mentioned about HFNC as well. So let's clear that as well. So from the Cochrane 2016 forest plot, so I think before 2016 we had only forest plots. After 2016, I think Cochrane has come up with evidence tables. So in the forest plot, the left one is the HFNC, right one is the CPAP. So you can see the diamond. So below 28 weeks, it is touching the line of no effect. In 28 to 32 weeks, it is favoring HFNC. More than 32 weeks, again, it is touching the line of no effect. So if you see overall, the diamond actually touches the line of no effect, meaning you extubate the baby to CPAP or HFNC, the effect is going to be similar with respect to post-extubation. So if you are extubating to CPAP, you can definitely do. If you have a HFNC device, you can definitely do. But if you have a NIMV, especially for a 28-weeker or a less than 1 kg, you can prefer NIV over others. So coming back to the index case, the baby was extubated to CPAP with PEEP of 5 centimeter, flow of 5 liters. FiO2 we started at 30% because baby required 25% FiO2 on SIMV. So the child is comfortable with normal breathing, no retractions, saturation is fine. We did a post-extubation blood gas. So the blood gas seems to be showing very mild acidosis, which can be normal for this 30-weeker as well. So what nursing instruction would you give the nurse now the baby has been extubated? What would you advise them? Because steroids are not safe for baby's brain development. So generally avoid here for a short duration intubation. If you want to give, you can consider, but it depends from unit to unit. Steroids, what else? We need to continue monitoring respiration because we are anticipating collapse or CPAP failure. So 6 hours later, the newborn was found to have increased work of breathing with intercostal retractions. Now the FiO2 has gone up to 50%. The PEEP we have increased to 6 centimeter. 2 hours later, the respiratory distress is still persisting. The baby now requires FiO2 of 40%. Once increasing the PEEP, our FiO2 has fallen down. Silverman score is 5. This is our blood gas. It shows respiratory acidosis. So what has gone wrong here? We extubated a baby who was fine. tolerated for 1 hour. Now at 6 hours, now the distress is more. What has gone wrong? You're right. So probably would have given feeds and baby would have aspirated, possible. What else? So you're right. Collapse is a definitely an important possibility here. So neonate was continued on CPAP. We did an X-ray. You can see that there is a collapse, right upper lobe collapse. So extensive physiotherapy was initiated. So as your PEEP was at 6, FAO at 40%, remember it was not a CPAP failure criteria. We continued on CPAP. We did not intubate the baby. With good physiotherapy, FAO2 requirement decreased to 25% within the next 24 hours. So we learned about CPAP failure as well as post-extubation. So this is how we could actually prevent intubation. So the message here is that we need to start delivery room CPAP early, prevent mechanical ventilation as much as possible, give early rescue surfactant. Even in post-extubation, I think NIMV is superior, but if you don't have NIMV, don't worry, you can still continue with CPAP or HFNC. So this is the last slide. So if you have to, this is a driver diagram from one of the studies. If you have to increase CPAP success rate in your unit, you need to first reduce mechanical ventilation in the first 72 hours. You should have a plan for air leak in the unit. You should have a plan for nasal injuries. So if these are the outcomes, so what are all the drivers for this? We need to use early CPAP. To use early CPAP, you need to have a logistics to use CPAP in the delivery room. Fix a TP resuscitator in your delivery room if you have decided to give delivery room CPAP. So make a unit policy when to intubate, when to extubate. So you need to have a unit policy for CPAP. So you need to provide early rescue surfactant by Ensure. So thereby you can obviate the need for mechanical ventilation. Regarding air leak, if you are delivering PEEP of 6 to 7, if you have a good monitoring, if you have optimized the flow, chances are less, but you should be able to identify high-risk infants with an early X-ray or preferably with a cold light. Regarding nasal injuries, you need to develop CPAP maintenance bundles. As Anil mentioned earlier, if you have a nasal mask, injury will be less. If you have Ram's cannula, injury will be less. Probably with Hudson prongs, you need to be cautious with the nasal interface care, and we need to improve supportive care on CPAP, the monitoring on CPAP to prevent nasal injuries. So if you're able to do this, you're able to reduce the CPAP failure rates in your unit. So thank you. Any questions? Any questions or doubts so far? So if there are no questions or doubts, I think we'll move on to the next session for the day. So the next session is by Vinod sir. Vinod sir, are you there?
Yes, sir. I'm available, sir.
You're able to see the screen, sir?
Yes, sir. Yes, sir. I can see, sir.
Want to share the screen or you want us to play from here?
No, I will share the screen, sir.
Sure. You can share the screen. So Dr. Vinod has done his DNB from Coimbatore. Share my slide open. So Dr. Vinod actually currently is working at Rio Maternity and Children's Hospital, Madurai. He has done his MBBS from Tirunelveli Medical College. He has done his DNB Pediatrics from Coimbatore. And he has also completed his fellowship in neonatology. So his special interests are in preterm nutrition, neonatal resuscitation, high-risk follow-up. I think as we go through his slides, you will find that he has interest in NIV as well. So over to you, Vinod, sir. Sir, you can share your screen.
Yes, sir. Sorry, sir. I have some problem in sharing. Can you share from that, sir?
Sure, sir. Sure. We'll be able to share. Dr. Vinod is going to take us through what is the supportive care of a baby on CPAP, which is most important for us to prevent CPAP failures. Over to you, Vinod, sir.
Thank you so much, sir. Thank you for the introduction. I'm Dr. Vinod, consultant from Leo Children's Hospital, Madurai. First of all, I would like to thank Karnataka State Chapter, NNF Chapter, South Neonatal organizing team, as well as the NIB ventilation team for providing me this opportunity. So in the next 10 to 15 minutes, I'm going to present regarding the supportive care, what we are supposed to give for a baby who is on CPAP. So in the next 10-15 minutes, I'll be discussing about the various components. One is the ongoing assessment. That is the support what we are supposed to give for a baby by continuous assessment. Not only baby, the interface, the CPAP device or the system, everything we need to assess. Then the respiratory monitoring. So far, it has been excellently discussed, and it makes my job easy. I'll just show what are the things we need to see in the bedside, and we need to act accordingly. Then the nutritional support, what we are supposed to give, not only for any baby, especially for the babies in CPAP, we need to provide proper nutrition so that the outcome becomes very good. Next, please. So finally, some take-home messages. So coming to online assessment, ongoing assessment, we need to continuously monitor the baby, the interface, what we are using, and the CPAP device. So based on these things, we need to intervene and give proper support for the baby. Next slide, please. So once the baby is on CPAP, general care we usually give. Okay, first look at the appearance of the baby. The baby should be comfortable on CPAP. The color and perfusion we need to look at. Okay, so if the baby is comfortable, that is, we are ventilating properly, the baby will be comfortable. So obviously, when the lungs are properly ventilated, the perfusion gets corrected. So look for the comfort of the baby, look for the color as well as perfusion. Vitals, you're supposed to monitor every 2 to 4 hours, at least twice during each shift. Okay, monitor temperature, heart rate, respiratory rate, saturation, as well as BP. Not only monitor, you record and document everything, because a slight change during a few hours can say that the child is going on for some distress or the baby is going on from complications or something. So all these things we can make up by properly monitoring the vital signs. Then cardiovascular system, look for the pulse volume, capillary refill time, urine output. All these things have to be documented, which clearly shows the volume status of the baby. If the baby is comfortable, then obviously the activity, tone, reflexes should be normal. So baby should be comfortable and the ventilation should be proper for all these things to happen. Most important thing is insertion of orogastric tube. When the baby is started on CPAP, immediately insert the orogastric tube and check the position, because CPAP belly should be avoided. The abdominal distension when we get because of the air that gets inflated into the stomach will further worsen the respiratory distress by compressing the lung or the chest wall, chest cavity. So always insert the orogastric tube and see to that the air doesn't compress or it doesn't distend the abdominal cavity. Next slide, please. So coming to airway monitoring, so always look for the secretions in nose and mouth. That is, every 3 to 6 hours, you need to assess whether there are secretions. The main thing is the secretion should not obstruct the airway, because it definitely prevents the proper delivery of the PEEP or the proper functioning or efficacy of the CPAP during CPAP ventilation. Okay, so suction is given only when there are secretions that obstruct the airway. Don't go for routine suctioning. This will agitate the baby, and so there will not be any proper synchronization, proper ventilation. So give suction only where there are obstructions or when there are obstruction because of secretion in the nose or mouth. So because of the flow of air, the nares may dry. So in such a case, you can moisten the nares with using normal saline or distilled water, whichever is comfortable. Next slide, please. So positioning. So any position can be advised, whether the baby can be in a supine position or prone position, or the baby can be in a sidewise lateral position. When in comfortable position, keep the baby and keep changing the position every 3 to 6 hours, at least once during each shift. Okay, support the baby with towel rolls or shoulder rolls or whatever it is, and keep the baby calm and comfortable. Avoid excessive flexion, excessive extension, or rotation of the neck. All these things will prevent the proper delivery of PEEP with the CPAP. Okay, everything will obstruct the airway. Next slide, please. So of late, we are just concentrating more on development supportive care. For this baby also, for these babies who are on CPAP, a proper and a good environment should be given for the baby, so that not only short-term, long-term outcome should also be good. The NICU, in the NICU, we should maintain optimal sound and light. Sound not more than 45 decibel and light should be somewhere below 646 lux units. Okay, so avoid over light and over noise inside the NICU. This will agitate the baby. Preterm babies may go for pulmonary hypertension or bleed inside. So and the next comes nesting and swaddling. So provide proper nesting for the baby. The baby should mimic the position inside the uterus, inside the mother's uterus. So mimic the intrauterine position of the baby and keep the baby comfortable. So coming to pain and pain management, we should always be preventing the pain rather than managing after the baby experiences pain. Because once the baby gets pain, it's definitely going to cause discomfort for the baby, which is going to affect the proper ventilation, obviously. So as the need for blood gases, it has been already explained, there is no specific role for blood gas to do again and again in case of a baby on CPAP. So avoid doing unnecessary blood gases or unnecessary pricking and have a proper handling for the baby. Previous slide, please. Sir. Yeah, last one is mother to baby interaction. So keep the baby comfortable. Always ensure the baby has if the baby is clinically and hemodynamically stable, keep the baby over the skin to skin contact with the mother, or you can give KMC with the CPAP intact. So all these things to be taken care of to have a better outcome actually. Next slide, please. So coming to the assessment of interface. So regarding interface, we got a lot of discussion so far. In our unit, we use nasal mask as the interface. We are so comfortable with that. Nasal injury is very, very less. Obviously, I accept that the malposition is almost commonly occurring with the nasal mask when compared to prongs. But that can be, we can easily train the staffs and we can easily assess, and frequent assessment and observation can relatively bring the chances of malposition much. Next slide, please. So what are the things we should watch for when you are assessing the interface? First thing is whether we use prongs or mask, see to that whether it is snugly fitting in the nares. Okay, then only the what we are delivering, what we are desiring will be delivered to the baby without any problem. Symmetry of the nares, if the mask or prongs are properly fit, then the nares should be symmetrical. Look for blanching of the skin as well as the skin breakdown. Blanching of the skin denotes that there is some compression and the blood circulation is compromised somewhere. And the skin breakdown is also because of nasal injury, which should not happen, because when the skin breaks down, especially in case of preterm babies, it acts as a portal of entry for infection. The infection is more common when the skin breaks down. And the most important thing is when you are using the prongs, see to that there is a proper gap between the columella and the prongs. Sorry, it's not nares, some type of mistake. The gap should be maintained between the columella and prongs to avoid the nasal septal injury. Next slide, please. So coming to other things, what we are supposed to look for is appropriately placed cap. The cap should be ideally placed, like the pictures what we have shown earlier, and also the thing what we showed you earlier. So the cap should be properly placed, ears should be covered, it should snugly fit. The one thing we are supposed to concentrate more regarding this is the nasal interface what we are using, it get attached to the cap where what we are fixing. So only if the cap is positioned properly, we can have a proper seal or proper fitting of the nasal interface. So twisting of nasal interface should not occur when we keep all these things properly and we monitor properly. Then comes a compression. Look for compression. There should not be any compromise in the circulation. Areas of pressure and excoration should be looked for. All these things should be, the interface assessment should be done at least once during each shift and should be monitored and should be documented. Okay. Next slide, please. So this is a nasal injury score for the babies who are on CPAP. Here we are taking into account the tip of nose, the nasal septum, nostrils, shape of the nose, bridge of the nose, upper lip. So all these things have been scored based on the severity and based on the things involved here, based on this chart, and the severity has been assessed. So if it is more severe, we need to act immediately. Next slide, please. So assessment, next comes the assessment of the CPAP device or the CPAP machine. So what are things we need to monitor when the baby is on CPAP? So we have started the baby on CPAP. We have set the pressure, flow, and FiO2, everything. So all these things should be monitored and recorded. The pressure that has been delivered for the baby, the flow rate, what we have kept, and also the FiO2 requirement for the baby. If any, why we need to assess all these things? If there is an increase in the pressure requirement or the FiO2 requirement at any point of time, that can be easily picked up earlier, so that we need to be prepared for assessing the baby and also act accordingly. So, and then comes to the bubbling chamber. So bubbling chamber, we all know the whatever the pressure we set, that is a PEEP that is delivered, will be reflected in the bubble chamber. The level we set the pressure in the bubble chamber. So the water level and the bubbling should be always checked and recorded. So if there is only proper bubbling, then it is sure that then we can ensure that the proper, that is the desired PEEP has been delivered to the baby, and it's reflected in the bubbling chamber. Next slide, please. So the most important part is humidification. So the humidifying chamber that has been depicted in this picture. So in the humidifying chamber, always set the temperature to 37 degrees Celsius. See to that the gas, that is the flow, what we are giving, the air, what the blended air and oxygen, what we are giving, should be properly humidified as well as heated. So the temperature should be set at 37 degrees Celsius. Water level in the chamber should be checked appropriately. Okay, so the water level should not go down. This is a common mistake what everyone used to do. Failing to check the water level in the humidifier. So water level should be checked and it should be maintained. No condensation in the inspiratory limb, and to some extent of condensation in the expiratory limb. It shows there is a proper humidification that is going on in the circuit. Next slide, please. So coming to respiratory monitoring. So regarding respiratory monitoring, a lot of things we have discussed so far. The basic principle behind this respiratory monitoring is to assess the efficacy of CPAP, whether we are adequately delivering the CPAP, whether the baby is adequately getting the pressure, FiO2, all these things we can monitor. And one more important thing is early identification of the respiratory complications. Next slide, please. So much has been talked about the Silverman-Anderson score, about the down scoring and all those things, SOFI index, all those things we have been discussing so far. So what we usually use is the Silverman-Anderson score, using the retractions that happen in the upper chest, lower chest, xiphoid retractions, nares dilatation, as well as the expiratory current. So based on these things, we are assessing the severity and also the response to the CPAP. So if there is an increase in retractions, that means that the baby is going in for some complication, or the baby is going for some worsening on CPAP. Okay. Next slide, please. So this monitoring with the Silverman scoring has to be done at least once in every shift, at least 4 to 6 hours, every 4 to 6 hours. And we need to monitor the score and we need to track it down. So in respiratory monitoring, in respiratory monitoring, what are the things we should focus on? The respiratory rate, respiratory effort, and respiratory pattern. If everything is okay, if the baby is properly ventilated and the desired PEEP is given and the alveoli are functioning normally, then the baby should be comfortable. So if there is any change here, then it should act as an alarm for us. Okay, so if the baby develops grunt or retractions, then it says that either the pressure is not sufficient or the baby is going on for complications. So look for the air entry, chest movement, as well as the breath sounds. So all these things should be documented. If the air entry is not equal on both the sides, because the commonest complication what we encounter in a baby on CPAP is air leak. Okay, so if the air entry is not equal on either sides, if the chest movement is asymmetrical or the breath sounds are diminished or unequal, then we should suspect. In such a case, we need to go for imaging, that is X-ray. Next slide, please. So coming to the last part, we have the nutritional support. So nutritional support has to be given properly and adequately for all the babies. First, usually we are dealing with this preterm, premature babies. So start the baby on parental nutrition whenever the baby gets admitted, when the baby has been started on CPAP. So total parental nutrition depends upon the maturity as well as the weight of the baby, and also the condition of the baby. So always aggressive enteral nutrition, early aggressive enteral nutrition is recommended. So start the baby on feeds, increase the feed volume by 20 to 30 ml per kg per day. That is, go on at a faster, rapid increase. Okay. So once the baby has reached 100 ml per kg per day, it's better to stop parental support of the parental nutrition and go for full enteral nutrition. So once a baby goes for 120 ml per kg or 150 ml per kg, add human milk fortifier as required, depending upon the maturity of the baby. So nutrition support should be ideally provided for the baby on CPAP. Next slide, please, sir. So the key messages are, what are the essential components of the supportive care? That is monitoring the neonate, not only monitoring the neonate or the baby on CPAP, we should monitor the CPAP device as well as the interface. Next slide, please. So the respiratory monitoring becomes the key here when we are dealing a baby with on CPAP. So it helps us to assess the efficacy of CPAP delivery, and also it helps us to assess the condition of the baby, because if the baby is going for complication, we can pick it up earlier. And finally, proper nutritional support, feeding a baby on CPAP and administering or providing proper orogastric tube. All these things will improve the overall efficacy of the baby on CPAP as well as the long-term outcome. Thank you for your patient hearing, sir. Thank you so much.
Thank you, Vinod sir, for summarizing the supportive care. It's not just the baby, we need to monitor the system as well as the interface. So thanks for summarizing the importance of developmentally supportive care as well as the early aggressive enteral nutrition, because we generally forget about both the things when baby is sick. So any questions to Dr. Vinod? Any questions? So there are no questions sir, at the moment. Thank you, Vinod sir.
Thank you so much, sir. Thank you for the opportunity. Thank you.
Our next speaker is Dr. Venkatesh. So Dr. Venkatesh actually is going to take us through CPAP nasal trauma. What are nasal injuries we see while babies on CPAP or NIV? How do we monitor? How do we grade? And how do we prevent it? Dr. Venkatesh actually is done his MBBS from Kilpauk Medical College, Chennai. Did his MD from Madras Medical College, Chennai. He did his DNB neonatology from Vijaya Hospital, Chennai. He has around 20 publications to his credit. So Venkatesh sir, are you there?
Yes, sir. Yes, sir. Yes, sir.
Can you share the screen or can you?
Yeah, you can operate, sir. Sir, are you audible?
Oh, sir, you are audible.
Yes, sir. But the screen is not full here. 1 second, sir.
Sir, are you able to see the screen?
Yes, sir. Yes, sir. I am able to see. Good afternoon, sir.
Oh, sir. It's over to you.
Yes, sir. I can proceed, sir.
Sure, sir. You can proceed.
Yes, sir. Good afternoon, everybody. It's my privilege to talk in South Neocon 2021. First of all, I thank the Karnataka State Chapter to give this opportunity for this. My topic is the CPAP injury and complications. But the previous speakers, everybody has spoken everything in depth regarding all the physiology and interfaces, everything in and out. The thing is, the CPAP injury and complication is a very narrow one. We are doing everyone with the bubble CPAP only. Most of the units are concentrating on bubble CPAP only. Dr. Anil has spoken about all other interfaces and all other modes. So I want to highlight that also before this bubble CPAP. Next slide, sir. So before that, sorry for that overlapping of the number. So these are the 4 or 6 modes are currently used throughout the world for non-invasive ventilation. Among that, we are talking today about only the CPAP and the complications alone. But the thing is, so the complications and the injury to the lung are mainly depends upon a lot of factors. We cannot come to one conclusion with one thing and certain things alone to define this will, if you do this, we can prevent all the complications like that. So it has got a lot of factors. For example, the gestational age is very, very important at the time of delivery. And maternal history is also very important, and weight of the baby, and sometimes what is the pathophysiology of the lung. So mostly we are delivering with the respiratory distress syndrome. Apart from that, the maternal history with some other complications from the mother side, sometimes autoimmune disease. These are all will have an impact on the outcome of the lung and also outcome of the babies. So on type of the CPAP machines, whether we are using bubble CPAP or infant flow driver, and sometimes the nasal interfaces, lot of interfaces are there. So in our unit, we are using both mask and also prong, and we have used for 60-70 days without any nasal septal injury also. So it depends, complication usually occurs, it's a multifactorial thing only I will tell. So we have to design our unit and we have to train our staff how, and we have to select all the devices and also the ventilators in the sense bubble CPAP or infant flow driver or ventilator based CPAP, like that. Each and everything we have to decide and select to minimize the CPAP complication. That is my overall experience I have seen so far. So I have ventilated nearly for 123 days for 600-gram baby without with intact brain. The child is going to school. My teacher is Dr. Kumudar ma'am and Dr. Jayam. He used to teach us in 2000s. So from that time, I have used the infant flow driver also. So the thing is, the complication is now it is getting narrowed down only for the bubble CPAP. Next slide, sir. So already Anil has showed everything. So these are just I have put because sometimes it is missed. So I put this photograph. Next slide, sir. Ram's cannula. Now everybody talking about this, about the Ram's cannula also. But only thing is leak is there, but otherwise it gives now lot of evidences. Without nasal septal injuries, lot of babies are coming out in a long-term case basis like that. But in the Indian setup, we have not have any valid data to suggest that this is a better choice for interfaces like that. Next slide, sir. Next slide. So same thing, it is discussed totally by the Dr. Anil. So why I want to put all those slides means without this, I cannot explain the complications. So that is why I put this slide, but a lot of overlapping from one speaker to another speaker. So it's a delivery system is very, very important in preventing the complications. Either the nasal prongs we are using or nasopharyngeal prongs or nasal cannula or nasal mask. But in CPAP, we used to always we are going to use the nasal mask and the nasal prongs only. So we will alternate if any baby is having a prolonged CPAP, like more than 3 weeks like that, we will alternate with nasal prongs with nasal mask. So sometimes if we see any reddening of the nasal septum or columella like that, we will alternate every 4 hours so that it will prevent the progression of the nasal injury. We have quite often see like that because of very 26 week or like that. After around 30 week, we will have this problem. So in that situation, we used to alternate with prongs and mask. We used only the Fisher-Paykel mask and prongs. Next slide, sir. So nasal mask and nasal prongs, we will alternate. Next slide. So second thing, in those days, 2004, 2005, I have used ventilator-based CPAP. On those days, infant flow driver also I have used. In that situation, we have not encountered any sort of lung injury like air leak also. But at the time, I was only a registrar. But so I thought best ventilator. Sometimes if resources is not a problem, we are using a very good ventilator that will have an impact in reducing the complications also. So not only the disease related, mostly whatever things we are using also, it's a major criteria for the complication and lung injury. That is my total experience from my side, but there is no validated data so far. Next slide. So overall complication, we can divide it into the nasal and respiratory and cardiac and GI. So everybody talked about the nasal. So CPAP, in general, we have a respiratory complications, cardiac complication, and GI tract complication. Coming to the nasal, so we got a septal injury, columella injury. Depending upon the interfaces, whatever interfaces we are using, we will get the injury. So the nursing care and frequent monitoring, frequent checking, and a lot of other things I will just tell later. What are all the things to monitor to prevent nasal injury? Coming to the respiratory part, so acute respiratory complications and chronic respiratory complications. So acute always know. So if you use a surfactant, how much pressure is needed at the time of giving surfactant, when to bring down the pressure, and these are all very, very important. These are all related with one case to the another case. So the resident has to be taught and to follow the protocol to reduce the pressure and FiO2 greatly. Otherwise, they will land it with pneumothorax like that. Cardiac only, we will have because of high teeth, they will have cardiac issues. Sometimes, basically, the newborn itself will have a cardiac problem. So apart from seeing lung alone, we should grossly check overall the neonatal condition. About sometimes we have to do the echo and see the SVC, IVC flow, and to look after the volume of the baby. Sometimes because of PEEP, high PEEP, it will produce a cardiac not cardiac problem, it's a transient one. If you come down or if you correct the pressure like that, it will recover. And GI, always we know about CPAP belly. So all CPAP, because of the entering into the intestinal air, it will cause a CPAP belly, and it will produce more of sometimes feed intolerance, and everything we will settle. And overall, the CPAP now is becoming a major alternate to the invasive ventilations. But even in UK and all, they are putting 23-weeker into HFNC non-invasive. That is why non-invasive ventilation is becoming a more sophisticated, not invasive. And compared to invasive, non-invasive will have a long-term complication is very less. And but the other parameters, everything we have to do in a correct way to prevent other complications. Next slide, sir. So this is anatomical marker. So nose has got so many things. So septum, philtrum, columella, tip, and everything. Here we have to concentrate on the philtrum and the septum and the columella. These are all the common injuries we will get because of the nasal interfaces. Next slide. So these are all the various types of nasal injuries. So if you see, so the first picture A shows it's the base of the injury is becoming very red. So usually this will occur in mask. So it will have a pressure on the junction of the root of that columella and the philtrum level. So the second B picture also showing it becomes a deeply ulcerated now. And third picture showing it that columella get a little bit more ulcer and entering into the septum. So this is all three pictures are showing a mask injury, but usually what will happen if you use a prong, it will have a nasal septal injury. Usually on the medial aspect of the both nose, it will have a pressure. So the very important factor in this to prevent all these injuries, we have to select the size of the prongs. So we have to first see the anatomy of the, not anatomy like that, the face of the baby, how, what is the nose. So the selection is very, very important. So each and every baby has to be decided by the little bit experienced person to select. So if you put a common one, then sometimes some baby will have a smaller nose and with angulation like that. So it will cause all this injury, lead to infections also in later. So if you have, so the lot of studies are showing less than 30-week gestations, they are having all this redness. But anyhow, now a lot of other preventive strategies also there, some protective tapes are coming. After putting that, if you put this mask and prongs, we can prevent all these nasal injuries like that. Next slide, sir. Sorry for these things overlapping, I think. So it is only how to prevent the risk factor for the nasal injury. One is the gestational age, I already told, the birth weight of the baby. If birth weight is very, very low, the fitting, what we will tell, the fitting should be around 80%. We have to leave nearly 20% of the nostrils. Then only the pressure will be, but a little bit leak will be there. So if you fit very tightly, then it will cause pressure necrosis. And CPAP interfaces. What are all these CPAP interfaces to select? So we should not go about always mask like that. Sometimes prongs will be the better for that. Short binasal prongs may be better for that kid. So depending upon the kid, we can change mask and prong, and sometimes no. If it's a bigger baby, we can go for a snip type of ventilation also with nasopharyngeal prongs. So our aim is to shorten the duration of the ventilation period, and the critical thing is nursing care and monitoring and shortening the duration of ventilation. It will prevent all the complications. And the skin, the mucous membrane and cartilages to be monitored carefully. Next slide, sir. So these are all the pictures taken from the other presentation. So irritation, that is, if you see that columnar area is totally changed, the shape of the nose will be, sometimes it will be a permanent one. So a lot of babies I have seen with one nostril will be very big and another nostril will be small, and that tip of the nose will be a little bit different. And sometimes the nasal columnar, it will go in depth sometimes. So these are all cosmetic things, but it can be prevented by careful monitoring. Next, sir. So another one, same, you can see the indent in this. These are all nasal, very common injury is nasal injury. If you compare with the lung injury, the nasal injury is more than the lung injury, I think so. Next, sir. So this is a septal damage, totally septum is gone. So the monitoring is very, very important. So every day twice or at least once a day, we have to check the nasal area if the baby is on CPAP. So to prevent all these problems, if you are finding anything red, so last Dr. Vinod has put one column. I am also going to do the same thing. So you have to grade according to that. We have to have act very fast to prevent all these problems. Next slide. Next slide, sir. The same thing, different picture. Next slide, sir. So this is these are also all our different picture. Next slide, sir. So here see the different sizes of the nose, laceration of the alum nasae. So whatever the thing we are using, tegaderm and glioderm, everything, and so we have to take care of the skin is very, very important in preterm babies. extreme preterm babies. Next slide, sir. So how to prevent all these things I have told in between. So these are all the new things. It is there, but we are not using in our unit. So pasting like that and making the skin a little bit protective like that. But we have not come across any type of injury. We have ventilated with CPAP nearly more than 50-60 days also without any even redness we have seen one or twice. After that, we have not. But we are Fisher Packle is very soft and it's a very good mask and prong. I think so, sir. Next slide. So I have told sir already the how to assess. Assessing the nose is very important. Deciding before the nasal interfaces, the shape, position, whether symmetrical, stretched out, any blanching at the skin at nose, skin breakdown, septum position straight. Sometimes the septum position will not be straight. In that situation, if you put prongs and it will cause septal injury. Next slide, sir. So this has been put already by Dr. Vinod. So every day we have to look at the tip of the nose, nasal septum, nostrils, nose shape, and we have to grade whether there is an injury, mild injury, moderate or severe injury like that. And depending upon that, we have to act. Next slide, sir. So other parameters causing all this problem, whether the cap appropriately placed, sometimes cap, if it is not appropriately placed, it will move. So it will shake the interfaces, it will cause problem. If the nasal interface component is twisted, prong size and tip of the nose. So the cap, whether it is correctly fitted is one of the thing. Another is excessive movement of the baby also causes all these injuries. So mostly I'm talking about the injury related with the nose. That is very common thing. Everybody will be complaining. But overall, the lung injury, whatever we are seeing is very less. Because we used to put for bigger baby SNP, not a bubble CPAP like that. We will go for SNP and we will have a controlled ventilation, non-invasive ventilation, bubble CPAP and infant flow driver for the younger thing. So we are not encountered even a single air leaks for the last 5 to 6 years, I think so. And we are using sometimes SLE 6000 CPAP mode and sometimes bubble CPAP for the younger gestational age. Next slide, sir. So we have to select the correct prong size, and sometimes lubrication is important. Nasal prongs and blanching of the skin occurs, we have to see, and massaging the nasal septum and minimize the point of contact. Always sometimes keep dry and clean. And so avoid using unnecessary topical applications. This sometimes it will prevent the nasal injuries. Next slide, sir. So I have already told some gap. It will be better, but it will have a leak little bit. But depending upon the clinical criteria, we will adjust the pressure and monitor all other system according to that. And the cap and the tube, the position, it should be in correct place, and excessive movements. Sometimes baby should be swaddled to avoid the excessive movement of the baby. So movement of the baby also sometimes it will have a problem in dislodgement of the prongs and mask and causing all those things. And it will have a impact on the seal of the mask also. So these are all the little things we have to train our unit staff nurses. They have to look after 24/7. Then only we can prevent everything. So we cannot stand all the time. most of the units in our units, we will train periodically regarding all those things to prevent all those injuries. Next slide, sir. So other complication I have told, so these are we are seeing very less actually, because we are not seeing more bigger baby with the respiratory distress on bubble CPAP. So because of maternal monitoring, we are came down in having meconium or DS meconium aspiration. For that, sometimes initially we will start on those days we will start on non-invasive ventilation, then we will switch over to invasive ventilation because of CPAP failure, like that. In that situation, air leak, everything, it will go. Now it is very less incidents. It's only observation data I'm talking about that. So air leaks, and sometimes BPD we are seeing for long, more than 6 weeks, sometimes more, 26 weeks or 27 weeks, up to 34, 35 weeks, we will have a CPAP sometimes. They will have a chronic lung injuries. So very rarely PIV. Otherwise, pulmonary complications with CPAP. So immediate after surfactant administration, we should come down the pressure or FiO2 as quick as possible to avoid air leak. That is the thing I want to tell. And the cardiovascular system, because of high PEEP, decreased venous return and cardiac output. So apart from that, we have to check whether child is having other systemic problem, having a cardiovascular disorder like that by doing functional echoes. Next slide, sir. So everyone knows CPAP belly is the complication from the gastro side. So feed intolerance is a very common thing. So what we will do, repeated aspirations of the air, and sometimes before feed, we will aspirate the air. So OG insertion and in place, we will confirm all the time for all NIVs and CPAP babies. So to prevent CPAP belly, so the best thing is OG should be in situ. And in neurological complication, raise the intracranial pressure. If you are going for a high PEEP, high CO2, so definitely they will have a more having a raised intracranial pressure, and in turn it will produce decreased cerebral perfusion. Sometimes it will have a neurological dysfunction because of that. So regular ABG monitoring and clinical monitoring is very important. So we cannot go about only with saturations to increasing the PEEP. So we have to see other system also to avoid all these. These are all complication. If we have to if we can avoid, if we see the baby in total. But everybody we are doing, but apart from that, sometimes it may happen. So we have a eye on that. Next slide, sir. So same thing, prevention, it's gastric tube. Next slide, sir. So gastric distension. So OG tube in situ. Next slide, sir. Same thing I have told to prevent. So every 2 to 4 hours, we will aspirate the excess air. So depending upon the gestational age, we will put a orogastric tube and lift the indwelling to allow for the continuous air renewal. Next slide, sir. So same thing only, sir. Next slide. So the thing is, we have to sensitize the nursing team about the alarms and babies on CPAP. So what they have to look after, when to take a call for that alarm. These are all very important. So if any desaturations or any other changes is there, So the alarm system, they have to be very, they have to call unit protocol to have a look on that. So we just for desaturation, they should not increase the FiO2 like that. Sometimes and this may happen in our unit itself, but the thing is, alarm should be attended appropriately. Next slide, sir. So same thing, only it's getting repeated. So sorry for slide. So I have sent in a correct position. It has changed somehow. Next slide, sir. Almost it is over. The say nursing care I have told in between. So we have to teach about the nursing care for a CPAP baby, how to have a good seal and a close assessment, and electronic monitoring and blood gases monitoring, and prevention of abdominal distension, and monitoring and yearly reporting of the complication of NIV. But this complication as a only CPAP we are talking about, it's a big classification. So that is why I am just concentrating in what I, not in a specific way, like theory. So if I compare pneumothorax with mask and the prongs literature like that, it will have a big topic. So that is why I have not quoted any scientific data regarding this. Because of workshop, I am just enlightening what are all the things we have to look at. So next slide, sir. So the important points, if you are using a cannula or mask, everything 14 days as per hospital protocol. So ensure the orogastric tube is in situ. Prongs should be snugly fit but not blank. Allow small gap between patients. Cannula kit is for single use only.
शिकलेल्यान दिसना पुरा दिसता शिवता हे अँगल आता किती दिसना कित्याक म्हाका पुरा काढला ते पळय येऊन पळय दोन्ही.
Next slide, sir. Thank you. Sir, are you audible?
Huh, sir, you're audible.
Next slide, sir. I think it's over. I think so, sir. So, any other questions I can take? Hello, sir. Are you audible?
You're audible, sir.
Yes, sir.
No questions or doubts from the delegate, sir.
Okay, okay.
Thank you, Venkatesh, sir, for joining us from Chennai. Thank you, sir.
Yes.
So our next speaker is Dr. Manisha. So Dr. Manisha is a consultant neonatologist at Ovam Hospital, Banashankari. So she'll be talking or taking us through triple HFNC, that is heated high flow humidified nasal cannula. So Dr. Manisha, have you joined? Can you switch on your video?
Abhishek, can I share my screen so that I'll have a...
Dr. Manisha?
Yes.
Yeah, you can start your this one. Over to you, Manisha.
Yeah. Am I audible, Abhishek? Abhishek, am I audible?
No, you're audible. You can start.
Yeah. Good morning, everyone. Actually, good afternoon. Yeah, this is Dr. Manisha. Sorry for joining virtually. Couldn't come to Hoskote this time. I'm a pediatrician and a neonatologist working at Ovam Banashankari branch. So today in the list of non-invasive ventilation workshop, the next talk is on HHH-FNC. So it is heated, humidified and high flow nasal cannula. So it's a very good link between the CPAP and the nasal cannula. So it stands in between the CPAP and the nasal cannula. So before we start the talk, what is this non-invasive respiratory support? So it's a part of the non-invasive respiratory support. So any mode of the assisted ventilation, which tries to deliver the positive pressure throughout the respiratory cycle without the presence of endotracheal tube. So without any invasive ventilation. So more and more from last about 10-15 years, we've been shifting or transitioning from the invasive respiration to the non-invasive support. And HHFNC is found to be a very good link, though may not be as good as CPAP in some cases, but maybe as good as CPAP in some cases, as we'll discuss in the further presentation. At the outset, I would also like to thank the organizers and the committee members to give me an opportunity to be a part of this workshop and a South Neocon conference. So as we all know, and as Dr. Venkatesh and Dr. Abhishek, everybody has been through the previous presentations on the nasal bubble CPAP. So the CPAP is the one which gives the delivered pressure, the positive and expiratory pressure to the newborns by non-invasive method. So this is the nasal bubble CPAP which first came in the picture. But we all also had seen that with CPAP, the complications were more in terms of pneumothorax or the desiccation of the nasal tissues, causing a little bit of nasal trauma. So when such things happened between the nasal cannula and the CPAP, the HFNC came in a picture. So with nasal cannula, we couldn't give any positive end expiratory pressure, and it was only the oxygen which increased the retinopathy of prematurity risk. And with CPAP, there were complications like the CPAP belly or pneumothorax, or when the CPAP was required for a little longer time, the nasal trauma, which was not very friendly with the nurses and also for the parents to see that for a long-term CPAP. So HFNC came as more user-friendly option in this case. So then that's when the alternative came as a heated, humidified, high-flow nasal cannula, which bridged the gap between the nasal cannula oxygen and the CPAP, and was more parent friendly, was more user friendly, and it is also delivering the peak inspiratory flow pressure almost or equivalent to the CPAP. So before I start my talk, we are going to discuss in these terms the need for HFNC, the mechanism by which the HFNC works, what are the different devices like the Fisher and Paykel and the Vapotherm, what is the evidence between the nasal CPAP and the HFNC in terms of managing the respiratory distress syndrome, apnea of prematurity or post-extubation, what are the recommendations for starting and what are the clinical guidelines in terms of how to start the CPAP, HFNC, how to wean it, when to escalate it, what are the complications expected, and what are the contraindications when you will not use HFNC. There will be a summary and the take-home messages at the end of this session. So let us start the talk. So what is HFNC? It is the heated, humidified, high-flow nasal cannula. So it gives a warm, which is about 37 degrees, humidified oxygen, which gives a relative humidity of about 100%, a blended gas between 21 to 100%. The gas flow starts from 0.5 liters till 25 liters, and there are some machines which give up to 60 liters per minute. But in neonates, we use it between 2 to 8 liters per minute. That is where I restrict my talk to 2 to 8 liters per minute. We use small binasal prongs as comparable with the CPAP. These are small prongs, and this is more nurses friendly. This is more parent friendly for the parents to see the baby on HFNC. So the mechanism of action. So how does HFNC work on comparable with CPAP? So these are the principles by which it works: the flow effect, the pressure effect, and the conditioning effect. So if you see this image, you can see the anatomical dead space. So the anatomical dead space is about 60% where there is no gas exchange happens. It's only the conducting airway which starts from nose, the nasopharynx, as you can see here. Then there is larynx, there is trachea, and first generation of bronchi. So where the actual gas exchange do not take place. And there, this gas which remains there, what we have seen that with HHFNC, there will be a continuous flow of the gases, which is given to the baby. So that causes this flushing of this anatomical dead space and improves the oxygen. Let me be more elaborate. See, when a baby inspires a gas, let's take it, it is 21% oxygen. If in the anatomical dead space, when this inspired gas is taken by the baby, there will be some amount of the exhaled gas from the previous cycle of the inspiration, which remains there in the anatomical dead space. So actually, even if the baby takes about 21% of oxygen, when it mixes with the exhaled gas, which is already present in this anatomical dead space, the concentration of oxygen decreases to about 15 to 16%. And the CO2, which is there in the inspired gas, which is only about 0.3%, increases to about 5 to 6%. So it's an oxygen deplete and CO2 replete gas when the baby breathes through the anatomical dead space. But when you give a HFNC, there'll be continuous flushing and washout of this anatomical dead space. And that's why there'll be improved oxygenation, because there will be rebreathing of high CO2, which is there in the dead space, is prevented. And there'll be always a reservoir of the fresh gas in the upper airway, which contains the oxygen, which has been there from the blended gas. So this is the primary mechanism by which the HHFNC acts. So it also is known to prevent the obstructive apneas, because it kind of causes a stenting between the upper airway. It helps in the CO2 washout, and it entrains the fresh air. It locks the fresh air which containing oxygen by flushing out the dead space air. It has also been found that even if there is a higher leak, even the leak contains the oxygen, and that's why the oxygenation is also improved. Even if we consider there is a higher leak, which is also one of the complications, or we say a side effect of the HFNC, but still it improves the oxygenation. The second thing is the pressure effect, how the HHFNC acts. So what is the pressure effect? The positive end expiratory pressure, the distending pressure on the alveoli, which makes the alveoli open up and keeps them open, as we see in CPAP. The pressure are more consistent with CPAP. HFNC may not have that much specific pressures, but it will be highly dependent on the prongs to nair diameter ratio and a degree of a mouth closure. So what is the prongs to nairs ratio? What we've seen is that the HFNC prongs have to be less than 50% of the diameter ratio. If it's very snugly fit, the amount of pressure which is given to the baby can be a little high. So there'll be little variability in the positive pressure, distending pressure, which can be given by HFNC, and also degree of mouth closure. It also minimizes the inspiratory resistance depending on the Poiseuille's principle. We have seen that the resistance, it decreases, the flow, it increases, and that's why the pressure, it increases. On the positive inspiratory flow, it tries to manage the baby's inspiratory flow and tries to give the positive distending pressure. By this mechanism also improves the pulmonary mechanics, because we keep the alveoli open, and that is when it is also going to help improving the functional residual capacity. Because of that, even the surfactant production is going to be more, and lung mechanics is going to be improved. So that is how the HFNC acts. So you can see here the prongs to nasal ratio. So the outer cover is seen. This is the nares. This is the nares, and this is the prongs. The diameter between the internal nares and the prongs, this should be less than
50% or equal to 50%, but not more than 50%. There should be some amount of leak, or there should be a space in between the nares to prongs. It should not be covering or snugly fitting the nares. Then it may also cause a little bit of desiccation of the nasal tissue and nasal trauma, and can increase the positive distending pressure. So what we are looking at is the 50% or less than 50% diameter. So, sorry. So HFNC pressure generation is found to be similar or slightly lesser than CPAP. As the pressure increases, if you increase the flow, we generally use till about 6 liters, but there is a possibility we can go up to 8 liters. So if you are going to go up on the flow, the pressure is going to increase. It has also been found that the pressure increases with the decreasing birth weight, with the same amount of oxygen blended, maybe over 50-60%, with the flow of about 6 liters per minute. A baby with 1 kg will have a more positive end expiratory pressure than a baby who is a 3 kg baby. So the pressure which is given by the HFNC depends on the flow, it depends on the birth weight, and it also depends on the prongs to nares ratio. So these 3 things are very, very important to determine the HFNC pressure. So PEEP increased by 0.6 centimeters of water if we increase the HFNC flow by 1 liter. So if the flow is 4 liters, we increase it to 6 liters. The PIP is also going to increase. It's a indirect way to know that what PIP we are giving. So PIP is increased by about 1.2 if you increase the pressure flow by about 2 liters per minute. So PEEP increases by 0.6 centimeters. So it is overall. The second thing is about the humidification. So HFNC, we deliver the air at 37 degrees Celsius. The normal oxygen which comes from the nasal cannula, it's a cold air, maybe about 15-20 degrees, and has absolute no humidity. But when we give a heated, humidified, high flow nasal cannula, we deliver it at 37 degrees and the relative humidity of 100%. So the water vapor content is also high. So why it is important? Because if we do not humidify the gas, and if we provide a cold and a dry air to the babies, it will impair the lung mechanics in terms of surfactant function. It is going to decrease the FRC because the alveoli are not going to expand as much as we expected. It will cause the collapse. It will decrease the mucociliary function and make the baby prone for the nosocomial infection, and it is going to compromise the pulmonary mechanics. So humidification is the most important part, as in CPAP, as in HFNC. So it's a mnemonic we can say about the high flow. So H stands for heated and humidified. I stands for inspiratory demands. F for functional residual capacity. As it increases the functional residual capacity, it is more lighter and easily tolerable, more nurses friendly, more parent friendly than CPAP. It minimizes the oxygen dilution. It always maintains the oxygen flow. And important, as I told you, it washes out the anatomical dead space. And that's why also decreases the obstructive apnea. So it is just a slide which shows whatever we have discussed before. So that is what high flow stands for. So HFNC also decreases the nasal injury and the respiratory distress score. This is one of the study which you can see that the nasal exam score, that is what they have seen at the nasal injury. CPAP is one which is more prone if the babies are on long-term CPAP, like the babies who are less than 800 grammars, we generally tend to give them CPAP for a little longer time. The nasal injury is higher in the babies with CPAP. So you can see the difference. It is about much lesser. So the p-value is less than about 0.005. So it scores better in terms of nasal injury score, and also in the same time decreases the respiratory distress score. So it is improving the pulmonary compliance as well as reducing the nasal injury. So HFNC pressure delivery, this is another study which shows that, that when the mouth is fully closed And when we give a flow of about 6 liters per minute with 60% FiO2, the pressure generation is quite high. Though we do not recommend that mouth should be fully closed and we should, put a jaw thrust. No, we should not do that. Some amount of leak is also going to improve the oxygenation. So this is one of the study which shows that if you close the mouth, it is going to increase the pulmonary, inspiratory distending pressure. So it is important that you have a good prongs to nares ratio, but it is not mandatory, or we shouldn't do the mouth completely closed or a jaw thrust, because then we'll have a variable pressure which is going to the baby, especially the babies who are less than 1 kg. So more the prongs to nares ratio, higher the pressure. To deliver at flow more than 6 liters per minute, generally we go up to 6 liters, maybe about 50% of FiO2, but mouth fully closed will increase the pressure, so we will not recommend that. Birth weight and HFNC, as I discussed, the decreasing birth weight with the same amount of blended oxygen, with the same amount of flow, it is going to increase the HFNC pressures. Comparable, as you have seen, with a 500 grammer and a 2000 grammer, the pressure is going to be more for a 500 grammer and pressure is going to be less for a 2000 grammer. So, factors determining the HFNC pressure, as we discussed, the prongs to nares ratio up to 50%. It should never be more than 80% or snugly fit. We should not close the mouth. We use the same flow. With the closed mouth is going to increase the HFNC pressure. Higher the flow, more the HFNC pressure. Smaller the birth weight, more the HFNC pressure. So it is the unit policy to decide on to start on the pressures. So generally, they start with about 4 to 5 liters of oxygen and FiO2 of about 30% to 40%. It depends upon their discretion to start, depending upon the clinical condition of the baby. So coming to the indications, what are the indications to start with HFNC? So HFNC is still not considered as a primary mode of ventilation for the respiratory distress syndrome. For the babies who are less than 28 weeks or less than 1000 grammars, I'm going to come to that with the studies later. But it is not the primary respiratory distress, primary respiratory support for the babies who are less than 28 weeks and less than 1000 grams. It is used for the babies who are little on a bigger weight with the mild to moderate respiratory distress. It's a very good alternative for the post-extubation support for the more mature infants. So when I say mature infants, we are considering somebody who is more than 30 weeks. It is used for the babies with CLD, yes, with the chronic lung disease, where the dependency on the CPAP or the oxygen is more for more days. So using a CPAP is definitely going to have more problems with the nasal trauma. So we can use a more user-friendly HFNC. Babies who have got nasal trauma from HFNC, we can wean to the CPAP, we can wean to HFNC. It is also used as for the prevention of the apnea of prematurity. So looking at the indication, CLD is the most important because they need a CPAP for a little longer time. So such babies will not have more complications with CPAP. So as an alternative to CPAP, as a weaning from CPAP for the mild to moderate distress for the little mature babies who are more than 30 weeks, as a post-extubation support and for the apnea of prematurity. So let us look at this anatomy of CPAP. So you can see that there is a gas blender here. So this is the one which blends the gas, and you will have from 21 to 100%, which goes to the inspiratory limb to the humidifier, where the gas gets heated and humidified. From there, the expiratory limb comes and it goes to the nasal cannula. So this is an OptiFlow system, which is by the Fisher and Paykel from Auckland, New Zealand. And we also have a Webotham, which is not here. Mostly it is mainly in USA used. So this is what we used for the HFNC. You can also use it using a Y connector. If you do not have a blender, using a Y connector between the air compressor and the oxygen flow meter. And you can have a chart where you can have a connection between the two and determine the percentage of oxygen using a blended gas. So FiO2 can be blended between 21 to 100%. The flow available is 2 to 60. We use it 2 to 8 liters in babies, and temperature between 31 to 37 degrees. This is using a Ram's cannula. In the OptiFlow system, you have a wiggle padded ones, which is attached to the it is actually attached to the cheeks, and it is with the pad, so it is more comfortable for the baby. So that is seen in the Fisher and Paykel one. So with the standard nasal cannula, I have seen the difference between the vapotherm. Generally, vapotherm is not being used here. So let us look at the OptiFlow and the nasal cannula. With nasal cannula, if you give more than 4 liters, there'll be too much of discomfort for the baby. It is not humidified, not warmed in the nasal cannula. But in the OptiFlow, we generally don't go beyond 8 liters, 2 to 6 liters, 100% relative humidity, and the temperature is about 36 to 37%. It's a comparison between the two. This is a Ram's cannula, which is also can be used for giving HFNC. So you have different sizes in the Ram's cannula, and which is color coded. It is also can be used for the micro PMEs, which is less than 750. And this is the diagram which I showed. This is a Ram's cannula, which can be used and attached to the HFNC unit. So that is also readily available. So initiation of the HFNC, so we should start first looking at the baby. We should have a proper prongs to nares ratio, and it should cover only 50% of the nostrils diameter. We should start with the FiO2 of about 40%, and the pulse oximeter is the one to tolerate, titrate, sorry, not tolerate, between the target saturation of 90 to 94%. The humidifier should be set at 36 to 37 degrees, and nursing care should include the monitoring of the Silverman-Anderson score. So they should check the respiratory rate, the retractions, the indrawing, as well as the heart rate. Blood pressure has to be checked to see that the baby is hemodynamically stable or not. Because HFNC can be used in the babies for spontaneously breathing, it is important that the child has to be hemodynamically stable. Babies with shock and hemodynamic instability, we do not put the babies on the HFNC, as well as we do not put these babies on CPAP as well. So 1 to 2 kgs, generally we start with 3 liters per minute, 2 to 3 kgs, 4 liters, and 3 to 4. This is a overall guideline. It changes with unit to unit discretion. They decide, and depending upon the baby's condition, we decide. But overall guideline says that babies with 1 to 2 kg, you start with 3 liters, and maybe you can gradually up it if the baby does not maintain the target saturation. So escalation generally happens in the 1 liter per minute to maximum. We go only till neonates 8 liters per minute, depending upon if the child's Silverman-Anderson score increases in terms of tachypnea or chest recessions. But in case of hemodynamic instability, we may have to stop the HFNC. Weaning, in terms of if the baby is stable on HFNC for at least 12 to 24 hours, we can consider weaning. Generally, first we wean the FiO2 by 10%, like over 24 hours. So baby who is on 40%, maybe once in 6 hours, we can cut down the, depending on titrating the pulse oximeter and the target saturation. And then we decrement the flow rate 1 liter per minute every 12 to 24 hours. It's all guided by the work of breathing, the oxygen requirement, and the overall condition of the baby. Once the flow rate is about 2 liters per minute and maybe less than 30% of FiO2, we can discontinue the HFNC. So let us look at the evidences and the comparison between the HFNC and the nasal CPAP. So these are the studies I have taken after 2016. There are about 5 RCTs, which also has one Indian study from Dr. Srinivas Murthy and Dr. Nandakishore Kabra, where they have used HFNC as a primary support for the respiratory distress in the preterm babies for less than 28 weeks, also till about 34 weeks. So let us look at these studies. So there are about 5 journals we could get. So these are all RCTs and multicentric trials. And these 5 studies, the one is from JAMA, one is from New England Journal of Medicine, one is from Indian Pediatrics. So what does these studies show? So there's a hipster trial, which is very, very famous in the New England Journal of Medicine. So they have taken in consideration babies who are about 28 weeks, and they studied about 534 preterm infants, where they have used HFNC in few babies, used about 6 to 8 liters, and in some babies they've used CPAP with 6 to 8. So it's a randomized control trial. It was a RCT, and they have considered the effect as outcome as a failure within 72 hours, where they have to go in for the mechanical ventilation. So IPSTA trial was stopped in between. It was interimly stopped because the difference between the two was quite high, less than p-value was less than 0.0001. So about 25% of the babies on HFNC failed this, and only about 13% who were on CPAP. If you're able to see that, even the Indian trial, which was shown here, this is the Indian trial, which has also been used in the babies, HFNC, 28 weekers and 1000 grammars. They have also used HFNC. The flow liter is about 5 to 7, and CPAP 5 to 7 centimeters. And here also, if you see the difference, it's quite significant, that 26% of the babies on HFNC failed this, and only 7.9%. So this also was stopped interimly. So this was stopped. These two trials were stopped interimly. The other 3 trials, if you can see, they have taken babies. This is a Korean journal trial. They have taken little mature babies, about 30 to 35 weekers, and that's why we do not see much difference here. And these, even this trial, I've seen only about more than 32 weekers. So more mature infants, the HFNC is tolerated better. The babies with 28 weeks and 1000 grammars, there's a interim, these trials were stopped in between. So CPAP was considered better primary support for these babies. So if I have to give you in nutshell, so if there is a primary support we are considering for babies who are less than 28 weeks and less than 1000 grams, even if you have done Ensure or you have not done Ensure, primary HFNC is not recommended. More than 28 weeks, more than 1000 grammars, if you have done Ensure, maybe it's your unit policy, but still we consider it's no. Post Ensure, CPAP is considered better for them. But HFNC as a secondary support for babies more than 28 weeks and more than 1000 grammars, if you have to wean from IMV, yes, you can consider using HFNC. If you're weaning from CPAP, yes, you can consider IMV, HFNC. But weaning directly from IMV for babies who are again less than 28 weeks or less than 1000 grammars, it is not recommended presently. CPAP is considered to be better. So that is a take-home message, that less than 28 weeks, less than 1000 grammars, Ensure done or not, or directly wean from IMV, CPAP should be still considered as the primary support. So post extubation, there was no much difference in death or CLD they have seen, but they have seen its HFNC in better in post extubation cases, but it lowers the risk of the air leak and the nasal trauma. So this is a RCT where they've taken about 10 trials, and they have seen this is the difference. So post extubation you can still consider, but not for babies less than 28, less than 1000 grammars. And directly from IMV. From CPAP, yes. Bigger babies, yes. Mature babies, yes. More than 32 weeks, yes. HFNC versus CPAP, if you've seen for the nasal trauma, as we have considered, the ratio favors HFNC because you can see the nasal trauma, the extubation failures were better in HFNC as compared to CPAP, because nasal trauma is less. This is more user-friendly, nurses-friendly. But when we have seen the secondary outcomes in terms of air leaks or BPDs or mortality, there is not much difference between the HFNC and the CPAP. The RR value is about 0.7, so there is not much difference. So in terms of BPDs, air leaks, or in-house mortality, CPAP and HFNC, they are almost the same on both levels. Prevention of extubation failure, the pneumothorax is found to be lesser with HFNC than with CPAP. So if you can see the difference and the relative risk, the favors HFNC is in terms of extubation failure, and pneumothorax, it favors the HFNC. So these are all secondary outcomes in terms of favoring HFNC. Duration of the CPAP with HFNC, there's one study which they have seen when the babies have been on CPAP with the same weight, same gestation, and the babies have been HFNC. There's a little difference. If you see, the babies on CPAP have come out faster than the babies on HFNC. It is taking a little longer time than the CPAP. So babies on HFNC are requiring a little longer time to come out of weaning as compared to CPAP. So CPAP, that way the cost also has been reduced. Apnea of prematurity, when you've given flow more than about 2 liters, it is going to generate the positive distending pressure. It's also been helpful in apnea of prematurity. So cost effectiveness, they have seen difference between CPAP and HFNC. So sole primary support CPAP is likely to be more cost effective. As I said, the number of days the CPAP was used a little lesser than the HFNC, hence the cost effectiveness wise CPAP fares better than the HFNC for 28 weekers or more. Contraindications of using HFNC is similar to CPAP. If you have a cleft lip or cleft palate, if you have severe cardiovascular instability. So these are all used HFNC in the spontaneously breathing infants. So if there is a severe cardiovascular instability, there is not that's not the support we are going to use. So baby is in shock, or the baby is not hemodynamically stable, going into recurrent apneas despite of giving caffeine on HFNC, then we have to upgrade. So that is a contraindication. And when you will consider the failure of HFNC, it also differs from unit to unit, but our unit says it's about presence of respiratory acidosis, pH less than 7.2, PCO2 more than 60, and PO2 less than about 50. So if you have hypoxia, hypercapnia with respiratory acidosis, if on HFNC your SAS score, Silverman-Anderson score, has increased from 4 to 6 or 6 to 8, that means that the baby's work of breathing has increased on HFNC. So you should consider maybe upgrading it to CPAP or to the IMV. Presence of shock or presence of recurrent apneas, then we have considered it's a failure of CPAP, and you should consider it going to the next level. So in a summary, as I said, the take-home messages, it is HFNC is inferior to CPAP if you are considering less than 28 weeks or 1,000 grammars. There's not much of the evidence, but it's a very good primary support for more than 28 weeker, more than 1,000 grammars with mild to moderate RDS after the insure. Secondary to post-extubation support for more than 28 weeks. Yes, it's a primary support. You can use it for CPAP as a backup effect. You can use it for the babies who are on CPAP having a lot of nasal trauma. You can use it for the post-extubation. We can also use it for apnea of prematurity. Duration of respiratory support might be a little more days as comparable to the CPAP. And we can consider CPAP as a backup effect. So high flow nasal cannula, it is useful in the babies with the established nasal trauma. It's very comfortable to give KMC with. It is user friendly, it is parent friendly, it is nurses friendly. You can establish the breastfeeding. There was one study where they have seen the time to reach full feeds. It is not statistically significant, but it's a little better with HFNC than with CPAP. It minimizes the desiccation of the delicate nasal tissues. It can also give effects like CPAP. And when you have considered between ventilator days, BPD, sepsis, or death, there is no much difference between CPAP and HFNC. HFNC also can be used during the transport. HFNC also can be used when they have done the pain perception score. It has been seen that HFNC fares better than CPAP when they have done the premature PIPP scores for the babies. So pain perception is much lesser in HFNC as comparable with the CPAP. I would also like to put up in last a few words about HFNC that is also being used now because the season is being now, we have seen a lot of bronchiolitis cases now. HFNC is also being so instead of using a standard oxygen, HFNC fared better in terms of in a bigger babies also in terms of whenever there is a bronchiolitis they have used. We do not have Vapotherm here, but Vapotherm precision flow, they have also tried giving inhaled nitric oxide through HFNC. HFNC. So we are basically using more and more Fisher and Paykel here. So that is also used in the bronchiolitis. So especially in this season, I just wanted to put up that as a last one. So consider it always, it is the neonatologist and the pediatrician's discretion and your unit policy to decide on whether to use a CPAP or to HFNC. It's always a good, bridge between a CPAP and a nasal cannula. And if you have a mature babies with a mild respiratory distress, consider this using as a primary respiratory support. Yeah, thank you.
Thank you, Dr. Manisha, for summarizing HFNC. So I remember one of the talks given to us by Dr. Aparna from Hyderabad. So
Yeah.
she talked on HFNC, where do we stand now? So her last slide actually was a nice slide, which actually compared HFNC to a gulab jamun. It is easy to have or it is sweeter, and CPAP to a bitter gourd, which causes more nasal injury, but it is good for the babies. So I know the debate continues as more and more evidence comes in. I think it's very clear till now that if you have a baby with RDS, CPAP will be the primary respiratory support. So once after the RDS is settled, for weaning for smaller babies, less than 28 weeks or less than a kilo, I think CPAP is still the best, or plus minus NIMV. So post extubation care, we have seen NIMV is superior. But if you want to compare between CPAP and HFNC for larger babies, that is babies beyond 28 weeks, I think HFNC is equally efficacious than as CPAP. Probably you will end up having 1 or 2 days extra on HFNC, but nasal injuries will be less compared to CPAP. So any questions to Dr. Manisha? Sir, please.
After listening to this topic, sir, now we have a clear idea which one, where and when to use. But one thing I have doubt in my mind is about term babies with meconium aspiration with mild to moderate cases. Nothing has been mentioned about it.
So regarding term babies with meconium aspiration syndrome, so there have been, in term babies, let's say like any baby beyond 35 weeks, oxygen is a primary support. But let's say if a baby has mild to moderate respiratory distress, that is SAS score beyond 3 or down is beyond 4, there's a lot of evidence coming up over the last 5 years from Indian literature, because Western countries don't see meconium aspiration more commonly than us. So there's a lot of evidence coming from Hyderabad. So where they've used CPAP as a primary respiratory support, they've started at a PEEP of 5 centimeter as a primary respiratory support, and they've tried maximum till 6 centimeter. And they found that length of stay is lesser when you use CPAP for meconium aspiration syndrome as a primary respiratory support compared to oxygen. The air leaks was not different. So they're giving CPAP, the bubble CPAP or ventilator CPAP with PEEP of 5 centimeter. They're not going beyond 6. So 6 centimeter they've used in very fewer cases. So for meconium aspiration, CPAP is safe. So if you're using it, appropriate flow and appropriate PEEP. So they've not compared HFNC versus CPAP. That's the limitation there. For HFNC, I think most of the Indian units have been using HFNC for TTNB and those situations, but we do not have any literature on that. Karthik sir, would you like to add on this part?
Thank you so much. I was listening to Manisha's last part of the lecture. Very, very brilliant exposition, Manisha. HFNC is probably the way to go for the future, as I see, except for the very small babies who are less than 28 weeks gestation, where it's not a very good primary mode of support. But in a term baby like meconium, and the baby needs oxygen, and low flow cannulas are not the in thing now, because you can't clearly monitor the FiO2 unless you've got a low flow cannula connected to a blender. It's always good to go for a high flow nasal cannula with heated humidified circuit, and you can start with the flow rates of about 5 liters per minute also. We have tried HFNC even in primary mode in meconium aspiration. Though, as you rightly said, Dr. Murki and his group in Hyderabad has been trying CPAP with initial support for meconium, but HFNC should be okay in bigger babies. It's not an issue at all.
So thank you, Karthik sir. That is HFNC probably is a upcoming modality there. So you can try CPAP. There's no, like we have evidence saying that CPAP will reduce length of stay. So any other doubts or questions to Dr. Manisha? So if there are no questions, we'll move on to the next talk. So the next talk is about non-invasive ventilation. I think this will be the last talk prior to lunch. And to give this non-invasive ventilation, we have the expert in the field. So we have none other than Dr. Karthik Nagesh sir.
Thank you.
Dr. Karthik Nagesh sir did his MD from PGH Chandigarh. So he did his fellowship from Australia, and then he has been heading neonatology unit at Manipal. So he's currently the in charge at Manipal Hospital. So Karthik Nagesh sir, as we are all aware, he has done a lot of fuss in the country. So he's the first one to get surfactant in a baby. He's the first one to get PDA surgery done within the NICU. There's a lot of fuss to his credits. So the NIV in South India, probably I would say Karthik Nagesh sir has done a lot of work, lot of education sharing he has been doing for the last 3 decades, I can say. So
thank you, Abhishek, for this very nice words. Can I start sharing my slides?
Sure.
So I'll just, yeah. Yes. Are you able to see my slides?
Sir.
Okay. So without much ado, I just wanted to talk about the reasons why we need to go for non-invasive ventilation. This is, I think, as people have already told before me, we have, at least I have been very, very fortunate for last 3 decades or so to have seen the kind of progress in respiratory care in this country and across the world also. We have started from NICUs where a lot of ventilation aggressively we are doing. And more as I realize now, we have been using only non-invasive modes like these now in our babies, mostly CPAP and high flow nasal cannula. Again, people have exposed this before me that it's basically to prevent volume trauma related to ventilation induced lung injuries and atelectode trauma also. So if you were to avoid, if you had a situation where you needed to avoid invasive ventilation, what would you do? You would like to therefore give non-invasive ventilation using a similar mask like CPAP connected to a ventilator, trying to manage the ventilation as far as possible in the pressure volume curve, as you can see, gentle form of ventilation where you don't cause atelectic trauma to maintain some kind of a PEEP, and also trying to prevent over-distending the lung so that you try to keep the upper limits of the pressure also. So you're trying to gently ventilate the baby. Even in gentle invasive ventilation, we follow the same principles to avoid the volume trauma and atelectic trauma, but more so with non-invasive ventilation, these things are now also our aims. We all know, and we have discussed this before, that essentially the preterm baby has got a different airway than an adult, and you have a situation that unlike invasive ventilation, when you give non-invasive ventilation through a nasal tube, the pressure practically comes down by the time the airflow reaches the larynx. And subsequently also, because there's a very narrow passage subsequent to that, some of the air is not able to reach the trachea properly. So you need to give it with a little bit of higher flow and pressure. And sometimes there's a chance that it can go into the stomach, causing distension of the stomach. But the biggest advantage of giving non-invasive ventilation is you're avoiding the tube passing through the airway into the upper portion of the trachea, as a result of which a lot of things like infection and other complications related to endotracheal intubation can be avoided. So particularly so volume and barotrauma can be avoided, and infection also. But the problem all the time remains that is in non-invasive ventilation, sometimes the flow is too less, as a result of which there may be a little rebreathing in the upper airway here, which also we need to avoid when you're going to plan to do non-invasive ventilation. So CPAP most of the times is able to help in all this, but sometimes there is a reason to go beyond CPAP, because there may be a situation in the lungs of the baby where the alveolar to arterial oxygen gradient is very, very high, which means there may be a lot of oxygenation need for the child, and there may be a ventilation perfusion mismatching in the lungs also, as a result of which there is diffusion limitation. So just giving oxygen alone is not enough, because these babies can go into hypercarbic states. These babies can also have a right to left intrapulmonic shunt, which is happening. And these babies have a need, therefore, to get beyond oxygen. So it is not only just giving a little bit of pressure with a little oxygen, or even probably a just little bit of high flow nasal cannula. You need to probably give what's called ventilation, which is non-invasive, so that all these things can be met. Of course, traditionally in the yesteryears, we were giving oxygen. Now with high flow oxygen also we can give. Babies were getting responded to CPAP also, the way you can see, including the ventilation perfusion mismatching, and the intrapulmonic shunts were responding. But in sicker babies where there was severe alveolar membrane kind of thickness, or there was a hyaline membrane disease or severe meconium, you would need to have ventilated these babies. But these are the babies which we are now able to manage with non-invasive ventilation without adding on the deleterious effects of ventilation. So once a baby has been resuscitated in the first few golden minutes, and we are all talking more and more about delivery room CPAP now, the baby then subsequently, if the drive is not good and the baby's lung volume is so small that severe RDS is settling in, we can probably think of starting what's called gentle ventilation using non-invasive methods. So if you have a situation where the baby is born somewhere and access to initial intensive care is not available, and the baby is not able to be given any respiratory supported birth, so what are the natural processes which occur immediately? Because the baby's lung is not very good, the baby has a tendency to develop an upper airway collapse. There is obstructive apnea which is happening. Simultaneously, there is a low FRC which causes low compliance in the baby, and there is alveolar derecruitment and atelectasis which causes severe hypoxia and hypercarbia because of ventilation perfusion mismatching. There is lung injury due to lung inflammation, and slowly the increased work of breathing causes respiratory acidosis and fatigue, and the child may just die. So our aim is to try to intervene somewhere here so that all these aspects can be taken care. And that is where CPAP has been found to be definitely very, very useful. It also stimulates the baby to breathe well. But all these effects can be exponentially increased if you were to do non-invasive ventilation also. So that is the reason why I wanted to show this slide. Is no doubt the baby himself, when the baby has respiratory distress syndrome, will try to extend his neck, breathe faster, trying to do a lot of grunting by partly adducting his glottis, as a result of which some kind of an auto CPAP is generated, so that he's able to wash off his carbon dioxide, become better in oxygenation, and improve his FRC. But all these things is what was the principle by which CPAP was found to be useful. And all the trials done about 10, 12 years back, the COIN trial and support trial suggested that soon as the baby is born in the delivery room, if you were to start prophylactically CPAP, or what we call early rescue CPAP with 5 to 6 centimeters of water, you can probably avoid death into severe hypoxia and acidosis, or even the possibility of intubating a baby, which is almost about 50 to 80% of the times you would be able to avoid intubating the baby. But still, some of these babies were needed to be intubated and would meet surfactant. So that is where people started thinking in this last 15 years or so, no doubt CPAP is good, and all these other things which I mentioned earlier was able to be done by good CPAP. What is then the need for giving non-invasive ventilation? The need is only in those babies who need it. Let's see, if you see here, sometimes 80% of the babies, the support trial suggested that sometimes we need ventilation, and about 50% of the times, even if you started prophylactic CPAP, you would need to still ventilate babies. So it's not that you could avoid ventilation, you would need to ventilate them. But then what if you were not to ventilate them and therefore avoid the deleterious effects of invasive ventilation? What if we were able to manage with non-invasive ventilation? Basically, it's nothing very great. Non-invasive ventilation is just as if giving CPAP, but adding some ventilation breaths to the baby. And if we were to do non-invasive ventilation effectively, even as a primary respiratory mode, soon as the baby is born, you would probably avoid ventilating babies 50% of the times further. So that means intubation can be avoided further, and the risk of chronic lung disease also becomes lesser, and the need for ventilation also comes down, and therefore the need for NICU care also comes down. No doubt, there is a slight increase in incidence of pneumothorax associated with non-invasive ventilation, but that is far outweighed by the benefits of giving non-invasive ventilation. So when do you decide to give non-invasive ventilation? The circumstances are either as a primary mode, if the baby is gestationally very small, for example, 24 to 28 weeks, the baby is very small, you can start with non-invasive ventilation straight away and take the baby to the NICU. Of course, you would have started CPAP in the delivery room. Maybe with a T-piece, you can start giving a little bit of breaths, positive pressure breaths to the baby while connected to the CPAP. But once the baby comes to the NICU, you would give non-invasive ventilation. Or you have a situation where the baby has been started on respiratory support with CPAP, but there is recurrent apneas occurring, the SAS score is worsening, the child is continuing to grunt, retractions are increasing. These are the criteria for CPAP failure, which means our saturations are poor, oxygenation is poor, and the PEEP has reached to more than 7 centimeters and FiO2 is more than 60%. That is defined as CPAP failure. So in these situations, especially the baby is not tolerating CPAP, you would think of switching over to NIV. In the earlier situations, earlier days, you would probably intubate these babies and give them ventilation, but that's not necessarily nowadays the protocol. Most of the times we'll give it a trial of non-invasive ventilation. So you can see most of the trials in the early part of the last decade and last part of the decade before that had suggested that almost 50% of the times, though you would start CPAP in the delivery room, 50% of the times babies would end up being ventilated because of CPAP failure. So this is the group of babies, especially if they're smaller than 28 weeks of gestation, you can probably think of using non-invasive ventilation. So again, the reasons are again very obvious, because ventilation-induced lung injury can be avoided, infections can be avoided, it's too invasive, and sometimes you don't need to shift the baby to a tertiary level care unit. You can give non-invasive ventilation even in a unit which has got a ventilator with the mask or the nasal prongs, you can probably do it. So these babies who otherwise hitherto would have gone into respiratory failure and needed intubation and mechanical ventilation, we can probably avoid that happening and switch to non-invasive ventilation. So the technique is called, standard terminology is called non-invasive positive pressure ventilation. Basically, it's nothing but just giving nasal CPAP with intermittent positive pressure ventilation. So this is the new kind of advantage. Sorry, just one. Hello. You are not able to hear me. Can you hear me? So can you just tell me soon, where did you lose me? Yeah, I'll just, you tell me once it's on, I'll cut back. Come on, come on. Sorry, yeah, there was a small interruption. I hope you can see the slides now. Okay, so as I was mentioning, what is non-invasive positive pressure ventilation? It's nothing but giving nasal CPAP with intermittent positive pressure ventilation. And this is what many of us have now started doing, especially for these smaller babies, even as a primary modality. So all the terminologies which you've been hearing since morning, the next step is probably non-invasive ventilation using NIPPV. Now, if you were to see what is the difference between CPAP and intermittent positive pressure ventilation. In CPAP, there's a continuous bias flow of air, which is given at 5 to 6 centimeters of water with an air and oxygen blend, and that is going, and the baby is spontaneously breathing, and the child gets the CPAP. But in intermittent positive pressure ventilation, the bias flow is continuing all the respiratory cycle throughout. There is a baseline level of CPAP which is maintained, which is called PEEP. And on top of it, positive pressure beds are administered like seen here. So you can probably do it as at a certain fixed times so that a positive pressure breath is always given at a certain time. Or just like the synchronized IMV, which has been described earlier, you have devices now which are available, which can keep. Sorry.
Karthik sir,
yes.
Just to we had some unstable connection for just 10 seconds. This slide actually we lost, sir, in the initial part.
Yeah. So shall I share my screen again? No. What do I do?
Your screen is visible. This slide actually initial part we lost, sir. We lost the audio.
So are you able to hear me now?
We are able to hear you, sir.
Okay.
The power is back, sir.
Yeah. Nothing much. I'm just trying to introduce the concept of the intermittent positive pressure ventilation. It's nothing. If you now see this slide here, you will understand that in CPAP, there's always a continuous bias flow as a result of which the baby is breathing on its own and you are giving just positive airway pressure. Whereas in intermittent positive pressure ventilation, the baby is no doubt having a spontaneous breathing, but on top of it, you're adding some ventilator breaths with a nasal interface. That is what is happening here. Now, there's another type of giving intermittent positive pressure ventilation that is called bi-level positive airway pressure, which I'll come to later and describe that later a little bit more in detail. Now, what happens therefore when you do this NIPPV, physiologically, you're anyway giving a good P. As a result of it, there's good recruitment of the collapsed non-ventilated alveoli, because especially in RDS, hyaline membrane disease, you know, there's a very inhomogeneous lung. There's a lot of ventilation perfusion mismatching. So that is rectified if you were to do that. It decreases the airway and pulmonary resistance and improves the ventilation perfusion ratio. So if you do this, automatically the lung compliance gets better and the baby is able to breathe in this portion of the air pressure volume loop where the resistance is less and the compliance is better. So the lung injury is also better and oxygenation improves. Parallelly, with the improvement in the minute volume, the carbon dioxide washout is better. And because of that, the work of breathing becomes better and parallelly the cardiac output also becomes better. So automatically the child is calm. And if you were to convert, you must have seen, I'm sure most of you are neonatal pediatricians, when you see a baby who's on respiratory distress, you connect with CPAP. More so if you connect a baby with a ventilated CPAP, which is called NIPPV, you'll find the baby's breathing becomes calm. And that's a sign of good NIPPV which you're giving to the baby. So essentially, NIPPV or CPAP splits the upper airways. So it opens the airways up. It is therefore allowing the prevention of the airway collapse, especially on inhalation. It prevents obstructive apnea. That is very important. So all these small premature babies, even if their head is turned a little bit to one side and there's a slight twist in the trachea, there's a chance of obstructive airway, obstructive apneas occurring. And that is prevented more so by NIPPV than CPAP. It stabilizes the chest wall and therefore oxygenation is better and therefore surfactant production becomes better, maintains the FRC, recruits more alveoli and prevents alveoli. And more so compared to CPAP, NIPPV is able to get rid of carbon dioxide better and improves oxygenation better. This is data which is available and meta-analysis has suggested that. There is a reduction in inflammation in the lung and therefore lung injury is better prevented with NIPP. Again, work of breathing, respiratory fatigue and acidosis is better avoided by NIPP as compared to CPAP. And all this data later on I'll show you. So it improves the respiratory drive by stimulating the J receptors and the Herring-Brewer reflex, and therefore central apnea is also prevented. So there are two types, as I said, of NIPPV. One is the standard NIPPV, where ventilator breaths are given to the baby, and parallelly CPAP is administered. So PIP and PIP, both are there at a certain frequency. You find there's data to suggest it improves the mean airway pressure and therefore improves oxygenation. It reduces the work of breathing, and synchronization is also possible in NIPPV, which further efficaciously improves the oxygenation. The other is bi-level CPAP. You have been now talking about single level CPAP, which say is 5 to 7 centimeters of water. Just think if the device was able to give another level of CPAP, it almost becomes like ventilation, but a little slower. So let's say about 10 to 12 breaths per minute. You stay, one level of CPAP is, let's say, 5, and the other level of CPAP is, let's say, 8. That also has been found to reduce the carbon dioxide better. It improves the oxygenation better. So these are the two types of NIPPV which are available. CPAP also can have an apnea backup. Many machines are now available which can give an apnea backup, like a small standalone CPAP device called the infant flow driver is available, which can give an apnea backup. You do realize that CPAP cannot prevent apnea, especially if you do bubble CPAP, it can't give an apnea backup. But on a ventilator, you can set an apnea backup so that, like in this figure seen here, you can see that the baby has a good respiratory drive and CPAP is being delivered well, but a certain time occurs, let's say for 10 seconds, where the baby becomes apneic. So automatically a good CPAP pressure is delivered. So this is like an apnea backup, which is possible. This is what I was referring to called the bi-level CPAP, which is now easily available. Even on a ventilator, you can do it, or you can do it with standalone CPAP devices which are available. There is CPAP going on at a certain level. For example, this is all spontaneously breathing babies, and the CPAP pressure, you have set it up, let's say at 5 centimeters water. But after a certain time, it goes on to deliver the CPAP pressure at, let's say, 8 centimeters of water. So it is biphasic. So for some period of time, let's say the baby has taken 10 breaths, let's say spontaneously, and the CPAP is being delivered at 5 centimeters. Then for the next 5 to 6 breaths, it can deliver based on whatever timing you decide, which is easily adjustable in these devices. You can give the same CPAP at a higher level. This is called the bi-level CPAP, which is available. Now, if you were to compare standard CPAP, which is going on like this, and baby may or may not have good spontaneous breathing activity, but the CPAP has just got a standard level of CPAP being delivered there. Whereas in bi-level CPAP, there is 2 levels of CPAP generated. The device which can do this is now available in this country. It's called the infant flow driver. It is available. It's a driver, and it's got air oxygen mixture being given through this driver, and there is a generator which actually delivers the PEEP pressure to the baby. So this is a very interesting kind of mechanism. It's called the Konda effect. What happens is that from the driver, the air and oxygen mixture through a blender, let's say at 5 to 8 liters per minute, is being driven into this incoming port of the machine, of the kind of device which is connected to the CPAP mask. So what happens is that the Konda effect suggests, just like water flows, suppose you have a waterfall, the water flows along the side of the waterfall or the side of the mountain, and it flows. It doesn't spill across like that. Like that, this air and oxygen mixture goes along the direction of the flow of the tubing and then goes into the baby and generates a CPAP pressure. Now, when there is an expiratory effort by the baby, the air oxygen mixture which comes back is able to flip backwards and come out. As a result of which, constantly there is ingoing gases and outgoing gases all the time. And you can set in the machine 2 levels at what it can be done. So this provides a bi-level CPAP, which is also called CPAP, with a little pressure. What happens is you can set it, for example, here in the knob here, you can set it at, let's say, 5 centimeters, And here you can set it at 8 centimeters. So there's a bi-level of CPAP getting delivered. Also, these kind of devices are able to give what's called a sigh breath also. So you have CPAP bi-level going on, and once in a while, maybe 10 breaths a minute, you can give a slight positive pressure breath in addition to that. So that is what is called CPAP. Like you can see here, this is CPAP going at, let's say, 5 centimeter and then at 8 centimeter. And once in a while, a slow sigh breath is given on top of the CPAP. So that this helps better lung recruitment and it helps better oxygenation in the baby and wash out of CO2s, and also triggers the baby to breathe better. So these devices are now also available and they're able to. So this is one form of giving nasal intermittent positive pressure ventilation. So again, to recap, what is NIPPV is that basically on the mean airway pressure, which is constantly being delivered to the baby, the CPAP pressure, you are intermittently giving positive pressure breaths. So in a ventilator, you can set the PIP, the PEEP, the respiratory rate, and the inspiratory time, and you can give it delivered through a mask or through nasal prongs. So this is just a cartoon to depict the same. You have CPAP going on at a basic level to keep the alveoli from collapsing. On top of it, you are giving the PIP. We can set it up, for example, 18 centimeters of water and PEEP of, let's say, 5 centimeters of water. And an inspiratory time you can fix, let's say 0.3 seconds. So for 0.3 seconds, it will give that pressure and intermittently. But if you see in NIPPV here, the baby is breathing spontaneously, but a set time is given whenever the PIP is delivered. It is not synchronizing with the baby's breath. So sometimes you may have an asynchrony. The baby may be expiring and the positive pressure breath through the mask or the nasal prongs can be delivered to the baby. So there is a likelihood of some intermittent asynchrony which can happen. Now, if you were to compare the bi-level CPAP versus NIPPV, the difference, as I told you, this is a very small rate which you keep. As a result of which, the bi-level CPAP, the CPAP is delivered for a longer time. And this is, for example, the 5 centimeters, and this is, let's say, at 8 or 9 centimeter, but the interval inspiratory time, as you can call it, is longer here. Unlike in NIPPV, where the rates are more, and therefore the inspiratory time becomes lesser. Here you can go even up to 1 second or so in the respiratory cycle. This is usually kept at 0.3 to 0.5 seconds. That's what we do. So proposed mechanisms of NIPP we have discussed already, but basically it improves ventilation perfusion. It reduces the work of breathing and makes the mean airway pressure increase, as a result of which the baby's oxygenation is better and CO2 removal is better. And to some extent, there's a good washout from the dead space, which is there in the upper airway and in nasopharynx. And there's a good stimulating effect on intermittent cycling of the respiratory drive. So typically, you can use NIPPV as a primary mode as well. Especially in babies who are gestationally more than 28 weeks, you can. Some people would say, don't use it gestations less than 32 weeks, but we have tried it effectively in babies, especially in today's world. Preterm babies are born to mothers with antenatal steroids being given, and they seem to come out in a better condition, but they still have that mild RDS and a little fluid in the lung, which needs a good transition, and the respiratory drive may not be very good. So gestations 28 weeks and above, you can probably try. Post-extubation mode, definitely it's recommended. You have ventilated a child for some time, and if the baby is very small, less than 32 weeks gestation is definitely recommended. And as a rescue therapy following failure of CPAP, instead of ventilating a baby, you can try NIPPV. So this is how you would do it. So simple. You set the settings as you would set in a ventilator. The inspiratory time of 0.3 seconds should be enough. PIP varies. Now, this is very, very variable. Nobody knows clearly, and still data doesn't tell you what should be the PIP. But the average PIP we would take is about, if you're extubating a baby, it can be the same PIP where the baby was extubated from. Or if it's a primary support, you would start at around 15 to 16 if it's a baby 28 weeks of gestation or more. PEEP, you could start at 4 to 6, and you would keep a backup rate of 15 if it's just for apnea you're doing, but 30 if you would have to do it for RDS, respiratory distress syndrome, and keep the flow liters, smaller babies 6 liters per minute and bigger babies 10 liters per minute. And all you need to do is do the same adjustment of settings like in the ventilator. This is an SLE 6000, you can see. The settings are the same, I time, PIP, inspiratory time, and the FiO2. Of course, you would try to connect it to a test lung. You can see how the test lung is functioning here. You will see that once you do these settings, the test lung, if it's working well, there you can see the pressure volume curve, the loop there. You can see the baby, the ventilator is delivering a good breath, and then you can connect the baby with a non-invasive kind of interface. So these are the settings which I discussed earlier. If it is hyaline membrane disease, you can start with these settings, and maintenance of saturation is the same target of 90 to 91, 95. And if it's post-extubation, the same pressures as what you are extubating the child with. Inspiratory time may be 0.3 to 0.4, and target saturation is 91 to 95. But of course, for apnea also you can use it, and there the oxygenation is not such a problem. So, and also the rates you can keep it low, and the pressures also you can keep it low there. And subsequent management depends exactly like invasive ventilation, you maintain with blood gases and the clinical status. So the indications are the same as for CPAP, if I was to summarize. But when you need some extra support, for example, the baby has been very unwell in the delivery room, and very small baby who needed positive pressure ventilation, whose respiratory drive is not really good. Unfortunately, it was a sudden delivery, precipitous delivery. There was no chance to give antenatal steroids. The oxygen need has come to be more than 40-50%. No doubt you're going to think of giving surfactant, but after giving surfactant, because the respiratory drive has distress has been severe, you can probably think of giving the child NIPPV. If the baby has come to you from somewhere, or the baby is worsening on the Downey score or the SAS score to more than 7, you can consider NIPPV. There's an algorithm people sometimes go by. If the CPAP pressure, if the CPAP failure and the pressure is exceeding 7 or 8, and the FiO2 is also increasing, and you multiply the two, if the score is more than 1.28, you would probably need to consider giving NIPPV. So now the question is, if NIPPV was, I'll just skip this slide. If NIPP was initiated and the gestation was, let's say, in 32 weeks or less, NIPP was initiated, what do you do subsequently? Monitoring the child as usual, as you do for RDS, is the protocol, and blood gases, standard precautions are taken, and the standard targets of blood gases is done. But if you were to feel that the respiratory distress is getting better and the FiO2 needs have come to less than 30%, and the PIP and the PEEP standard can start coming down, each reduction in PIP or PEEP, you monitor it for a few hours and do the blood gases, and you find things have come down, you can probably deprong the baby to nasal CPAP or high flow nasal cannula as per standard, whatever requirements you can do. This would be the way you would arrange the protocol for the baby. Now, there is a new technology which unfortunately is not easy. It's not new, I would say. It's about 10 years in existence. This is synchronized NIPPV. Unfortunately, this is not now currently available. The old Infant Star 950 ventilator, we used to have this ventilator long back, 20 years back. This would have a small kind of a wiring connected between the abdomen of the baby, taped like just like a skin probe, you tape it to the middle of the abdomen there, and then it will be connected to the ventilator. So when the baby would take a breath like that, there is a trigger, the baby ventilator will sense the baby's breath. This is called a Grassabes capsule. As a result, when the baby senses, the ventilator senses the breath as the inspiratory breath of the baby, the ventilator would derive, to give breath to positive pressure ventilation to the baby. And as a result of which, some form of synchronization would be achieved if you were to do that. Unfortunately, these ventilators went out of fashion. Recently, most ventilators, as you know, have been having flow sensors. There's only one ventilator available in the entire world, which is called the Julia ventilator, which has got a flow sensor which can be adapted to non-invasive form of ventilation. So even without a good tight-fitting mask, with a little bit of leak also, still it is sensitive enough to be able to pick up the flow and to be able to generate the positive pressure breath to the baby. The other is, of course, the NAVA, which I'm sure Dr. Kulkarni, the next speaker, will be talking about it. But I'm going to restrict myself to a little bit of data on SNI-PPV. Basically, it's been seen that the diaphragm, earlier people were having a device which was connected to the diaphragm, like the one I showed you, the Grassaby's capsule, where as soon as the baby would take a breath, it would indicate the baby is inspiring and therefore give a positive pressure breath. But it was fairly recognized that only when the glottis is opening, that is an indication that the positive breath needs to be given. That is where it's important to have a flow sensor inside the tubing of the ventilator itself, so that there is a good advantage for that to be able to pick up the early respiratory drive of the baby, as a result of which when the glottis is opening, the ventilator can go and derive a breath to the baby. So this is the flow sensor, which is an online force, or you can call it an inline force flow sensor, which is part of these kind of ventilators. And even a small air coming into this mechanism will be able to trigger the flow, trigger the ventilator device. Of course, there is a worry about air leaks if the device is not well connected. That is no doubt always a worry. You can see the device here. It is connected to the nasal interface here, but it's always a worry if the air leaks, especially from the nose or from the mouth, whether it will be sensitive enough. But the Julia ventilator, especially experimental studies have shown that it's very sensitive, and in spite of a little bit of air leaks also, it is able to pick up and to be able to give the SNI-PPV the desired way. So the Julia ventilator looks very similar to this. Of course, this is an SLE 6000. Unfortunately, the Julia ventilator, only a few demonstration pieces are available in this country. It has come to this country, it's available now. But then similar is the setup there, and you can get same, you can see loops, you can get all kinds of modalities which you want to use with these kind of ventilators also. So this is how you would go ahead and set up the Julia ventilator also for SNIPP, or what you call synchronized NIPPV. So here you can see, unlike NIPPV alone, if you synchronize it, there's a trigger. You can see the trigger happening here. The baby takes a breath like that, which is recognized by the flow sensor, and a positive pressure breath is given to the baby for a certain inspiratory time, which you determine. And then there is no expiratory asynchrony. Most of the times it's a well-matched synchrony. And this has been found in most of the studies that SNI-PPV improves oxygenation better as compared to NIPPV alone. And with an apnea backup there, you can be rest assured that the baby will be getting a good trigger and will be getting a good respiratory support in spite of not being able to trigger the breath. So this is what I said was the difference between SNI-PPV and NIPPV. You can see here, especially here, if you see the ventilator gives a breath in spite of the baby being in expiratory phase, and there is expiratory asynchrony. This will not happen with SNI-PPV with the modern ventilators which are available, and it's got an apnea backup also. Now, this is just the data which was published this last decade or so, which shows that if you were to do synchronized NIPPV, you have the baby having a larger time with good oxygenation throughout the inspiratory phase of the baby, unlike the NIPPV. This is more robust data which has been published about a decade back, which shows that with NIPPV, the carbon dioxide washout was lesser as compared to the SNIPPV. So this is the reason why more and more people are advocating the use of SNI-PPV. It reduces the work of breathing, increases synchrony, the thoraco-abdominal synchrony, it improves. There are experimental animal studies which have been done in the lab which show that carbon dioxide oxygen concentrations are reduced better, and tidal volumes and unit ventilation happens better. Just a word about the interface to be used for NIPPV, just like CPAP. Please avoid nasopharyngeal tubes. The single prong nasopharyngeal tube should never be used at all. In fact, 10 years back itself, they were discarded. Most of the times you'd use nasal prongs or nasal masks. And this is now meta-analysis available, which shows that nasal masks reduces the incidence of need for endotracheal ventilation. It reduces CPAP failure and also NIV failure. And obviously the nasal trauma is also reduced. So nasal masks is what most of us would prefer. But if you were to still use prongs, then you will have to make sure the columella and nasal injury is closely looked into all the time. So this is just something which has come to India this last couple of years, the RAM cannula, which essentially is a tight fitting cannula which needs to be connected. It's also useful. A lot of units in the Western countries, especially in the United States, use this RAM cannula for giving nasal intermittent positive pressure ventilation, either during transport or as a standalone in the NICU also. It is unlike the CPAP cannula, where it's no doubt it's a bioral prong, but it is connected with a single limb backwards. And from there, it is connected to the ventilator. As a result of it, the ventilator's expiratory valve maintains a CPAP pressure in the circuit. It has a heated and humidified limb, which is connected to the other side. There's a very tight fit, needs to be very tightly fit. And that is the way it can work. And the only problem with RAM cannula is there's not enough data to suggest whether it delivers the correct amount of pressures or not. And sometimes there's a worry that it may give a lot of pressure. So you have to be a little careful using RAM cannula. There's not much robust data available with it. This is, of course, the beautiful, elegant experimental studies which were done 2 decades back, which were done on babies. And Professor Moretti from Italy has done most of this work on SNI-PPV, which shows that if you were to compare SNI-PPV or compared to CPAP, the oxygenation is much better and the tidal volumes delivered are much better with SNI-PPV. This is the data which is published. And also Professor Bancalari in newborns in the using such plethysmographic data has suggested that SNI-PP is much better as compared to this. Of course, now meta-analysis is available, which says that NIPPV does appear to be more superior to nasal CPAP as a primary respiratory support to decrease respiratory failure and the need for intubation and mechanical ventilation. Also, as a secondary support, it is very useful for post-extubation babies. It's definitely been found to be very useful. And there is now data available, meta-analysis also, which is suggestive that the NIPPV has lesser failure rates as compared to CPAP. This is very well proven now. So if you have a small baby, and if you think the baby's respiratory distress is severe, it may be prudent to put the baby on NIPPV. At least you have standard ventilators, even the Draeger Babylog 8000 you can use, or any of the modern ventilators you can use, or at least you can use bi-level CPAP if devices like this are available, because bi-level CPAP would be better than using just simple CPAP. And of course, there are just 1 or 2 concerns that the peak inspiratory pressures which need to be started with in an NIPPV model is still not very clear. Lot of data still needs to emerge, but you would not go wrong if you to start somewhere between 14 to 16 as a primary mode, or post-extubation, whatever the ventilatory pressures you are giving on invasive ventilation, you can start that, but still data needs to be done on that. And there is some worry whether the tidal volume delivery is good enough or not with NIV, but most of the times in day-to-day practice, you should be not going wrong if you were to do NIPPV. And there's enough data which suggests that if you were to do NIPPV, especially in babies who are small or post-extubation, the chances of re-intubation are very less. So I like to conclude my talk with this slide now. You're most welcome, Abhishek, if you have some time to ask any questions or any doubts. Thank you so much for this opportunity.
Thank you, Karthik sir. I think most of our participants, when we asked in the morning, what's their hopes from this workshop, most of them answered they wanted to learn about NIV. I think most of their expectations will be met on the theoretical aspects. I think we learn more about NIPPV in the workstation as well. So I think sir has summarized well that whenever some baby is on CPAP, it needs extra support. I think NIPPV is the answer there, and NIPPV is well proved well beyond doubt that it is the better mode in the post extubation setting compared to CPAP. So any questions or doubts you want to ask with sir?
Good afternoon, sir. I'm Srinivas Murthy here.
Yeah, hi, Srinivas.
ಚೆನ್ನಾಗಿದ್ದೀರಾ sir?
ಚೆನ್ನಾಗಿದೆ.
Sir, a couple of things. I mean, it was very interesting. I heard throughout without blinking my eyes. It was such a wonderful talk that you gave.
Thank you.
Only a couple of things I have as a sort of, I would say, discussion points. One thing you told that the NIPPV is just the CPAP with added rate, which honestly I contest because I have published a paper telling that with the opposite meaning, telling that NIPPV is not CPAP with a rate rather than it is IPPV without a tube. That is the title of the article that I have published. The reason is I went through the evidences about why NIPP have become so popular. I know, I mean, you have really stated why it should be used. I agree with you on that aspect. But most of the comparisons were with CPAP, which I feel is not correct because in NIPPV, the force or the pressure which drives the gas into the lungs is the positive pressure, though there is a spontaneous breathing in between. So I sort of argued in that article telling that it should be compared with the invasive, that is the tube in situ, endotracheal tube in situ, and then we should really get the information whether it's really superior or not. And in fact, currently we are running one study where we have recruited babies who have failed CPAP. We give CPAP, they fail according to our SOP index of more than 1.6, and then they are randomized to either tubed ventilation or insure and then go for NIPPV, which is halfway through. Probably by next year we should have some result. So there is one just a point that I would like to discuss. The second thing is about the RAM cannula. In fact, when I was in Canada, I was using this, and out of curiosity, I really took one RAM cannula which was used, and I dissected it. I didn't find it was any different from the usual nasal prongs that we use, except that it ends at that junction of the two limbs, and then there is a adapter which can adapt to the usual whatever our things. Apart from that, it is no different from our usual nasal prongs. The caliber is bigger and the material in which it is constructed is better than Ramson's. So I was just wondering on what basis we are all sort of accepting it as one of the mode of non-invasive ventilation. I was really curious. I mean, I'm not against anything, but I'm just curious because it is, I would say, grander prongs, which has been, the tail has been cut and it has been adopted to use for a settlement.
I'm so glad, Dr. Srinivas Murthy, you brought out this point about RAM cannula. I had my hesitations because of the fact it is now marketed last 3 years in this country. I wanted to bring it about. It has not undergone any robust clinical trials at all. The nurses, especially in the United States, doctors and nurses find it very easy. And it's very easy for transport because in my own unit, from the labor room to the NICU, it's easy and it gives maybe some CPAP. We probably use it along with the TPs in case we want to use some kind of positive pressure beds in the way. But once the baby comes to the NICU, we don't use the RAM cannula at all. We have not been. In fact, I am very, very worried about using it because the pressures it gives is not very sure. Nobody knows. And it's not undergone any robust clinical trials at all. In fact, sorry to say, but Dr. Ram is a very close friend of mine. I myself expressed my worries about this to him, but that's when it's not really approved even in many units in the Western world. I would say the standard of care would be still your standard interfaces like Hudson prong, or you can use mask CPAP. That would be a better mask thing with the NIPP. I absolutely agree.
Thank you
Sir,
very much.
just to let you know what you said, the study which you are doing, of course, in a smaller way as a pilot, we did it in 2009, which we presented at the European Society for Pediatric Research, a very similar thing, which you are now doing as a RCT. And we also, I'll share with you maybe the data related to that also, where we did find that the need for mechanical ventilation becomes lesser if you were to use it as a primary mode, the NIPPV. But I'll probably share it with you.
I completely agree with you, sir. There is no, I wouldn't contest your finding, but my argument is this: CPAP is a different mode, entirely different mode, because the gas movement occurs because the babies breathe. Whereas here, we actually pump the gas in, either to the nose or to the trachea. So even with the common sense, we can say, tell that the failure rate should be less, because we are actually pumping the gas. So that was my argument in that article, and probably if you find some time,
definitely I'll find time to read that article. It sounds very interesting. It's a very good thought. See, CPAP, the baby is spontaneously breathing and is inhaling, and here you're pumping. I absolutely agree with you. Absolutely agree with you.
It should be better than CPAP in that sense.
Yes, definitely. It's wonderful.
Thank you very much, sir.
Thank you. It's nice to see. In fact, you have done so much work on respiratory systems. In fact, one of your earlier projects on oxygen saturation index, we did very similar, and we presented at the Pediatric American Societies. We found that was, very, very comparable to oxygenation index also. We really respect you for your work on that, which you published in Indian Pediatrics, I think, a few years back.
The recent one is in European Journal of Pediatrics, sir. That was 2 months ago.
Okay.
That is the validation study. The one which was published in Journal of Neonatology, Clinical Neonatology, was probably 2.5 years ago. That was a pilot study. The one which we have published just 2 months ago is a validation study, sir. Now completely validated index.
Excellent. So I should go through that. Thank you.
Yes, thank you, sir. Thank you.
Very nice.
Sir, Dr. Srinivas from Coimbatore, sir.
Hey, how are you, Dr.
Hello, sir.
I'm fine, sir.
Thank you.
I think just answering to the question of Dr. Srinivas Murthy, I think the main difference is we are not intubating.
Correct.
So that's the difference, because that's not an invasive technique which you're following. So I just wanted to bring out that fact. Because we are not intubating, it's still a non-invasive method of ventilation.
Yeah.
I think your lecture also was very good, Srinivas.
Thank you so much.
Excellent. Okay. Thank you very much.
Abhishek, you are muted. I can't hear you.
So there are no questions from the delegates.
Yes.
It's nice
Okay.
to hear the argument for and against Ramscanla. I would say there's nothing for Ramscanla at the moment. So the physiological experiments are showing that Ramscanla is able to deliver 70% of the set pressures. But we need, as you say, we need more robust clinical trial data from India as well as from the Western literature to make it as a standard of care at the moment. So I think we agree with you that probably Hudson prawns and mask are the primary nasal interfaces. For Ramscanla, I think time has to answer.
Yes, correct.
So thank you, Karthik
Thank
sir,
you.
and thank you, Srinivas sir.
It's very
So we'll
nice.
break for a lunch for 30 minutes.
Yes.
And we hope to see you back at 3 o'clock with the next talk. Thank you, everybody.
Thank you. Thank you so much. Thank you.
So I think after a long day session, so we have very short session left with us. So we'll have one talk followed by one workstation, one talk, one workstation. So just to break the monotony. So the first one will be on humidification. For the talk on humidification, we have with us Dr. Mani Kumar. So he is the assistant professor at Chengalpattu Medical College. He did his DM neonatology from ICH Chennai. So he's going to take us through humidification. What exactly is humidification? Why is humidification necessary? Is there a difference in humidification temperature when you manage term and preterm babies? What happens if you do not provide appropriate humidification? So let's learn from him. So over to you, Mani sir. Yes. Okay. A very good afternoon to everyone. First of all, I'd like to thank the coordinators for inviting me for this talk. Basically, my topic will be on gases and humidification. So I would like to cover most of the basics alone in that. So there's a mixed crowd, and where some are already practicing and some are about to practice. And it's always better to have a look into the basics of all these gases and humidification. So my overview will be to give a brief introduction about the sources of gases and their properties, and about the physiological aspects and the need for humidification, and what are the available types of humidification that are available. So coming to gases, we are dealing with only two types of gases. One is air and other is oxygen. So air, for some reasons, it's very easy actually. You just need a compressed source. It's very easy. If you have some electrical connection, there are various sources available even at the bedside. And in big hospitals, there are compressed sources of air also. So as far as the oxygen is concerned, there are various sources of oxygen. People during this COVID season are very much aware of all the sources of oxygen. So the common sources are something like these oxygen concentrators. So these needs a power source, but they are very easily transportable, and they are typically used for low flows of oxygen, not typically used for delivering CPAP. Actually, you can't rely on that for delivering a sufficient amount of CPAP for a continuous long run, actually. So the typical use are these oxygen cylinders in most of the hospitals. So usually this oxygen is stored as a compressed one. So they are having a 137 bar pressure, so nearly 2000 psi's. But the thing is that the capacity is limited, and they require something like what is called as the pressure gauge and regulators. So as you can see, the A is the cylinder and B is the control knob or regulator, and C is the flow meter which is attached to that, and D usually it's connected to a humidifier if you're directly giving oxygen. And there are various types of cylinders. These are the commonly used ones: D type, E type, F type, G type, J type. And in many of the hospitals, they still use and rely upon these oxygen cylinders, where they keep it as a manifold. They combine many of these cylinders into a single one and deliver through pipelines to all the babies inside the ward. So still, even now, many of the big hospitals, even in the city, run like that only. So that is how it is being done actually. So that is typically called as the oxygen manifold, which requires a one-time investment for all your oxygen lines. But honestly, I would say that they are very safe. So the only thing is that they will run out of oxygen soon. You have to replace all these cylinders. But if you have a facility for replacing it, it should not be a big problem actually.
So another one typical is this liquid oxygen. So what is liquid oxygen? Basically, so any state of matter will exist in three states: solid, liquid, and gas. So as you go up the temperature, it turns from solid to liquid. As you go up the temperature, it becomes liquid to gas. We all know that oxygen is a gas in room temperature. So the actually boiling point of liquid oxygen is minus 183 degrees. So they reduce the temperature or pressurize so much to reduce the temperature and fill it in some tanks and containers. So you have to know that the expansion ratio is 860:1, by which what I mean is that 1 liter of liquid oxygen can give 860 liters of oxygen. That is the biggest advantage of this. So it's very similar to an oxygen cylinder, but it is more pressurized and the expansion ratio is huge. And they can be transportable like this. It can be manufactured at one site and it can be transported through a lorry also. So you can replace it as and when needed. So they can provide some huge amounts of oxygen as and when it is required. They occupy less space because it is very much compressed and they are safer. But again, it requires pipelines to be there in the, please. Expansion ratio. So inside that is so much of compressed. So if you release that 1 liter of liquid oxygen, it will give to 860 liters of oxygen. So the how much it is compressed, you are just to create the impact of that actually. So that is how it is compressed nearly. The expansion ratio is nearly 860:1. So it's not just the amount of liters in the tank that you can use that alone. It is so huge. Even a small carry bag oxygen is also there, as you can see in this picture. So some of those patients can even carry those liquid oxygen like a backpack. So it's so handy, so it can last for 1 day for those who are on CPAP also. I mean, who are on COPDs, they require if the oxygen is still used like that also. You see, this is a development which is happening as of now. Another thing is that oxygen plant. So basically, the biggest problem with the oxygen plant is that it is a large on-site central source. It requires power. It occupies a huge amount of space. So when you're going to install an oxygen plant in your unit, it consumes a lot of space. It requires a power source. So because it requires a power source, if it goes down, it's always better to have a backup cylinder with you. So that's how it's being done actually. So needs an adequate infrastructure and also, of course, pipeline systems with the need for handling heavy cylinders between wards. If there are no pipelines, what we generally do is to push the oxygen cylinder from one ward to other ward so that it can be used. So just to give a brief outline about what are the typical sources, you may be starting your own hospital. So you have to think of all these things as to which is your best source possible for you. Still, as I said, the common source of oxygen is oxygen cylinders. We call it as a jumbo cylinders. All those nomenclature of A, B, C, D, that is actually outdated, but that is what is still being followed in India as of now. So I'd like to restrict myself to all those types of cylinders actually. And after this oxygen is made available, to deliver, there are some intervening devices which are called the air conditioning or regulating devices. So we have called as what is called as a diameter pin index system. So there are many index systems available. One is a pin index system or the diameter index systems. So it depends upon varying size of diameter. It will be one for oxygen, one for air, so that you can't cross fit. Similarly, pin for oxygen. You would often notice that when you try to insert a oxygen pin into an air pin, it won't fit in. So that is a pin index system basically. So this is a diameter index system. And there are some regulatory cylinders, and this is called as the barbed connector system or the Christmas tree connector. And this is one of the traditional humidifier bottle which we use. And commercially, there are various things available. Most of them ignore some of the safety aspects in that as well actually. There will be some safety regulator, pop-off valve, and you can have a minimum regulator level and a upper regulator level. The height will decide the resistance as well as the degree of humidification. But all those are very low levels of humidification. And in resource limited setting, from even one pin, you can have two systems. So these are also available. So just know the types of regulatory systems available. And these are the typical commonly used, the so-called Thorpe level. These are called the Thorpe flow meters. And in flow meters, it is the standard thing that either you will have something like a round bubble, or you can have what is called as the a triangular one. So there are certain nomenclature as to how it has to be read. For these round things, the middle part is what is the flow mentioned. And for these triangular one, the upper part is what is level. So both are actually 4 liters per minute. So that's how it is actually. And there are some pressure monitoring systems as well. How much is the pressure that is available there, you can measure. And actually, if you consider a CPAP, there are only 2 important parts in it. One is a blender, another is a humidifier. Blender costs around 65 to 80,000. Humidifier costs around 80 to 100,000. So literally these two consume the whole amount of CPAP machine. There is nothing else in that. So many companies will be willing to give you some cheaper CPAPs. They will compromise one of these two. Either they compromise the blender or they compromise the humidifier. So it's very vital as to why these are essential. I think this question will be very easily answered. Why is FiO2 important? What are the hazards of giving unmonitored excess oxygen? Everyone knows the effect of hypoxia. Hypoxia will behave typically like hypoxic ischemic encephalopathy. You can have long-term neurological outcome. Similarly, hyperoxia, what are the harmful effects of that? Free radical. Because of that, what is the outcome that we see? ROP in a preterm baby. Very good. What else? In a term baby? Yeah, literally every possible disease is linked with free radicals. Be it be the 4 major morbidities of preterm: IVH, PDA, NEC, ROP, BPD. All those are linked in the short term. Even the long term neurological outcome is linked with free radical injury. Not only that, even the hyperacute effects. Say, for example, you are using that unmonitored oxygen in the resuscitation room for a few seconds, hardly a few minutes, not even few minutes, few seconds. Even now we have robust data to say that you should not give excess oxygen in the resuscitation room itself. What is the big hazard is that it delays the onset of spontaneous breathing, giving excess oxygen. So people are trying to reduce few seconds of high oxygen exposure as well, leave alone unmonitored for a long time. So know the effects of unmonitored oxygen. So it can have short-term hyperacute effects, acute effects, short-term effects, long-term problems, all are there with oxygen. So we have to use blenders. So this is the higher end model. So we have some automated blender which is available, which have just a knob, and you can have take 2 ports out of that. Not that one is air and one is oxygen, both are oxygen. So one will be a high flow meter and another will be a low flow meter. Low flow meter for low flow oxygen like 2 liter, 1 liter, 0.5 liter, 0.25 liter. You can take it accurately from that. The maximum flow in this low flow is only 2.5 liters or so. So you can adjust very accurately this low flow. So these are also available, and 15 liters is the usual flow meter which you have in most of the wards. Up to for 15 liter flow meter, it's very difficult to titrate 1 liter, 0.5 liter and all. With this low flow meter, it's very easy to titrate. So both these require compressed air source and compressed oxygen source. If you don't have any air line, you can't use a blender. Literally, it's that. So you should have a air line in situ to use these blenders. If you don't have these two, because this, as I said, a good blender costs nearly 65,000 at least. So if you don't have enough money or if you don't have the enough resources, what you can use is that just use a Y connector. Just like a oxygen flow meter, you have air flow meters. That's very cheap, hardly 1,000 rupees or 2,000 rupees or so you can get it. So you get it, you connect one in oxygen, one in air, you get both tubes, you get a Y connector, you connect it and take it out. So you can blend manually how much flow you keep for oxygen, how much flow you keep for air. So based on that, you can have what is called as this flow tables. It's a very simple formula, but most of us don't like formulas, and that's why we took medicine as a career, right? So I think this table will be suitable for most of us. You can use it in wherever you want to blend it and you can put it. So say for example, if you take 1 liter of oxygen and 6 liters of air, still it would give 32% FiO2. So that is how it works actually. So you can blend even, these are called as the so-called mechanical blenders. So why I'm saying all these things is that there are hazards of oxygen. That is the only underlying thing, nothing else. So try to avoid that. You can do it in a sophisticated way or a very cheaper way, but make an effort to do it. That's it. Then comes humidification. As I said earlier, all compressed gases are dry and cold because they have to be dry to get them compressed into that particular cylinder also. And only if you make it solid, you will be able to reduce the volume. So they will be cold. So they are essentially unhumidified gases. So as I said earlier, so these are the three forms of anything, any matter for that matter. Okay, solid, liquid, and gas. As we go higher up in this order, this is the basic chemistry, which I took it from my kids science school actually. So they only taught me. I was wondering as to how to make very simplified when I saw my kid reading this, and I took that slide from her actually. So from solid to liquid to gas, as we go higher up, you can see that you have to increase the temperature and you have to increase the heat energy. So the only thing is that gas is a higher form of matter which inherently has some energy. If you add energy to solid, it becomes liquid. If you add some more energy to liquid, it becomes gas. The energy most commonly added is heat energy. But actually this is what is called as the latent force of vaporization or latent energy of vaporization. So water molecules are naturally attracted to each other. If it is in water, it gets clumped to each other and it will be like this. But when they are in water vapor, they repel each other because of the inherent energy in that. So you need some energy to repel each other. So that's the basic physics of it. And then this will be the most important talk for my most important slide for my talk. So whenever we talk about humidity, the previous slide is very important to understand this slide. So this is the maximum amount of water that air can hold. So as you can see, the maximum amount of water that air can hold increases with temperature. So these are very magical slides actually. For 37 degrees, the maximum amount of water vapor that air can hold, say for example, 1 liter of air. At 37 degrees, 1 liter of air, maximum it can hold 44 milligrams. And at 30 degrees, it holds only 30. So this, beyond that, what will happen? If you try to imbibe some water molecules into the air, it will form condensation. Below that, it is half saturated. We can still add some more water vapor to that. So that is the concept of absolute humidity and relative humidity. What do you mean by absolute humidity is that, say for example, you take 1 liter of air, how much amount of water it contains, that is absolute humidity for that water. Say for example, if for 37 degrees, it contains, say for example, 30. Now you keep 1 liter of air. Now that air contains 30 milligrams of water vapor. The absolute humidity is 30 milligram per liter. But what is the relative humidity? It depends upon how much is the maximum that it can hold. And we very well knew that for 37 degrees C, the maximum that it can hold is 44. So for 44, now you are holding only 30, which is somewhere around 66% or 65%. Okay. So that 65% is the relative humidity. So when there is air at 30 degrees, I mean, so for 37 degrees, you have only 30 milligram per liter. It can hold up to 44, but it is now holding only 30. So that means it is 66% of relative humidity and 30 milligram per liter of absolute humidity. So absolute is in absolute numbers, how much amount of water it contains. Relative is relative to how much it can hold maximum, how much it is now. So as I said earlier, see typically for 30 degrees, this much is the water vapor now it contains. Now if you reduce the temperature, it becomes now the water is the same, but you are now cooling the gas. Now the ability to hold water vapor decreases because in lower temperature you hold only a relatively lower volume. So for example, this is 100% relative humidity. So this is how it should be. So if you increase the temperature, relative humidity decreases, but the absolute humidity remains the same between all these three things. You can see that the total amount of water vapor is the same between these three. But as you increase the temperature, the holding capacity increases. So this is the only slide which I want you to understand the concepts of absolute humidity and relative humidity. And these values are the typical values. Say for example, your medical gases, they are typically cold and compressed, usually at 15 degrees. They contain a relative humidity of only 2%, absolute humidity of only 0.3. For all practical purposes, it's taken as 0. So they are dry. So all the medical gases which are available from your source are all dry. And for room air, so it is typically a 50%. What is there in our conventional room? We take it as 20 or for an average Bangalore climate. For Chennai, I should have taken 30 degrees actually, because I came to Bangalore, I thought of putting it as 20 degrees. So it's relatively 9 milligram per liter in the atmosphere normally. And in the lungs, this is our core body temperature, 37 degrees. We need that 100% relative humidity with a maximum humidity of 44 milligram per liter. That is what we desire upon. When the gas reaches the lungs, it should be like this. That is normally done by the humidifying mechanisms naturally existing in the body. But when they are bypassed by putting a tube, or when you give so much of flows to overcome that normal saturating mechanisms, you are supposed to humidify externally. That is the whole process of humidification. So another point is called as what is called as dew point or condensation. As I said earlier, when the temperature is high, it can hold a large amount of water. When you reduce it, it can hold a smaller amount. At one stage, it becomes 100% relative humidity. What happens when you reduce the temperature still further? It can't hold. Already it's cooling to the maximum. So the remaining water will form as water droplets. So the temperature beyond which there are some water droplets seen is called as the dew point or the condensation point. So know the concepts of what is relative humidity, what is absolute humidity, and what is dew point. So having known this, what are the problems of condensation? Why not? What? Water only, right? What if it condenses and settles in somewhere in the circuit or not? Of course, it's pure water. It's not like that. There are many problems with that. So one problem is that you have to understand that water vapor is 0.001 microns. Virus is around 0.3 microns to the maximum. Bacteria is around 1 micron. But your water droplet is nearly 40 microns. That is a problem here. A 40 micron water droplet can easily carry all those bacteria and virus along with it. And it spreads as carriers for infection. But when it is in water vapor, there is no possibility to act as a carrier. So that is the problem with condensation. So humidity as water vapor is safe, but as liquid water is a problem. So naturally, when there is more of water droplets, you go from your what do you call as the infection to your colonization to just a commensal. So it increases the risk of your infection to a greater extent. Another problem with condensation is that it occludes the tube and it hinders the delivery of pressures. So when you give a proper humidifier with no condensation, you can get some adequate pressures like this. But when there are some condensate like this, you can get a varied pressure. It's a very classical experiment. So condensates, one problem is infection, another problem is with delivery of pressures. So your pressure delivery may be inadequate when there are some condensates in the circuit. These are the two problems with condensation. So another most important thing is that it delays the mucociliary clearance of the airways. What happens in your airways? Normally the existing mechanism for clearing all those mucus is ciliary beating. So again, it increases the resistance to a greater extent. This is a Poiseuille's law, where your resistance is inversely proportional to the fourth power of radius. People will often say like this thing, even if you put a tight fitting tube in the trachea, it reduces your cross-sectional area by nearly 25%. If you go one size lower, it will occlude nearly 50%. And if that is occluded to some extent by your mucus like this, your airway resistance is literally gone. It increases to a greater extent. So clearance of mucus is very, very essential, basically. It increases your work of breathing. So it complicates your ventilation. You may find it very difficult to ventilate if you are not humidifying adequately. So what are the direct effects? We can see most of the time we will see some tubes like this occluded. I just changed the ET tube because it is occluded. I saw it visibly, it is very grossly occluded. The first thing when you see such a thing is that you check your humidification. Because of your improper humidification, only things are happening like this. And this is a late effect, totally occluded and baby is totally gasping and all. At that stage, you saw that and you remove the tube and reventilate. So in the early stages, you can have what is called as the atelectasis. Whenever a baby on CPAP develops atelectasis, the first thing you have to concentrate upon is humidification. So your atelectasis, ET tube block, increased work of breathing, risk of infection. So all these are problem with just a condensation or improper humidification. So this is what we expect: a good humidity, a good mucociliary clearance. It prevents heat and moisture loss because you are maintaining to the optimal effect. But when there is pure humidity, it dries up the mucus and heat and moisture loss is also there. So these are the direct effects which you can see very obviously or very easy to understand for you. This airway damage depends upon the time of exposure of inadequate humidification, literally. At one stage it becomes thick, at one stage it becomes a clearance stop and total ciliary damage and total cell damage. So this process will be greatly halted by using a proper humidification. In addition to that, so these are the indirect effects. What effects in addition to all those things? We all know that for a neonate, we need around 120 calories per kg per day. How is that 120 calories per kg per day utilized? Some are utilized for basal metabolic rate, some are used for thermoregulation, and some are used for normal nutritional processing, and some are used for activity. And when you consume all the calories for some other purpose like this, you burn out all the energy for some other purpose by increased work of breathing. Just because of an improper humidification, you will not have a good thermoregulation, you will not have a good growth, you will have a reduced activity baby will be in metabolic stress. So all these are indirect effects of improper humidification. So don't underestimate the effect of a proper humidification. So this is what is called as the isothermal boundary. We know that air is 50% relative humidity, which contains only 10 milligram per liter. But when it reaches the lungs, it comes to 100% humidity with a 44 milligram per liter. So when the baby inspires and expires, there is a isothermal saturation boundary. So this is where the 100% saturation, 100% relative humidity is achieved. Normally this saturation boundary is just before the level of your bronchiole. Just before it reaches trachea, it should be there, literally at the level of carina between that, the bronchiole. What happens when you give dry gases, when you overwhelm or greater flows, this isothermal boundary is shifted down. And when it reaches the alveoli dry, your alveoli is gone. So we want to push this isothermal boundary as much as possible to a higher level to reduce the workload spent for humidification by the baby. So we try to maintain the isothermal boundary, not to reach the alveoli. That is our whole aim for a proper humidification. So what are the types of humidification? We can have what is called the passive humidification. We don't add any water. We just add something called as the HME filter, heat moist exchanger, where you try to conserve the moisture exhaled in the baby's air and give it back to the baby. We don't add anything, but you try to capture whatever is the baby is exhaling. We try to add that and give it back to the baby. That's what we try to do. We conserve. This is a very low level humidifier. It's not advised actually for not the only thing advised. Some use still as a filter for virus. That's an added advantage, but still that alone can't be sufficient. We rely upon what is called as the active humidification. So active humidification, we add water vapor to the gases actively. So the types of humidifiers are bubble humidifiers, heated humidifiers, and servo control. So as I said earlier, the bubble humidifier contains a pressure relief valve, an inlet, a source, and 2 water levels. This can achieve up to a maximum of 10 to 20 milligrams per liter. You can't rely upon that for more. So that's a very low level. That's not all sufficient. You can't give that directly. So these humidifier are what is called as the passover humidifier. It can be a simple reservoir, or some will contain what is called as the wick units to create more surface area to make it more effective. So these are the different mechanisms. These are the very old types of humidifier where you have to keep how much heat is delivered to the humidifier manually. We can adjust on a time scale, or you can have 3 level, 1, 2, and 3. So these are very older models, literally. Still they are being used in many of the units actually. Much better than all those simple or non-humidified gas actually. Here you have to control the temperature of the chamber. Control is in your hand. You have to sit with the baby and find which is the optimal for the baby to deliver the optimal humidification. You have to do a lot of work. And these servo control humidifiers are the top end model. And literally, I have to say that Fisher and Paykel is the undoubted empire. They have literally a huge technology. And this is the outcome of all those things. This is the ideal one for neonates, and they are coupled with heated wire circuits. So what is the advantage of heated wires? So this is our ideal target. So we have to get an absolute humidity of 44, relative humidity of 100, no condensation. Condensation, infection, relative humidity less than 100%, suboptimal. Absolute humidity less than 44, again suboptimal. So this is the optimum that we should desire for any baby, literally. So this is a typical circuit. So here you can see that the inhaled gas is coming and getting heated in the humidifier. So what we ultimately want is that to the delivery to the baby, we need 100% RH and 44 here. So to achieve that, we are measuring the temperature here. So this temperature should be somewhere around 40, because there is a temperature drop of around 2 to 3 when it goes from this monitored end to the lungs. So we achieve a temperature of around 40. So 40, we keep it at a higher temperature so that also there is no condensation. So what is the temperature desired here? Here it should be 37. What will happen if you keep more than 37? It will hold more water. That water has to be lost somewhere before it reaches the baby. So beyond 37, if you take, there will be more of condensation. Less than 37, you can never add water in between. There is the only source of water. There is no water after that. So you have to keep a temperature of around 37 here, but here it has to reach to 40. How is it being done? It's by the use of the heated wire. We use a heated wire to heat it, so that prevents condensation, as well as you heat it to 40 here. So these are the typical values you need. 37 here, 40 here, and when it reaches the baby, it comes to 37. That's all. So you have to know the advantage of a heated wire. Without heated wire, it can't be achieved. So heated wire has its advantage. Servo control reduces your work. Active humidification is the way. So these are the only take-home points that I need to carry you. So how do you assess optimal humidification? Of course, I'm not sure whether it is very clear. Okay, you can see that. You need to see the beading or misting in the chamber. There should be some visible beading or misting in the chamber, and some condensation in the expiratory limb is okay. And people nowadays don't even want this to occur. Why to get that condensation? You heat the expiratory limb also. Nowadays, dual limb heated wire circuit are coming to prevent this type of condensation also. We don't want this type of condensation also. Some people feel like that. Why to keep some unnecessary source of infection? So condensation in inspiratory limb is definitely avoided. So I have to place the distal segment of inspiratory limb inside the radiant chamber of the incubator. That is one thing. You don't keep your CPAP machine and ventilator machine as away from the baby as possible. Try to bring it close to the baby so that temperature difference between the inside and outside are the same and prevents condensation to a greater extent. These are simple things which you can do, and keep a warm temperature, room temperature of around 26 to 28. So these are the simple things that you can do. That's all. I think we come to the end of our discussion. And I hope if you understand the simple basics of humidification, it will be okay for this talk. Any doubts, I'll be glad to clarify. Yeah, that's a good question. Yeah, there are various types of water. Many units still use what is called as the RO water, the plain RO water, which is available. I would say that's fairly okay because no bacteria survives at 40 degrees. We are going to heat to 40 degrees and all this water is going to stay there. But actually the recommended gas is a sterile water, medical water actually, that's available in a compressible bag and you have to keep it dripping in the humidifier. And that has to be a closed system. So when it gets consumed, water drips in automatically. The volume also doesn't change. And all those calibration done while you are ventilating the circuit initially, that also depends upon how much dead space it has and how much volume it carries. So when the water level goes up and down, that calibration also has no meaning then. So the ideal thing to do is to use a sterile distilled water, medical grade in a compressible bag available as 500 ml or 1 liter bottle, which is given to the humidifier as a closed system. There's something in between this, between RO and sterile water, we have something what is called as a de-iodinized water. Some people still prefer to use normal saline. The problem with normal saline is that it settles a lot amount of salt. You can't use the same for 24 to 48 hours. You can see a visible salt deposition. So that again changes your mechanics degradation. That's not advisable, though medically sterile. So it's not about the sterility. It's about a lot of volume changes that we take care to by giving sterile distilled water in a collapsible bag. Any questions or doubts?
Hello. Srinivas sir, are you able to hear us? Dr. Srinivas sir, can you unmute yourself? Dr. Srinivas, can you unmute your?
Yeah, unmuted.
I'm able to hear you, sir. Can you make full screen, sir? No, minimize Babri. So our next talk is about stabilization and transport on non-invasive ventilator. Dr. Srinivas. So he's a consultant neonatologist at Kowe Medical Center and Hospitals, Coimbatore. So he's going to take us through stabilization and transport with non-invasive ventilation. So Dr. Srinivas actually has done his neonatology training from Australia, and he'll take us through that. Sir, we are ready for your talk, sir.
Yeah, okay. Good evening, everyone. First of all, I would like to thank the organizers for giving me this opportunity today. Today, the topic given to me is stabilization and transport on non-invasive ventilator. The thing is, a lot of people have talked in the morning about the non-invasive ventilation. I thought I should stick to minimal on non-invasive ventilator and talk on more on stabilization. Plus, I will be covering what is the importance of NIV in stabilization and during transport. So coming to the introduction, medical transport itself is a very high risk and critically ill newborns, and it's a huge challenge to transfer these babies from one center to another. Luckily, I had a good opportunity when I was in Australia, when I was working as a fellow in Westmead. The New South Wales emergency transport team called me whether I could work as a casual. And that was a lucky break for me. I worked for almost 2 years in that, working whenever I was free. And it was nice to learn also, and it was a good money. Generally, for these transport, it requires really skilled persons and specialized equipments. Otherwise, we will end up in trouble while transporting these babies. Neonatal transport team is composed of a tertiary care neonatal intensive care unit, a perinatal care unit where they can receive the mother and deliver there, and then we can manage these babies. It also requires medical and surgical pediatric subspecialties to manage all the complicated babies, and a neonatal outreach program. This is very important because the centers which are sending us the babies, they should be able to stabilize the baby at least to a certain extent. Otherwise, by the time we reach there, we'll have significant difficulties in managing these babies. So there are a lot of programs organized, especially in Western countries, where they teach the peripheral center also to manage these babies appropriately in the initial stage. A baby delivered outside a tertiary care center is called as an outborn unit, and a baby delivered in a tertiary care center is called as inborn units, where the baby is being managed for all problems. Common indications for emergency neonatal transfer is respiratory distress and respiratory distress syndrome. So pneumonia, meconium aspiration, barotrauma, pulmonary hypertension, and lots of surgical issues could be the reason for neonatal transfer. This neonatal transport can be divided into 3 types. One is before transport, then during transport, and after transport. So before transport, stability of the baby should be taken care. During transport, you have to accept the challenges you will face during transport. And after transport, once it reaches the tertiary care center, active treatment should be started immediately for the success of these transported babies. Each step is very critical for the success of the neonatal transport. Stability of the patient's condition is a prerequisite for a safe transport. Good transition after delivery makes a transport more easy. So this is where you'll have to communicate with the referring doctor. So if the baby is getting delivered at any stage, the initial management has to be advised how they should take care. If we have an experienced pediatrician or a neonatologist there, we don't have a problem. Otherwise, if it's a rural center, then we have to advise the doctor who is looking after the babies about the initial care, because management of the first few minutes and hours after birth is the key to survival for these transported babies or sick babies. And shortened interfacility transport time leads to improved outcome. So we have to plan whether this baby has to be quickly transported or whether this baby can go a bit slowly. Based on that, in a lot of Western countries, we have got different types of transport system, road ambulance, then you have got air ambulance. chopper ambulance, all these things. So depending on different outcomes and different distance, they decide on that. Remember that despite advanced training and technology, mother usually makes the best transport incubators. So as far as possible, if you plan to transfer a baby, it's better to transfer the mother in utero for delivery in a tertiary care center where the outcome can significantly improve. So these are some of the transport. Here I've got a road ambulance and the interior of the road ambulance. And this is the chopper helicopter. And this will be the fixed wing. If you have to travel really long distance, then this would be the most ideal. And helicopter will be the quickest way of transferring the baby if it's an urgent case. Now, steps for transport. I'm just taking a scenario to begin with. We get a call from a regional center, say Primey 27 plus 2 weeker, and she's in active labor. If you think there can be some delay of more than 2 to 4 hours, then probably steroids has to be given. The obstetrician calls the tertiary care neonatal center, and she says that there is no time to transfer the mother in utero, and there is a high risk of delivering en route if we decide to. So in those cases, we have to manage the babies in the same center, wherever it is being, mother is being managed. And then you have to give the advice to the concerned people who are taking care of the babies. And history and details are noted. Immediately transport team is activated from a tertiary care center. Remember, based on the gestation, based on the severity of the sickness of the baby, we have to decide whom we are sending. So for a 27-weeker, we can anticipate significant problem. So at least one experienced nurse and an experienced doctor has to be assigned for the transport. Generally, every hospital who are doing transport will have their own transport trolley. They will have different checklist. Checklist has to be verified, though it is sealed. Make sure it is checked again so that you don't miss things. Suppose the referring center doesn't have surfactant, you have to surfactant too. Check oxygen air cylinder before you depart, because if you don't get an air or oxygen in the referring center, you will be in trouble. So ambulance, once you get into the ambulance, please connect the incubator to the ambulance so that it can be pre-warmed by the time you reach the transport center. All these steps were followed strictly in Western countries when I was working in the transport team. Now coming to the steps for transports of a neonate. If a pediatrician is available at the regional center, liaise with them and make a plan of management of these babies. Especially if the baby is delivered there, discuss about the delayed cord clamping, discuss about the early delivery room CPAP, and also the steps of initial resuscitation, just in case the person is not experienced. And we have to talk on basic neonatal care and NIV support also if possible. And once the baby is being shifted to the local NICU, baby has to be checked with the sugar, then IV line has to be inserted. Either put in an IV line, probably they should take the counts, culture, and if needed, if there are risks for infection, antibiotic also has to be started as early as possible. Once the transport team arrives, remember the batteries in the transport trolley may not last. Immediately connect to your power cord. Make sure your warmer or the transport trolley is getting warmed again. Assess if the baby is stable. Take brief history and the patient details. And if the baby is stable and ready for transfer, discuss the plan of management with the receiving neonatologist or pediatrician. Talk to the parents or attenders and then explain the risk of transport. This is very, very important. A baby who is being stable in NICU may become unstable during transport. And so this has to be informed to the parents, but don't increase their anxiety. Just say this is a common problem which you face. Most of them can be addressed. And also don't forget to take their consent for transport. Again, continuation, if unstable, you have to stabilize this baby. Otherwise, you'll be really in trouble during transfer. If time is available, wait and watch once you're stabilized, just to make sure baby will be stable throughout. Again, discuss with neonatologist before transport. Reconnect oxygen air to the transport equipment, then transfer NIV support to the transport equipment. Shift to transport incubator. Baby can be shifted now. Be careful whenever you're shifting from one place to another because the tubes, lines, and the equipments may be a problem. Take help from the local hospital nurses also. Make sure you don't have any trouble while shifting because dislodgement of lines and tubes could be detrimental. Now, anticipate problems throughout while you're transferring because the baby is going through the Sorry, I got a phone call. That's fine. Baby is going through a bumpy roads while being pushed here and there, and therefore these baby can become really unstable while shifting. Then once the baby is shifted to the ambulance, again, don't forget to connect to the power plug. Otherwise, your warm will not work functioning well. And also connect to the central oxygen and air in the ambulance. Be aware always that baby can deteriorate during transport. So that's one of the reasons why you have to make sure you stabilize the baby completely before you go for a transport. Arrival at the tertiary care center, shift to the NICU, following the same safety precautions, and then transport equipment has to be cleaned immediately by another set of people who are not taking care of the baby, and restocked, and all items has to be sealed so that for the next transport, the transport system is ready. Now coming to what are the things we have to monitor. So other than ABC, airway, breathing, circulation, there is a condition called the system as stable. So S stands for sugar and safe care during transport. Most of the babies can have sugar issues, especially IUGR babies can drop the sugar because of the inadequate glycogen stores. Extreme premature babies will not have enough glycogen stores. Therefore, sugar can drop very quickly. So sugar monitoring will be one of the most important criteria. And if the baby is infant of diabetic mother, hyperinsulinemia itself can cause problem with sugar. So sugar monitoring is again important. Watch for signs of hypoglycemia and frequently monitor the sugar values and make appropriate changes in your treatment. IV fluids has to be commenced and running. Think about whether this baby just requires an IV line or will require a UVC, because some babies, if they get really sick, requiring high amount of glucose, or if they require inotropes, UVC will be very handy. So this is one of the things for stress. And then temperature. So temperature also has to be managed throughout. We know that temperature stability is very important for the outcome of these extreme premature babies. So we have to take care, prevent conduction, convection, evaporation, and radiation. I can't go through the details of this because beyond the scope of this lecture. So now coming to A and B. A is for airway. Airway has to be supported throughout. And here we are managing with non-invasive, provided the baby is stable. We'll discuss about what are the prerequisites for non-invasive ventilation. So oxygen has to be given as appropriate. Never target higher oxygen than the required oxygen. 90 to 95 should be the target oxygen always. If needed, ABG has to be done. Always look for complications if the baby suddenly deteriorates, like a pneumothorax or a airway obstruction. And remember, blood pressure has to be monitored for every baby who is sick, because if the baby's blood pressure drops, this baby can get really sick quickly. So baby could be in hypovolemic shock, baby could be in cardiogenic shock or septic shock if it is a sepsis. So management has to be accordingly done with a bolus or inotropes or a soda baker if there is significant acidosis. Now LE, so stable. Last one is lab work. So prior to the transport and after the transport, we have to have this lab work. We have to take the counts, culture, electrolytes, and appropriate management has to be started. One thing which we need is maternal blood for cross-matching. So nowadays, most of the transfusion specialists seek maternal blood for cross-matching for any blood transfusion for the baby. So we can't go back to the same institution to get the blood. So always take maternal blood for cross-matching to your center. And antibiotics also may be needed for every baby because of the risk of infection. And also take every note what the baby was being given there. That will be important. Emotional is the parents and their attenders will be really in emotional instability because of the premature baby. So you'll have to talk to them, give them a lot of confidence, and tell them generally the outcome will be generally good, build their confidence, and then explain the risk of transport and take their consent. Now, pre-departure stabilization. There are three methods. One is method one. This is what our 108 ambulance does. The transport team comes in, takes the patient, quickly loads onto the ambulance, and then shifts to the nearest hospital possible. So this could be dangerous. Anything could happen during transport. Method two is the safest method, where the unit is maximally stabilized prior to departure from the referring hospital. This is the safest method. This minimizes the need for interventions en route into the NICU, that is tertiary care center. Method two is used more often with the transport teams and with highly skilled people. Longer ground or fixed wing transports also requires method 2, otherwise babies may not survive the method 1. The next is combination method. When it is rarely a bit urgent, or if you think the facility in the referring hospital is not enough to take care of the babies, do a quick stabilization. Say, example, baby has got a severe RDS with high oxygen requirement. Give a dose of surfactant, connect your NIV, and then shift the baby. In case the baby has got a pneumothorax, put a chest drain in or drain with a butterfly needle and then transport the baby. So this is combination method. Now coming to the non-invasive ventilation for transport. This has become very popular nowadays. In the last 2 decades, this NIV ventilation, because when I was working in Newcastle also, we used to do a lot of NIV transport where we never faced a problem during these transports. NIV techniques for respiratory support during transfer is increasing. Intubating all infants with significant respiratory distress is decreasing. Determine the best NIV technique required for each baby. But again, studies are not favoring one or the other, but we don't have enough studies for the latest methods. Many neonates can be transported on any of the NIV modes, but we have to select the correct one. During the past 2 decades, steady increase in use of NIV during transport has come, and this has been accomplished due to multiple reasons. One is because of advanced management of these babies, increased use of antenatal steroids, high-risk maternal transfer to level 3 facilities, surfactant replacement, and improved resuscitation protocols, especially the early CPAP and the delayed cord clamping has really helped, and improved knowledge about managing these babies. This has improved our NIV transport facilities for these babies. Now, criteria for considering NIV transport. So we can't transport every baby on NIV because it will be, these babies may get really sick. And just remember, during transport, every procedure will be difficult. So inclusion criteria for NIV transport is acute respiratory distress, chronic lung disease, stable on some form of NIV support for 2 or more hours in the referring hospital, chest X-ray showing adequate lung expansion, and FiO2 50% or less than that, and arterial PaCO2 less than 60 and stable, pH greater than 7.3. These are all subjective. If you think you can stabilize these babies, stabilize, make everything correct, and then you can transport on NIV. Again, exclusion criteria. So if the baby has got severe PPH and unresponsive to nitric oxide, then NIV is not the mode. You have to intubate these babies and take full control of these babies. Poor lung expansion. If the lungs are not expanded, severe RDS, and then requiring quite a high amount of oxygen, the gases are not good, then these babies are not for NIV transport. So a HFNC requirement of more than 8 liters per minute. This is based on different studies, but it's up to you to decide while transferring. There's baby requiring more than 8 centimeters of water of CPAP, and NIPPV rate, that is non-invasive positive pressure ventilation rate of more than 20. All these are indications that we should not be transporting on NIV. Oxygen requirement more than 50%, again, is a contraindication. If the baby has got a persistent apnea, you may end up in trouble during transport. So you have to be careful. Severe sepsis with poor cardiac output may be difficult to transfer in a NIV. Diaphragmatic cardia, which is a general contraindication, has to be intubated and not on NIV transport. Relative contraindication, again, if the babies of diaphragmatic hernia is relatively stable without any support, just as we transported for surgery, then NIV transport can be tried if needed, but you have to be cautious. Baby may get sick with NIV. So these are other surgical conditions. And if you look at a gas, a pH less than 7.25 or a PCO2 greater than 60, you have to consider whether this baby will tolerate NIV transport. If you're confident enough, you can, otherwise don't take a risk, because babies can become sick during the transport. Why NIV and not ventilation? So the thing is, here NIV transport can prevent a lot of complications. So here I have mentioned few: volutrauma, barotrauma, oxytrauma, which is a silent killer, atelectatrauma, pyotrauma, and rheotrauma. All these will be reduced by this NIV. So we have to prevent all these damages. That's one of the reasons why we should try to avoid intubation wherever possible. If it is needed, definitely have to do. Types of NIV support. There are different types. A lot of people have discussed in the morning whole sessions. I'm not going to the detail about these modes of ventilation. So what are the external interfaces? Again, today morning you all listened about this. So let me not go into the details of this so that I can cover other aspects. So clinical assessment before departure to prevent potential non-invasive ventilation failure is a must. You have to assess the baby before you put the baby into the crib or before you transfer the baby to the transport ambulance. So assessment during transport is very, very difficult. So all the assessment and stabilization has to be done before you start your transport. So difficult to determine the cause of any deterioration. During transport, if the baby deteriorates, it becomes a real hard work to find out what is the cause, because just the movement of the ambulance itself could cause this problem. But at the same time, if you think that it may be different condition which is causing the problem. So you have to be very careful in assessing these babies during transport. Difficult to assess the response to any intervention, again, because the GFRD's movements, so the ambulance. Difficult to manage complications. Suppose this baby needs an intubation, you will have to stop the ambulance just to intubate, otherwise it becomes really difficult. If the baby develops a pneumothorax, again, it is a tedious job to do in an ambulance. So controlled intubation before transport is always preferable. If you think this baby is going to become more sick during transport, go for a controlled intubation and then transfer. Select the most suitable NIV support for these neonates. Some babies may do well with just CPAP, some babies may require a high flow nasal cannula, or some baby may require a NIPPV or SNIPPV. Pre-transport assessment for these babies is important. All vital signs has to be managed. Blood sugar has to be checked. ABG if needed. Manage, assess all the respiratory system, every system, make sure everything is fine. Make sure the baby is maintaining oxygenation well, just in case the NIV support is taken off only for 1 or 2 minutes. And if baby deteriorates significantly, that may be trouble for us during transport, because of the haphazard movement of the ambulance, sometimes the NIV may not work well. So you have to be very careful. As long as the NIV support is not very huge, and you have to intubate these babies. Stability of the patient during repositioning, suctioning, and examining has to be taken. If changing or starting NIV technique, once you put the NIV, wait for minimum of 30 minutes, assess whether the baby is stable, and then start your transportation. If needed, take a chest X-ray to assess the lung expansion. If needed, take a blood gas also. So currently available approaches to non-invasive respiratory support during transport is, one is oxygen hood, simplest way, oxygen delivered into a crib, nasal cannula less than 2 liters per minute. This can be used only for shorter duration because dry air, because we have heard about the humidification and also the dry air. So you have to be very careful. So if it's only short duration, you can use this nasal cannula, otherwise don't go for it. It has to be heated, humidified, high flow nasal cannula, which has to be used. Nasal CPAP, yes, very good. Nasal CPAP also can be used. Nasal intermittent positive pressure ventilation also can be used. And high frequency nasal ventilation. This is getting more popular, but still we don't have any studies saying during transport it can be done, but possibilities are there, because a lot of people in Europe have started using as a first line of treatment for nasal support in these babies. Then heated humidified high flow nasal cannula. So this is the most popular one, provided the baby is tolerating well during transport, because it's very easy. Unlike CPAP, where you have to be very careful. So if the baby is tolerating this HFNC, this is the best method, because easy to apply, decrease nasal injury, success in reducing need for invasive ventilation, comparable to nasal CPAP, ease of nursing care, and ease of transport. All these are beneficial. These two studies have definitely shown that a lot of babies can be transferred just with HFNC rather than CPAP, if possible. Nasal CPAP, probably the best method of transferring the babies. This CPAP was introduced way back by Gregory, and then it has been modified significant number of times, and now we know what is most ideal. In the last decade, there is a marked increase in use of this nasal CPAP, and this is one of the oldest and best studied available NIV mode. Several studies highlights the success of neonatal transport with nasal CPAP, and there are 2 largest reports from Australia which demonstrated that lot of babies can be transported just with CPAP rather than invasive ventilation. And these are the other studies. No, I think morning again, you had a lecture talking on Ram's cannula, so let me skip on this. Nasal intermittent positive pressure ventilation. This is also possible. There are lot of available data that NIPPV is much better than CPAP, but again, data for transport is limited, but there are few studies which was analyzed in Cochrane meta-analysis, which compared NIPPV and CPAP for respiratory support during post-extubation, and they found that NIPPV was far much better than nasal CPAP, and whether this same technique can be used for transport is, again, we need more studies for that. Common reasons for nasal CPAP failure is recurrent apnea, bradycardia, hypopnea, need for high pressures, and also severe respiratory acidosis. Probably NIPPV may avoid these problems. So this is one area where a lot of studies has to come in for us to use during transport. High frequency nasal ventilation. This is nothing but, again, just like a normal high frequency ventilation, you just give this ventilation through the nostril. So this is also helped in NICU. A lot of babies who have got very stiff lung, collapsed lung, or chronic lung with a lot of fibrosis. This high frequency really helps in expansion of these lungs. So this mode may be better in a lot of babies while transporting also, but we need studies for that. Unless we have enough studies, it will be difficult to introduce it as a routine thing. But we do use in our NICU where we have got very fibrous lung. This high frequency nasal ventilation does help in expansion of lungs. So we give pulse therapy regularly, and these lungs are opened up nicely when we give high frequency pulsation. So this is very useful in very severe lung disease and when the babies have got significant apnea. And advantage is it does not induce a glottal constriction. And a lot of European people have started using this high frequency nasal ventilation as a first line of treatment to give CPAP. Guidelines for HFNC CPAP, that is high frequency nasal canal support, is you look at the baby, whether the baby has got increased work of breathing. If it is mild, then you can start off with a CPAP of 5 to 8 centimeter with a frequency of around 6 to 8 hertz or 400 to 6 breaths per minute. If it is moderate, where the baby can be started on a CPAP of 8 to 10 centimeter with a frequency of 6 to 8 or 6 to 10 hertz. So management guidelines, again, depends on different oxygen requirement. So based on the increased oxygen requirement, you may have to increase your CPAP. And accordingly, you have to change the oxygen requirements also. So NIV, now I think we have got another lecture in the coming few lectures, and I think they'll be telling about NAVA more. This is one of the more advanced mode of support. It can be used for both invasive ventilation and also NIV ventilation. Here, support is controlled by the diaphragmatic signal called the eddy current. So that is, eddy signal is given. So here, if you look at, this is the eddy catheter which is placed inside, and there you have got a lot of probes. These are this thing they can pick up signals from the diaphragmatic movement and immediately send signals to the machine. And that machine gives a support whenever the baby is breathing. So this gives a lot of synchronity for the baby, and less pressure is needed for this baby, less sedation can be given because of the synchronization. And babies can be quickly weaned off when they are on support, and also it prevents the diaphragm from being disused atrophy. Checklist again before transport. This is also very important. So though we have done the checklist before there, as soon as we reach there, again checklist has to be checked before going back to the referring hospital. Make sure you have taken the history and notes before delivery, during delivery, and after delivery, what all has been done in the referring hospital. Condition of the baby on arrival of transport team. Both babies and mother investigation reports has to be checked. Mother's blood sample for cross-matching has to be taken. Treatment should be given at the referring hospital. Stability of the newborn has to be assessed again. Parent counseling should be done. All this has to be ticked before departing. Risk of transport has to be explained to the parents. Consent for continued treatment and transport has to be done. If not stable, stabilize the baby and then go for the transport. Check sugar and all vital signs. Check all lines, secure them adequately before you start off your transport back. If facilities in referral hospital is not suitable, shift the baby into the incubator first and then use your facilities to stabilize the baby, and take all necessary precautions while transferring to the incubator. Be careful with the lines. At least 2 peripheral lines during transport is a must. Don't depend on one. If needed, a central line can be inserted through the umbilical venous line. After shifting, again assess the baby inside the incubator, whether the baby is stable, and then transfer the baby. During transport, again, you have to be assessing continuously because babies can really get upset during the transport and they can deteriorate. All vital signs has to be monitored. Preductal and postductal saturation can be checked regularly. Non-invasive or invasive or non-invasive BP can be checked. Transcutaneous CO2 monitor, ideal, but I don't think still we are very popular in our country in doing this. Blood gas, glucose and electrolytes can be done on emergency situation during transport. Be aware that baby can deteriorate or can have complications during transport. Complete all important procedures before transport. And just another thing which you have to be aware while transport, especially if you are going on the hillside or if you are going in the helicopter, as the height is increased, the lung volume can increase. And the gas also will expand. So a pressure which you're giving for a baby for a certain volume, the same pressure can give increased volume to these babies, and that can induce problem and can induce an pneumothorax. So here, if you are at a height of about 5,000 feet high, then that can give almost 20% extra volume to the lung, and that could be dangerous for the baby. So further the height, the more the carefulness you have to be there. So this is one of the reasons when the babies are being transferred in helicopter, they run very low height. They just run around 300 to 600 feet and not more than that. And sometimes along the seaside, they run only about 200 to 300 feet high, so that this volume change itself can cause a lot of problems to the baby. Some dangerous complications which can happen during transport is significant number of babies do not tolerate transport. Checking all the vital signs, very important. If the baby has been intubated, that is not in NIV, it can get dislodged during transport. Pneumothorax is one of the potential complications and very difficult to manage during transport. Sudden drop in BP, make sure you give a bolus or inotrox if needed. Losing all IV lines may be really dangerous. That's one of the reasons why you should have 2 or 3 lines for these babies. And emergency medicine should be there always in the transport incubator. And sometimes dangerous driving and bumpy roads can really jeopardize the baby's transport. So this is just one of the study in Australia, which showed that CPAP is an alternative to ETT ventilation for retrieval, because here they did quite a lot of transport without significant problems. Here, binasal CPAP was used for acute respiratory distress in newborn of 32 weeks of gestation. It was a retrospective review. Almost 369 newborns was examined. CPAP were used increasingly in these babies, and most of them were successful. Only later, baby, after being transported, some of them required intubation, but during transport, they didn't have much of the problem. Summary, NIV ventilation is a mode of support for neonatal patients with various respiratory disorders. It is necessary for transport teams to be able to move patients on various modes of NIV support. It is important that both inclusion and exclusion criteria are developed to ensure safe and effective transport of these babies. Specific modes of NIV support for various pulmonary pathophysiology is very, very important during transport. The transport environment is not safe, so wherever possible, make it as an in utero transfer. Infants who do well in neonatal ICU can become sick during transport. Be aware of this problem. Thank you.
Thank you, Srinivas sir, for your clear presentation on transport, ventilation during transport. So any questions, anybody? Sir, can you throw some light on what should be the, like, let's say we have an oxygen cylinder. So certain PSI is mentioned in the dial. So for the sake of our delegates, can you tell us, like, how do we decide how many hours or how many hours does the oxygen cylinder last if you're using 1 to 2 liters, or if you're using CPAP during ventilator? Because the big challenge during using ventilation during transport is a gas flow. Most of the times when we go for long transport, that's a major concern. So
I think that's one of the reasons why I highlighted, because you have to check that sufficient gas is there in the cylinders. So ideally, most of the time you have about at least 5,000 liters in each cylinder. So that's one of the important things you have to be aware of that. And then as soon as you go into the ambulance, you have to connect, because ambulance will have their own centralized oxygen and air during the transport. So as soon as you go there, you should be connecting to the ambulance. And once you reach the referring center, there if they have a central oxygen and air, make use of that. And otherwise make use of the cylinders till you stabilize the baby. And then again, just before departing, connect back to your equipment, so that will be useful for us to save our oxygen and air for the transport. So roughly, if you have about 5,000 liters based on the usage of 6 liters per minute, you can calculate roughly that can come for 2 to 4 hours if you are not wasting. So sometimes we do tell, if it's a long transport, asking them to take additional cylinders, but most of the time we don't have problems because of this. Shifting is done very systematically, because we, as soon as it's into the ambulance, it is connected to the ambulance big cylinders where they have got enough oxygen and air. So that's what you have to be taking care while transporting. Otherwise, you'll end up in trouble.
Thank you, sir. I think we need to check the oxygen cylinders before we move on. So any other questions? Thank you, Srinivas, sir, for giving
the
a...
other thing you said, forgot to mention is, we have got current ventilation like Stefan ventilators, where air may not be needed, because that takes in air from the atmosphere and generates the air pressure. So it's mainly the oxygen which have to be worried if you have got that system. But if you don't have a special system, then you'll have to take both oxygen and air.
Thank you, sir. Thank you. I think there are no questions from the delegates. Thank you, Srinivas, sir, for joining and enlightening us about using ventilation during transport. Thank you, Srinivas, sir. So
Thank you very much.
To the next part of the workshop. So we'll now move on to the workstations. So we'll divide you into 2 groups. So one group will actually go to my left-hand side, that is the nice Neotech part. The right-hand side is the Fisher and Paykel part. So we'll learn about both bubble CPAP and HFNC. I think I would request 5 people to come on the left-hand side, other 5 people on the Fisher and Paykel side. So we'll start with the workstations. I think Srikanth and Dr. Manikumar will help you out. attention, everybody. So we have finished HFNC and bubble CPAP from both Fisher and Paykel Lab. Hello, Sharath, can you share your slides? Sharath, can you switch on your video?
I think it is on. Can you see me? Hello?
We can hear you.
Just
Yeah,
a
Sharath, you can take us through that. No problem. I think we'll be able to see you once the camera mode is off.
Can you see now?
Yeah, we can see your slides. You can start, Sharath.
Okay, fine.
You lost your full screen. Yeah, yeah.
A very good evening to all the delegates who are there. I think you have been going through a very good session since morning. Of course, it is a hectic session, and so many of our teachers have already told many things about non-invasive ventilation, including one of my teachers, Dr. Manikumar, when I was in ICH. So I think that is a lot of theory which you have to digest. I'll just be going through a very important, just like the post-exam main examination, you'll be going through the Viva OC types. So probably a chest X-ray session on neonatal X-rays, where you'll be probably the best person to decide because you are on the bedside. Fine. So most of the times what we have seen is once you are given a chest X-ray, as from the time of internship, you just hold the X-ray, you hold it in some fashion. You just have to see what is the right thing or not. Check the name and the IP number and all these things. And finally, what happens? Can you interpret it? No. Most of the times, what happens is you will finally see the radiologist report. So, fortunately or unfortunately, all the neonatal care physicians cannot depend on radiologists. Neither do have time. One. The second thing is you have to take decisions in real time. So you will not be able to wait for some time, ask for a radiologist opinion or whatever. So it is at least apt to know the basics of reading a neonatal chest X-ray. So our objectives during this particular short session will be to schematically read and describe a neonatal chest X-ray, list and identify typical radiological conditions of a very few radiological newborn respiratory diseases in the newborn, understand the variations and overlap in the radiological picture of these respiratory disorders which we come across, and of course identify complications of the disease as well as of the ventilation. So basically, what are the indications of a chest X-ray? So many things would have been told in the morning sessions in non-invasive ventilation. And in one important case scenario, I think which was discussed by Dr. Abhishek, also he told chest X-ray is actually not required for initiation of CPAP. So why is it required? It is only required for initial diagnosis. It is not for the management as such. What is the initial diagnosis? of the cause of respiratory distress. That is all that is required for. Of course, many times we have to check for the positions of the tubes and the lines. And in case of a rapid deterioration in the respiratory system or of the clinical condition of the baby, as a part of dope in any ventilated baby, we are going to do. That is all the indications of a chest X-ray. So actually what is done in most of the centers, of course, nowadays it is decreasing, but still many places do use it as a routine thing. In cases of a daily ventilated baby screen or pre and post extubation, every re-intubation does not require a chest X-ray. You just have to mark the position of the ET tube, at what level it is marked, and put it down across the table in a very bold letter, so that every re-intubation, if at all it requires, at least at that particular position, it can be fixed based on the previous X-ray. That's all. And every drop in SpO2 and an increase in the oxygen requirement also does not mandate a chest X-ray. So basically, we have to decide by thinking, how is the X-ray going to help in the management in that particular case? That is the bottom line. So we all know the saying, the eyes see only what the mind knows. So what are you wanting to see? If at all you are going to get a chest X-ray done, is very important before you order a chest X-ray. So basically, reading a chest X-ray is just like this particular picture. I think most of you will recognize what is this. This is just a radar image. Radar image, the only thing what you have to do, however the radar images scans, either you go from outside to in or from inside out. You just have to mark out and identify what is the problem. That is more important. So whatever scheme you use, you have to stick to it in your routine course. So what are the things that we generally see? This is the quality of the exposure, the rotation, the soft tissues and the bones, apart from the most important, as we see, lungs and cardia. We see that we generally forget to see the soft tissues and the bones and concentrate more on the lungs and the chest and the cardia alone. That is why I have put these points in the initial part, and then the lungs and the cardia, which will obviously be seen by all of us. So here I have just intentionally put a chest X-ray of a newborn baby. We see it as a normal chest X-ray. So what are the basic things to describe, not exactly the picture what has been put. So it is basically an anterior posterior film and a supine one, obviously. And we see that the chest is more cylindrical and translucent compared to a adult. Ribs are more horizontal as well. Thymus is often prominent, and the CT ratio, as we all know how to calculate, will be approximately 0.6 to 0.65. The diaphragm is usually up to the level of the sixth rib anteriorly or posteriorly up to the eighth rib. So, but see, this is a chest X-ray where most of the times, most of our teachers will tell, why has this chest X-ray been done? So many things have to be just rectified. We also see that there is no NG tube which is put in this particular chest X-ray. So what is the indication for taking this chest X-ray? We do not know. And so many things we have to just keep verifying. So now coming to the exposure part, just putting two X-rays, you can see how an over-penetrated and under-penetrated chest X-ray of a newborn appears. In this over-penetrated X-ray, you see that the lungs appear hyperlucent. Everything is so dark, even the lung markings are not properly seen. This is very important to note. And the posterior vertebral bodies are seen very prominently. Compare this with the under-penetrated one, where the vertebral bodies are not at all seen correctly, and there is diffuse haziness around the hard shadow, which does not actually make a good silhouette. So the next part is a rotation. See the orientation of the clavicles on either side. This is definitely a rotated one, and commenting on the cardiomegaly in such a particular X-ray is obviously going to cause errors. if we are going to use it. So now let us see what are the soft tissues over here. Soft tissues, you can just make out in this particular chest X-ray, we have a beautiful soft tissue which is seen here in the right hemithorax. This is obviously the thymus, which has a sail sign. Many times we do see it and recognize it, but most of the times it may not, it may go unnoticed if it is not of this particular shape. However, we have to see these. Look at this particular X-ray. There is obviously a rib deformity over here. There is absence of the rib and there is presence of hemivertebrae. I have put this X-ray basically to show this will be a good X-ray because it is exposing the whole of the chest, most of the abdomen, and a part of the limbs as well. Because the first X-ray, if you are exposing this much part, the subsequent ones you need not worry, because if there is any other problem, it is very unlikely to be detected at this particular point. Now, just coming to the parts of discussion. In hyperinflation, what is a hyperinflated chest X-ray? Generally, we tell a chest X-ray in newborns is hyperinflated if there is presence of more than 8 posterior intercostal spaces that is seen. Okay, and there is flattening of the diaphragm, which is more prominent, and hyperlucency of the lungs. Also, there can be herniation of the lungs under the heart. As we have already noted, the ribs are more horizontal. Compare it to a under aeration, where less than 6 intercostal space, less than 7 intercostal spaces of the posterior part are seen. Now, one more indication, as I had told us, use of lines and tubes to identify the tips. Though we are dealing with the non-invasive ventilation, just to cover it up, we are seeing that correct for the checking the correct position of the endotracheal tube, we are using chest X-ray most often in most of the settings. What is the correct position? Just about 2 centimeters above the carina, and NG tube or OG tube as such will be midway in the stomach shadow. Then there will be, what do you call, the umbilical lines. The UAC and UVC are also picked up in this particular X-ray exposure. Also, for the PICC line insertion and checking of the tip, these are the particular things which have to be checked. Important is UAC. It can either be high or low, and as shown in the description, it has to be at the level of T6 to T9, or for the low ones, it should be between L3 and L4. So that is the ideal position, and in between that will be a dangerous or hazardous position. So it's very important to know about that. And UVC as well will be just positioned at 0.5 to 1 centimeter just above the IVC. See this particular X-ray, I have just put it particularly because though this contains so many lines and tubes, the position of UAC and UVC is not appropriate. Compare it with this particular next film, where UAC and UVC are actually very good, in good position. But however, what is lacking in this particular X-ray is NG tube, and there is absence or very minimal gas shadow that is very prominently seen. The other X-ray which you see is for the PICC line insertion. It is almost at the appropriate position, which is also showing good exposure of the chest. Now we see that there are some artifacts that come across when we see the chest X-rays. Can anyone just identify what is this particular artifact which is there on the X-ray, which is on the right side? Hello, am I audible? If it is very difficult, let me just can give an impression which may just mimic something like a pneumothorax. However, you can see that this particular line is extending beyond the diaphragm. So it is very unlikely that it is going to be a pneumothorax. And upon confirmation of the position, we can actually come back and just check the baby as well. So that will give the particular picture. And this particular X-ray as well, there is some radiolucent shadow which is appearing. What is this? This is basically what we call as the ventilator, the incubator port, which is giving that particular access. Okay, I'll just come to the few diseases which are for which generally chest X-ray is done. Now, respiratory distress syndrome is the commonest one, as we all have come across. So, what is the particular which can this particular? There are 4 X-rays which have been put up. This is particularly because respiratory distress syndrome can present in with any of these findings. This can be in stage 1, where there is very fine granularity and very minimal air bronchograms which are seen over here, or it can be a coarse nodularity which is seen over here and definite air bronchograms which are seen here, or when there is increase, there can be the baby is requiring an intubation and as well as ground glass opacification. And in this particular scene, it is almost seen that there is opacification to the extent of whiteout lung, where there is cardiac silhouetting is also not exactly seen. So next is a case of transient tachypnea of newborn, which we all come across very commonly. It appears as small streaky perihilar sunburst sign with increased streaky shadows on either side of the cardia. There is also there is some amount of cardiomegaly which can be noted. Note the same baby which is having a decrease in the cardiomegaly and clearance of the lung fields after a couple of days of respiratory therapy. So I put this particular X-ray of a very common condition in India, meconium aspiration syndrome. Mostly meconium aspiration syndrome, it will be presenting with coarse, granular and heterogeneous opacities on either sides of the lung, mostly with a history of meconium aspiration syndrome. So, but what is this? Here at the space of the arrows, we see that there is presence of fluid in the interlobar fissure. Now, after immediately seeing this, don't come to the conclusion of this being a case of TTNB, because TTNB is a diagnosis of exclusion, as we all know. So most important thing is the other findings also have to be seen. Another important condition is pneumonia. Pneumonia can be presenting in any of these particular fashions. It can be a lobar consolidation in one of the areas, or it can be in the presence of pneumatoceles, which we see here. In case specifically in case of staphylococcal pneumonia, or it can be in the perihilar streaking areas, which can be seen in respiratory syncytial virus infections. Less commonly though, in more rarer situations, we do come across in more ventilated babies or babies with air leaks, minimal air leaks, a condition called as pulmonary interstitial emphysema. Here we see that there is translucencies which are present over the perihilar areas in the form of tubes or small kind of perivascular distribution, giving a honeycomb appearance. All this is typically seen in cases of pulmonary interstitial emphysema, which can be a complication of RDS, which can be a complication of RDS in a prolonged stage if it is uncontrolled, or in cases of PPH. Now, I think this is a spotter for anyone. It is very easy. Why I have put up this particular slide is, this is one of the complications of any particular type of ventilation. You see here that there is definite hyperlucency in both the places, and with a collapse of the lung, underlying lung field. And in this particular case, you see that this particular baby had received non-invasive ventilation alone after resuscitation and was put on CPAP with higher pressures. So you have to, a very important lesson is that these babies on CPAP have to be watched out for development of pneumothorax. Last but not the least, when we are dealing with a neonatal chest X-ray, how can we forget about bronchopulmonary dysplasia or chronic lung disease? This is the most varied of the presentations. It can occur in any type because this is how the lungs do heal. The radiological picture just depends on how the healing of the lungs takes place. In the initial stages, it may be just like a respiratory distress syndrome. Only later on does these changes change over to be a white out lung opacities or sometimes honeycombing, and if it is neglected or in the later stages, it gives cystic or emphytematus and bullous changes can be present. Just to complete the discussion on just the common diseases, I am just putting across a particular condition of congenital diaphragmatic hernia. However, we see that in this case, particularly, it is intubated. My reason for putting this condition in a non-invasive ventilation workshop is not to tell that I use non-invasive ventilation in a condition of congenital diaphragmatic hernia. It is basically after the surgery. So suppose what is a baby with congenital diaphragmatic hernia is operated soon after birth, after stabilization, then the baby is on ventilator post-operatively. Now the question is, once the baby is intubated and not extubated, can you put the baby back on non-invasive ventilation for this particular hernia, and how good is it in the perioperative period or post-operative period is one thing which we have to just check it out. And maybe this can be a topic of discussion in your units where they are doing surgeries for congenital diaphragmatic hernia. I'll just take you through to just 3 case scenarios just to brush up. Say suppose there is a 30-year-old mother who has come with leaking fever for about 12 hours at 30 weeks of gestation. She was started on antibiotics and dose of antenatal steroid was given. But in view of a decreased Liker, emergency LSCS was planned. A baby was born at around 1.3 kg birth weight. Baby cried after stimulation. Baby has spontaneous respiration which has developed, but baby develops respiratory distress syndrome. For this, baby was put on delivery room CPAP by TPs and shifted to NICU, and chest X-ray was ordered. See this particular chest X-ray. Now, what is the most common condition that you would expect in this particular baby? Obviously, I think it will be respiratory distress syndrome, but I have just given the scenario because there is a history of leaking per vagina also. So PPROM is an important antenatal risk factor in this particular case, and though one of the important things to be ruled out is congenital pneumonia, you still have to treat it basically for respiratory distress syndrome because this is basically non-steroid or just taken 1 dose of steroid. So just see, after steroid administration or after delivery room CPAP has been given for some time, there is an improvement in the lung hyperlucency. So basically, in this scenario, it is a case of respiratory distress syndrome which has improved over time with adequate intervention. So CPAP has made the baby improve in its own with not much requirement of a surfactant probably. In a second case scenario, let me just take you through a case of a 25-year-old mother with 39 weeks gestation with GDM. She was induced, but there was failure to progress, and there was meconium stained amniotic fluid. Emergency LSCS was done. A weak cry at birth and respiratory distress since birth. CPAP was initiated, but needed to have an increased ventilator support in form of NIPPV. So X-ray was ordered, and this is the X-ray. So again, because again I'm giving the same condition, same X-ray. So the most obvious thing here is interlobar fissures fluid. So this can be a case of TTN, but obviously keeping the history background with the history of meconium stained amniotic fluid and the X-ray picture showing opacities which are bilaterally non-homogeneous. MAS will be the picture. If you see the X-ray as well, this might have been taken a bit later. The baby is requiring UAC, UVC along with intubation. So basically, baby is a more sick baby, which is requiring this kind of a respiratory and vascular access support. So we have to be erring on the side of a more severe disease in the form of meconium aspiration syndrome and treating more aggressively rather than taking it as a case of TTN. Third and the last case scenario is a 28 weeker 1000-gram birth weight baby with PPROM history, RDS with which required 2 doses of surfactant replacement therapy. Initially mechanical ventilation probably for 3 to 4 days. Now was extubated to non-invasive ventilation of some form. Let us take probably CPAP. Now there is a deterioration with respect to the respiratory distress on which particular day. Let us take it as on day 4 of life. So this is a particular X-ray. So now there is a deterioration for a baby which was on mechanical ventilation and has been extubated. Now what are the things that we have to see in this particular case? Any rapid decrease or rapid de-escalation of the ventilatory support itself can cause a deterioration in the respiratory pathology. So the change from mechanical invasive ventilation to non-invasive ventilation itself may be inappropriate in this particular case. The second thing is the baby may have developed a complication of a disease or mechanical ventilation. So what could it be? Because it is a preterm baby which is post-surfactant, we have to keep in mind the presence of or the complications such as PDA opening up in a massive way. One. Second thing is it can also be a case of pulmonary hemorrhage. We do not know. I have not given the full background. Even I do not know the exact background of this particular picture, but still it can be any complication of the disease as such, like PDA or a pulmonary hemorrhage, or sometimes a developing pneumonia because there is history of PPROM as well. So any one of these things can be causing problems in this particular case. Now, what if it deteriorates on a 14-day or a 28-day? Obviously, our diagnosis will be different. So second 14-day probably we'll be thinking of some other cause. Say pneumonia is definitely a possibility. VAP can be a possibility if the mechanical ventilation is for a longer duration and subsequently there is a development of respiratory distress which is increasing. Suppose the same thing is appearing after on day 28 or so. Obviously, one of the initial things that we'll be suspecting is a development of a chronic lung disease that is evolving BPD. So these things have to be taken into consideration. So my point in telling or putting up this case scenario is do not go by the X-ray alone. It is the clinical background of the particular case that matters the most in taking clinical decisions. So it's very important that a clinico-radiological correlation is done in each and every case rather than just interpretation. You know, we are all only neonatologists. Yes, we are not radiologists, but we can definitely read some of the bedside case scenarios much better. However, let me tell you that newer modalities of imaging in newborns are already there in the market, and definitely this is going to be of much more use in the very near future. However, still most of the units world over are still dependent on chest X-ray. So knowing basics of neonatal chest X-ray is very important rather than thinking and asking for a radiologist every time or every sooner. So I think that is what I want to emphasize, and I would want to just thank all the listeners for their patient listening. Any questions are there? If at all, of course, I am not the authority in chest X-rays, but still, being a practicing neonatologist, I can just try to help you out in some case scenarios. Of course, there are a lot of neonatologists who are more more experienced. So definitely they'll be able to share more help. Thank you.
Thank you, Sharath, for taking us through X-ray. You have taken us through the X-ray very well than a radiologist. Thank you, Sharath. I don't think so. We have any questions.
Thank you.
Thank you, Sharath. So we are now left with the NIV workstation. I think we'll finish off NIV workstation and then move to the next this one. Screen sharing.